Hello. Start. A very good afternoon, everyone. On behalf of Sir Gangaram Hospital, Dr. Shyam Agarwal, sir, Dr. Rakesh Kaur and Dr. Arvind Kumar, I would like to welcome you all for this event, Clinical Updates in Management of Early Breast Cancer, powered by Update in Oncology X. So first of all, a very warm welcome to all, and I would like to invite Dr. Shyam Agarwal, Chairman and Director, Department of Oncology, Sir Gangaram Hospital, Dr. Rakesh Kaur, Senior Surgical Oncologist, Sir Gangaram Hospital, and Dr. Arvind Kumar. Sir, please.
Good afternoon, everyone. Thank you very much for coming in. After a hiatus of more than 2 years now, I think the old boys and girls are all supposed to get together. So I think this is the first occasion from the oncology department where Dr. Kaul and Dr. Arvind is supposed to join us. We do have Dr. Deepika and Dr. Bimlesh here. So we all welcome you to this important meeting, which is focusing on the management of early breast cancer. So we thought, let's focus on one subject, which is becoming more and more relevant because I believe more patients are going to be coming in, and breast cancer is the commonest malignancy in women in our country now, surpassing cervical cancer, as we all know. So I think there are several new developments and we need to interact and discuss regarding the surgical aspects, the diagnosing aspects. The molecular aspects are really coming in a very, very big way, besides, of course, chemo, radiation, and so on. And I was hearing from someone, artificial intelligence is also going to make in, waves now as we, understand more and more about the molecular biology and other aspects of all cancers, particularly breast cancer. So I think we look forward to an interesting 2 days of deliberations on management of early breast cancer. And I hope everybody enjoys and goes back to implement those discussions in their day-to-day discussion. So Dr. Kaul, please.
मैं अपने ऑर्गेनाइजर्स की तरफ से तहे दिल से आप सब डेलीगेट्स और फैकल्टी का खैर मकदम करता हूँ और इस्तकबाल करता हूँ. This has been a like of 2 years and I think we are coming out of the black clouds of the COVID, and let us start it again and beginning. It should be a good beginning and encouraging beginning, and I think this should be we should ensure that it should be a success and one of the rare physical conferences, not a hybrid, not a virtual one, and let us hope for the best. Thank you very much.
Thank you, sir. Thank you, Dr. Shyam and Dr. Kaul. So for the first session, I would like to invite the chairpersons, Dr. Seema Sood, Consultant Radiologist, Sir Gangaram Hospital, and Dr. Shelly Sharma, Consultant Radiologist, Sir Gangaram Hospital, on the stage, please.
A very good afternoon to all of you. It gives me great pleasure to invite our first speaker, Dr. Madhvi Mohan Chandra. Madhvi is one of the leading breast radiologists in the country today. And she's from AFMC, maybe just for a short 6 months, followed by MAMC. And presently she's heading the Department of Breast Imaging in Gangaram Hospital. She's got numerous awards and chapters in books. In fact, just recently last year, she was awarded for the teaching program in the Indian College of Radiology. I welcome Dr. Madhvi Mohan.
Thank you. So, thank you very much for inviting me to speak here. And this, as Dr. Shyam Agarwal and Dr. Kaul brought out, it's great to actually be here in the physical space. And we are discussing early breast cancer. And you know that the detection of early breast cancer is impossible without the radiologist's involvement. That said, breast cancer is a field where the radiologist, the pathologist, the oncologist, and the oncosurgeon all work closely together in not only diagnosis, but also management. Screening mammography has changed the game altogether. It's imaging asymptomatic women, women who show no signs or symptoms of breast cancer at all, but you still image them and you image them at regular intervals. And this has led to significant reduction in breast cancer mortality, as has been brought out by multiple studies in more developed countries. Over the last 35 years, we have seen a 30% dip in breast cancer mortality, some of which is definitely due to treatment, but a lot of which is due to early diagnosis. So when we diagnose these early lesions, they are impalpable because they're either tumor in situ or stage 1 cancers, that is up to 2 centimeters. So quite often, especially if deep in the breast, they cannot be felt. So now what are we going to do with these cancers once they are diagnosed? The surgeon obviously needs to take these out, but if you can't feel them, you cannot be approximating, and you have to go in and localize them. So the radiologist comes into play here, and this enables the surgical excision of non-palpable breast lesions. For example, if you see this lesion right here, it's a, can you see the arrow? No. Okay. So you can see that lesion right there. It's a very tiny lesion, and the surgeon needs to go in and locate that. So now what we are going to do, the radiologist is going to figure out how to reach this lesion, and is going to put in a wire like this or a non-wire localizer. And then the surgeon will follow this or follow the non-wire localizer and go in and get that mass or calcification, whatever the lesion is. So this removes the targeted tissue with adequate surgical margins while avoiding unnecessary and excessive surgery, because cosmesis is something that's very important to any woman with breast cancer. Whatever the age, they don't want a deformity, they don't want a missing breast, if possible. Also, in women with a large tumor burden, prior to the onset of neoadjuvant chemotherapy, it's important always to clip lesions. This is a better than 5 centimeter mass. And in this, before you start neoadjuvant chemo, it is important to biopsy and then to put in a clip at the point of biopsy, also in the metastatic axillary nodes. So you see this clip here and this clip there. This is for later localization. Now, the traditional localization methods are wires. Now, wires of 2 types, typically fish hook, so named because it's, it is like the kind of hook on which we impale a fish, and we can actually think of the lesion like a fish. And the other is J wire, which has a tip like a J, and you put it into the lesion. So these are the 2 kinds of wires that we usually use. Now, what is the procedure? First of all, the radiologist is going to identify the easiest access to the lesion. So in this case, the easiest and shortest access would be from this side, because from the top, it would be a very long depth and a long surgical dissection. Everything is aimed at a shorter dissection and a smaller volume of tissue coming out. So we are going to localize and put in the wire from this side. This, of course, may not match the surgeon's desired incision line. So we are going to come to that later. So when we want to put it in from this, the side, we are actually going to compress in the opposite direction, put in the wire there, and then adjust under vision. We have also worked out a kind of a tweak in Gangaram, where we do freehand tomolocalizations. This is a process that has been perfected by us and now presented in multiple conferences. And in this, you don't have to change the position of the patient. So in a single compression, we do the localization, and we have found across multiple patients that there's a better than 93% accuracy. So you can see there, it's a very small architectural distortion seen only on tomosynthesis, and we've got the wire straight through it. We can also put the wire under MRI guidance. You have MR compatible wires, and also under ultrasound guidance. In the lesion that I have been showing, it was visible on ultrasound, 7 mm only. This wire was put in under ultrasound guidance, and right there in the center, you can see it. This is very easy for the patient because she's lying down. You don't give her any additional radiation except for the check films. Even when you're doing a localization under ultrasound guidance, it is imperative that you go in and take check X-rays to confirm proper placement of the wire. After that comes the discussion with the surgeon. So this, we are always in touch with the surgeon on phone, on WhatsApp. We are sharing images, even though we hand images to the patient. Frequently, even before the patient has reached the OT, the images have reached the surgeon. We are going to discuss how deep from the skin it is, where the thick part of the wire is in relation to the lesion, exactly how much the diameter of the section has to be, and if the lesion in a hook wire localization, the most important thing is that unlike a biopsy, it doesn't have to be absolutely accurate. It has to be within a surgically dissectable margin. So even if you're 5 mm off, it doesn't matter because it's a 3D dissection. You're going to take out 2 to 3 centimeters of tissue. So 5 millimeters off doesn't matter as long as the radiologist can tell you exactly where the lesion is and where the wire is. So this is the tomo thing. Again, we say the distance from the skin, etc. We can mark the tip of the needle on the skin to prevent unnecessary dissection. And also we give us a diagram, a paper drawn diagram with the name of the patient and a similar distance from the skin, where the tip is, where the thick part is, where the lesion is, to make it very easy for the surgeon to go in and dissect. This is a sample of the kind of diagram we send out. So now after the wire is in and the surgeon has dissected, remember the process is not complete without the pathological specimen coming back to X-ray first and being imaged. We have to have a specimen radiograph for the procedure to be complete. Without that, your hook wire localization or your non-wire localization process is not complete. It has to come to radiology even before going to pathology. So this is how we take a specimen image, and you can see that the lesion is out. Now, in case we can't see it on 2D, sometimes we take a tomo of the lesion, and this is a tomosynthesis image of the specimen. So we can see the lesion very clearly. But in this one, you can see that it's close to the margin. So in this, we would advise revision of the margin. So now how are we going to advise revision? So always the surgeon tells us where the sutures are. It's a single thread, double thread, which margin. You can see I've put this low exposed image here so that you can see the 2 sutures there. So we can say that this margin needs revision and the surgeon will go in and revise that margin. So before the pathologist is going to comment on the margin, we will comment on the visual aspect of the margin and indicate to the surgeon before closing that this margin needs revision. Then after the procedure, of course, it's over to the breast surgeon, and they're going to deal with the patient and issue final results and recommendations. Now, there can be some complications with wire localization. There can be usual interventional and surgical complications like pain at the wire site, hematoma development. There can be vasovagal syncope, which we do have once in a while, more because of anxiety and the patient is fasting, etc. The correct area may not be excised in a small percentage of patients. Ideal wire entry site, as I mentioned, is determined by the radiologist. The surgeon may want to go in at a totally different site. So this is something that is a problem with wire localizations. Wires can migrate within the breast, as we'll see. There can be a retention of foreign body. There can be a pneumothorax. And wire migration can even happen to extramammary sites. So I'm showing you a couple of complications. These are the exception and not the rule. They shouldn't put you off localizations. So in 2003, we had this 44-year-old female who came to us for a screening mammogram, and we discovered this architectural distortion with an ultrasound correlate. As you can see, there's architectural distortion there, better seen on the mag view and on ultrasound there. So we put in a wire. There's the wire being inserted and send the patient to OT. But then we waited for the specimen radiograph and no specimen radiograph came to us. We waited, we called the OT repeatedly. Finally, we were told surgery is over long back, the patient's gone, the specimen is in pathology. This was 6 p.m. We tried to get the specimen for pathology, finally disgruntled, we packed up and went home. In 2007, the patient came back to us for a screening mammogram at 48 years of age. And what do we find but the hook of the wire still in place? Sadly, the wire had been transected outside. We hadn't seen the specimen. The wire was still in place. And then this was again localized and operated. So foreign body retention can be a complication. Another complication which happens in fatty breasts is that the wire can move. So here's a patient in which we had these calcifications, tiny calcifications. She had an invasive lobular carcinoma on the other side. So we were very suspicious of these. Biopsy was non-conclusive, so we decided to excise. And as you can see, the wire was totally in place when we did the localization. This is the deployed wire. But by the time she went to OT and the specimen came back, fortunately, the calcs were out, but the wire had moved 5 centimeters. So this can happen even with good fixation of the wire on the skin. Then another problem that happens in fatty breasts. Here's a patient who had these coarse calcifications, and on biopsy, this was ADH. So we were worried about concomitant DCIS, ductal carcinoma in situ. So we needed to localize this. And there was an ultrasound correlate, which was biopsied and found to be the ADH. So we decided to go in on ultrasound and localize this. And there's the wire going into the lesion. You can see very clearly it's there. But lo and behold, when we take the check X-ray, here is the calcification and there is the wire, 9 centimeters. That's not a dissectable margin. So we put in a second wire, leaving the first where it is because we were scared of withdrawing it and breaking it. So here we put in the second one, exactly where the calcs are. And by the time we take the fixation image, it's moved 4 centimeters further into the breast. Big problem in fatty breasts where there's no tissue to hold on to this. So these are some of the complications. We finally had to do a skin marking. And then there can be migration to extramammary sites, like here where it's gone into the chest. Then here it's actually reached the IVC. Then it can go into the neck muscles, the back. It's been known to go into the lungs. It's been known to reach the pericardium, but fortunately, these are all case reports. Now, the problem with wire localization, I'm going to take a couple of minutes extra, I'm sorry, that you have delayed surgery start times because it can be a difficult localization, as in the last case I showed, unexpected delays in the radiology department. When you have an early wire, the machine will invariably not boot in time. Unexpected, transport issues, the ward boy doesn't show up or something, and multiple patients all lined up for hook wires. So non-wire localization techniques have been developed, but they are not in significant use in India, mostly because our patients don't have significant insurance for these procedures. And this is a very expensive, capital intensive thing, most of them. Intraoperative ultrasound needs a lot of radiologist time, so not used very much. Skin marking is something that's not very accurate, although we do use it sometimes. Then we have injection of, radionuclide, which is radio-guided occult lesion localization. We just inject some technetium, but this has been abandoned world over because of inaccuracy. Then we have I-125 radioactive seeds. These are 5 millimeter seeds that are inserted into the axillary nodes and the lesions, very great for axilla especially. And you take out a much smaller area. Plus the surgeon has the happiness of being able to decide their own incisions instead of us deciding that they will go in from here. Similarly, you have MagSeed, which is a small steel clip. All of these are 5 millimeter to 1 centimeter. This is done, there's a fluctuating magnetic field and a introducer needle and a console that reads off. And Then you have Savvy Scout, which is a radar thing with 2 antennas sticking out. And then we have an RFID tag. So in those, each RFID tag has a unique ID number, which makes it very nice and easy to localize. But again, there's a huge capital cost when you start. So basically, between wire localization and non-wire localization, non-wire is better for the surgeon. In fact, if you have a big onco setup coming, you should invest in one of these. But wire localization is something that is economically more feasible for India. So, and the big thing about non-wire localization is you can put these things in for up to 5 days to 7 days before the lesion needs to be operated. So we don't have the surgeons waiting for us on the morning of, surgery. So these are the main differences between wire and non-wire localization. And these are the ways that early cancer can be localized. Thank you.
It's working? Okay, I congratulate Dr. Madhvi for a very nice talk where she brought out non-wire and wired localization techniques for breast cancer. And we as radiologists and you as surgeons, I think we are in a very good space where we both can work together, detect early breast cancers, localize those and take those out right in time. So house is open for questions if anyone wants to ask any questions.
Madhvi, I think you scared all the surgeons away, showing all those complications.
Yeah, we don't really want to be doing thoracotomies after putting in wires, but there's a total of 7 case reports, so we can be happy over thousands of wires being put in.
And these are not our cases.
Well, one of them is our case, which we haven't published, so that's the reason.
Thank you very much.
Thank you.
Thank you, chairpersons, and thank you, Dr. Madhvi, for the wonderful lecture. Next, for the next session, I would like to invite Dr. Ramesh Sadin, Senior Consultant and Surgical Oncologist, Indraprastha Apollo Hospital. Dr. Dinesh Khatiyar, Consultant Surgical Oncologist, Venkateshwara Hospital, New Delhi. And Dr. Sharan Chaudhary, Surgical Oncologist, Max Smart Super Specialty Hospital, Saket.
Dr. Agarwal and the team for inviting me over here for chair this session and for having a physical meeting after more than 2 years. And it's nice to see everybody's face and smiling face. So I think the topic is very well placed right in the morning because neoadjuvant chemotherapy has come to stay, especially for triple negative and for HER2 positive disease. I mean, most of us are now giving neoadjuvant chemotherapy. The size may vary and the lymph nodal status may vary. So he's got 2 lectures whether neoadjuvant chemotherapy changes the treatment for the primary tumor and treatment for the lymph nodal disease. And I think there are changes, and I think this so-called neoadjuvant chemotherapy National Surgical Adjuvant Breast Trial B04 about 25 years ago said that it reduces the size, and the only advantage is that you can do a breast conservation surgery if there is no difference in the overall survival. So today we have none other than my friend and an excellent clinician and a surgeon, Dr. Geeta K, to come and talk to us about breast conservative surgery versus mastectomy in patients who have neoadjuvant chemotherapy, and whether they have responded or not responded, what would be her take on it? Thank you.
Thank you very much for your kind words, ma'am. And I thank the organizers for having me here to speak on this topic, which I think I will keep it relevant to us because as surgeons, we need to know when to start and when to stop and how to do things when it comes to a neoadjuvant chemotherapy. But because I can assure you that neoadjuvant chemotherapy does not make the life of a surgeon any simpler because you don't know what you're trying to take out and you're shooting in the dark. So it is time for us to think beyond mastectomy, that is for sure. That's not the only option that is there. And as we see the evolution of the various treatments, various surgical treatments, we do see that there has been, we've covered a long way, and we've come from a point where extended radicals and radical mastectomy to modified radical mastectomy and now to breast conservation surgery and possibly in the future, no surgery at all. So while MRM may be the norm still in our country, I would say about 70 to 80% of our patients still undergo an MRM. How often do we think BCS, even if it is early stage breast cancer, let alone what happens after neoadjuvant? The simple answer to that is mostly not. So then when you look at these patients, who wants to be this? The lady on my left, when you can have something like this, is also a question that needs to be answered. But then we must be aware of the stumbling blocks which prevent us from offering a breast conservation surgery to more suitable women. So in India, about 60 to 70% of patients even today present with locally advanced or metastatic breast cancer. And the tumor and breast size ratio often preclude breast conservative surgery in such situations. And many lose out on breast conservations primarily because there is no radiation facility. And overall, the BCS rates in our country hovers around 5 to 20%. So in my center, we do about 30% breast conservation surgeries. In Tata Memorial Hospital, over the last 10 years, it has gone up to a 60 to 70%, which is quite heartening. So then the question is it possible? And I must support this claim with evidence. So I'll just take you back to early breast cancer when this discourse started. The only reason as to why neoadjuvant chemotherapy was being offered then was just to downsize the tumor who were initially ineligible for BCT and to convert them to candidates of breast conservation surgery. There was no other reason. And even to date, there is no evidence to show that neoadjuvant chemotherapy makes disease-free survival and overall survival better. So these were the prospective randomized controlled trials which compared breast conservation to mastectomy in early stage breast cancer. You can see a list of these trials. I'm sure we're all aware of this. And it was the NACBP 06 in 1970s by Fisher and co-workers who randomized 1,800 plus patients to various methods, including lumpectomy and radiation. And they found that the cumulative survival at 20 years and cumulative incidence of death was not different in either of these groups. So then at 20 years of follow-up, they also found that the IBTR, or the ipsilateral breast tumor recurrence, was 39.2% in those who underwent lumpectomy. Add radiation to it, it fell to 14.3%. But there was no significant difference in terms of DFS and overall survival. So when you look at the Milan studies, that was Veronesi et al. Who did these trials starting in the 70s and going up to the late 80s, and conclusively showed that a breast conservative treatment was equivalent in all manner compared to a mastectomy. So now we've come one full circle. I'm just mentioning this. According to the Mayo Clinic in 2008, the mastectomy rates were close to 45% in 1997 in the United States of America, dropped to 30% in 2003. This is the mastectomy rate. And it shot up to 43% in 2006, and actually they're close to a 50% now. So this is an interesting study which came off the brightness trial. So Gulshan and colleagues looked at this brightness trial, which was for triple negative stage 2 and stage 3 cancers. And there were patients who were randomized to receive neoadjuvant chemotherapy. Of this, before treatment, about 76% were considered eligible for breast conservation, about 24% were ineligible. After treatment, the 75 of the ineligible became eligible for breast conservation, that is 53%. Many women who were eligible for a lumpectomy, including 26% of those who tested negative for a genetic mutation, opted for a mastectomy. So that is why I said we have come a full circle, and possibly Angelina Jolie's choice was dictating the choices of many. And we see a lot of women opting for a bilateral mastectomy, even without proof of genetic mutations. So now let me come to the topic of the day, and that is the breast conservation in locally advanced breast cancer. So this is where it started, the NACBPB 18, which compared pre-op versus post-op chemotherapy in stage 3. There was an increase in the breast conservation rates by about 8%. Local recurrence rates were pretty much similar, and conversion to breast conservative surgery was highest in those with larger tumors. So this is the Indian experience from the Tata Memorial Hospital by Dr. Vani Parmar et al. And they also showed that breast conservation therapy is technically feasible and safe. So for us, that is very, very important to know that it is safe in, of course, select group of patients with no detriment in outcome. And this is a PRISMA compliant systemic review and meta-analysis, which included about 16 trials, and they concluded that breast conservation was safe. And this is after neoadjuvant chemotherapy. If you look at the local and regional recurrence, no difference in breast conservation compared to mastectomy. Distant recurrence, disease-free survival, overall survival was better, in fact, in the breast conservation arm. So we have more such studies which concur with the same thought, and that is that breast conservation is not lesser than mastectomy in terms of disease-free survival or overall survival. So I'm just giving a sneak into a 2-year data that we have all put together. These are 6 institutions, large cancer facilities in the country. Just look at the last line. Only 26% of patients with LABC had BCS, and the rest had MRM. So now I will come to the technicalities of how breast conservation comes into play in a patient who's had a neoadjuvant chemotherapy. So the important thing to do is to select the patient right. We have to be very, very certain about the margins, and we have to start thinking about de-escalating treatment, especially in the axilla after neoadjuvant chemotherapy. And because we have the benefit of using oncoplasty, you can actually take the stress out of margins and cosmesis. So when do you say that a patient is not a candidate for breast conservation after neoadjuvant chemotherapy? If the residual tumor continues to be in excess of 5 centimeters despite neoadjuvant chemotherapy, there is a large area of skin edema still, there are diffuse microcalcifications, multicentric disease, meaning 2 different quadrants, possibly not. If it is close by, even if it is a different quadrant, you can consider breast conservation surgery. And if there is medical contraindication to the use of radiation, you should not consider breast conservation. To ensure clear margins, you must prepare well. So what is an adequate margin? So there has been a lot of discussion, and we thought this discussion will continue till the cows came home. But finally, in 2014, based on a meta-analysis, no ink on tumor for invasive and 2 millimeters for DCIS was pronounced as adequate margins. So we have to work towards this adequate margin, especially in the post-neoadjuvant setting, and you have to prepare for it even before the neoadjuvant chemotherapy starts. So as far as imaging is concerned, I think MRI is a good tool to assess the quantum of disease and also to assess response post-neoadjuvant. So one must do a core biopsy of the primary, core or FNAC of the axillary node. With clip placement is something that you may consider, because I think we are moving towards that. Preoperative pictures of the patient with the tumor marked out and documented on your notes as well. It's a good reference point for you when the patient comes back to you after neoadjuvant chemotherapy, and it is of great help to your radiation oncology colleague also. So like I said, MRI will look for the size, extent of lesions, is there a bilateral synchronous lesion, and in follow-up for response evaluation and for surgical planning. So in a pre-chemotherapy patient, that's the lesion, and you have placed a clip within it. So the accuracy of the residual lesion on MRI is more, of course, with various subtypes, which is HER2, triple negative, those with mass lesion, and those with a higher Ki67. Clip placement, very simple to do, just as Dr. Madhvi has shown, that you need to place that clip within the tumor guided by ultrasound, and sometimes, and then the stability of the clip position should be established, and then subsequent to that, this clip is what is going to guide you towards excision. So if it disappears completely, you're not able to see it on an ultrasound, then a stereotactic wire localization is the way to go. So this is how it should be when you operate in the theater. You must orient the specimen. There is no getting away from orienting the specimen. And one thing extra that I do possibly becomes easier for the radiologist to determine which margins is to mark the margins with clips. So the radio opaque clips stand for a reason. So what we do is say if it is a one clip at the superior, 2 clip at the medial, or 3 clips, 2 clips on the lateral, and 3 on the inferior, whichever way you want to. So that gives you an idea as to which margin may be close when it goes to the pathologist as well. And of course, you must put clips at the base after you have removed the lump. Then start thinking about de-escalating axillary management after neoadjuvant chemotherapy. I think somebody is going to speak more about it, but it has been ascertained from the NSABP B27, possibly that 50% of axillary lymph nodal dissections are unnecessary, and more so in patients who receive HER2-targeted treatment. So we have various clinical trials in this setting, which is the ACOSOG 1071, in which dual agent mapping and recovery of more than 2 nodes was associated with lower false negative rates. The Sentina trial, again, false negative rate was about 14.2% of after the neoadjuvant chemotherapy. For those who had 1 node removed, it was 24.3, came down to 18.5 when 2 sentinel nodes were removed. So then we come to the targeted axillary dissection, which is possibly going to be the way in the future, because with targeted axillary dissection, which essentially means sentinel node biopsy and the clip node, when you remove that, then the false negative rate really comes down to 2%. So the clip node, there is a problem with the clip node, that the identification can be a problem in about 23% of cases in this study. Clipping reduced the false negative rate. The sample size is small, but routine use of TAT may reliably identify those patients who have possibly had all their nodal disease eradicated by neoadjuvant chemotherapy. So there is an ongoing Aksana trial which will answer which method is superior for addressing the axilla after neoadjuvant chemotherapy. Just quickly on oncoplastic breast surgery, which is essentially to help us, possibly take larger margins, because if you have oncoplastic techniques in your armamentarium, you can possibly take out more and fill it up with more. And oncoplastic techniques are suitable and safe for patients undergoing breast conservative surgery. So this is what you can achieve with oncoplastic breast surgery. This is a post-neoadjuvant patient, round block on the right, round block on the left. And this is anterior intercostal artery perforator flap. This lady had 2 lesions, both have disappeared and both have been wired. They're close to each other, and this is a patient in whom you can do a breast conservation surgery with oncoplasty. So that is what you're seeing, and this is exactly what Dr. Madhvi was saying, that you should bring out the wires, do a specimen mammogram, and that's the flap that has been raised and placed in a horseshoe-shaped manner within the cavity. And these are the immediate post-op images, and these are the follow-up images, and you can see that there is barely any scar to see. This is another patient who had a largish lump, 2 lumps in fact, one at 11 to 12 and another at 8 o'clock, which was indeterminate, that needed to be included because this had not been biopsied, but she was very, very keen on conservation. My original plan was to do an ICAP for her, but as we went along, we realized that the defect was bigger at the 12 o'clock position, and this ICAP would not suffice. So if you have the benefit of oncoplasty in your armamentarium, I changed my plan and decided to go for lateral thoracic artery flap. And that is what we did along the lateral mammary crease. That's the flap inset into the cavity. And this is how she looks in the immediate post-operative period. There is hardly any scar to be seen. And this is one of my own innovative perforator flaps. This is still in publication and it should come through. So this was a patient, again, very reluctant to get a mastectomy done. She had 2 lesions kind of far apart, and that is where we use this flap, and that is her result 2 weeks post-op. So extreme oncoplasty is another terminology that we use in those patients who you would otherwise say mastectomy, tumors larger than 5 centimeter, multicentric, and localized skin involvement. So you can actually offer breast conservation in that situation also, but you must be prepared with what you're going to fill that patient. So that is where you would do an LD flap, and that's how she would look. So that's my take-home message. There is no substitute to a good mastectomy in cases which do not qualify for BCS. I don't want anybody going back from here thinking that mastectomy has to be relegated to the background. That's not the case. In cases which are suitable and they do not compromise oncological outcomes, breast conservation should be offered. Clip the primary and regularly assess the primary. That the onus is on the surgeon. Perform sentinel node biopsy after NACT only after you have validated at your institution. TAD is promising, but more evidence is required before routine use. Breast conservation with oncoplasty is safe even after neoadjuvant chemotherapy. Extreme oncoplasty to be used with extreme caution. And keep communicating with your colleagues like Dr. Madhvi Chandra and the other pathologists who are there in this audience are a very, very valuable asset. You should keep talking to them. Thank you very much.
Thank you, Geeta, for an excellent talk detailing how to conserve the breast and also de-escalate surgery in the axilla even after in locally advanced breast cancer cases after neoadjuvant therapy. If there are any questions or comments from the house, I invite them now.
Yes, please go ahead.
Please use the mic.
HER2 positive and the triple negative, even the, the tumors that may be node negative, would you consider doing a sentinel lymph node biopsy before their neoadjuvant chemotherapy?
So you mean that the patient was node negative to start off with?
Yes, but say had a 3 centimeter
Yes.
tumor and it's HER2 positive. So she's a candidate for neoadjuvant.
So very good question. That's exactly, this is the only subset in which I would do a sentinel node biopsy. Patient is proven node negative. We try and do an FNAC in such patients. I mean, sometimes you have very small nodes and your radiologist may say it looks pretty all right, we can't do it, that's fine. But otherwise, if the FNAC says it is negative, that is the only subset in which I would do a sentinel node biopsy post neoadjuvant chemotherapy. You're absolutely right, because we are in a quandary with the HER2 positive small tumors and the triple negative smaller tumors where we are doing neoadjuvant. There, I would certainly do a sentinel node biopsy after neoadjuvant.
Thank you so much, Geeta. Just want to make one small, suggestion that you, for a breast conservative surgery after neoadjuvant chemotherapy, you got to be more careful than you are in a non-neoadjuvant chemotherapy, because especially for hormone receptor positive tumor, they do not respond by a centrifugal. They respond patchy, and the tumor size more or less remains the same. So if it wasn't satisfactory for BCS pre, it's also
unlikely. Yeah.
So I would be very careful for a hormone receptor positive.
So that's why the MRI, ma'am, because the MRI will tell you whether it is a Swiss cheese pattern of response or is it a centrifugal response.
Most often the hormone receptor don't respond this way. The triple negative and the hormone receptor positive. And the other thing that I actually want to ask you is that if you have an excellent ultrasonologist, you don't really need an MRI if you have a good, and especially if the response is like PCR, radiologically, So a triple negative 3 cm lesion, you can see under ultrasound disappear, So I don't know if you really need an
So
MRI.
I would say again, coming back to what you said, triple negatives and HER2 positives possibly. But if it is an ER/PR positive, I can't tell you the number of times you'll burn our hands, because I would always say that compare like to like. If you've done an MRI in the past, before beginning it, then you must compare it with an MRI.
And regarding the MRI, I think if it is not done well, especially with an injector and a breast coil, it's no good.
It's no good.
I throw them into the dustbin if it is done in a ABC center which haven't done it right, because you just don't get the information that you need. The third thing that I want to make a point is that breast conservative surgery is as good or maybe better than a mastectomy with regard to the Scandinavian study of 20 years follow-up of 20,000 patients in each arm. In fact, they showed the BCS
The survival
was
is
doing
better.
better, 1.4 versus 1. So I think if it's a suitable patient, breast conservation.
Should be offered. Should be offered. Thank you.
Thank you, Geeta.
Thank you. Thank you.
If there are no further questions, we move on to the next speaker. Now it's my pleasant duty to invite Dr. Umang Mittal, who is the Director and Chief Surgical Oncologist at the Merit Cancer Hospital and the Senior Consultant, Department of Surgical Oncology at Fortis Hospital, Noida. Dr. Umang will be speaking on management of hereditary breast cancer and risk reduction.
Good afternoon, everyone. At the outset, let me thank Dr. Shyam for inviting me to the first meeting and everyone on the dais. And also thanks to everyone who is here after such a sumptuous lunch and still looking at the academic meetings that we're having. So let me start talking about the hereditary breast cancer, which is something which everyone talks about today, and it's really coming up in the big way in India too. And I'll be basically limiting myself to the role of risk reduction surgery. I will not be talking about a lot of the medical parts and other things on this. So let me first pay homage to the father of cancer genetics, Henry Lynch, who was the first person who described these cancer genetic syndromes in the 60s and 70s. And as Geeta said, hereditary cancer would be incomplete if you don't mention and thank the beautiful lady who has actually made it more famous than actually doctors would want it to be. And people come out asking for mastectomies after this. But yes, it has really put hereditary breast cancer on the map of people's mind. So when you talk about hereditary breast cancer, we're talking about hereditary cancer syndromes, most of the cases. And these occur when an individual is inheriting the genetic mutations by virtue of the germline mutations. So what's the difference? A germline mutation would be one where the mutations are passed from parents to offspring. Which are somatic mutations, which are acquired by any cell in the body after birth. See, all cancers, sporadic cancers, are actually having somatic mutations, but they're not passed, and therefore they will not be concern for us when we talk about hereditary breast cancer. The gene discovery started in 79 when P53 was discovered. And we had the BRCAs discovered from 90 to 95. Apart from that, the other strong penetrant genes like ATM, PAL-B2, CHEK2 were also discovered. So most of the genes which are associated with hereditary breast cancers were discovered in 2005. After the genomic project, so many more have been discovered, but BRCA1 and BRCA2 still are the most important. So when we talk about hereditary breast cancer genes, the division is into high penetrance genes, which would mean that they have a 5 to 20-fold chance of a patient developing cancer. Vis-a-vis moderate to low penetrance genes, which have 1.5 to a 5-fold chance of getting cancer. And this is the same chance that a lobular carcinoma or atypical hyperplasia would have. So what to do with that is still, we do not know. For the high penetrance genes, definitely some sort of thing has to be done. So the high penetrance genes are the BRCA1, the BRCA2, the PALB2, TP53, PTEN, and STK. These have almost a 50 to 85% chance of the patient getting cancer in the future. And then we have the plethora of low penetrance genes, and I will not go into detail of that. Suffice to say, we today need to understand which patient would require these genetic risk evaluation. And I talk about a person who comes with cancer. So any person with cancer with a known mutation in the family, diagnosed breast cancer less than 50 years of age, triple negative at or before less than 60 years of age, 2 breast cancer primaries, breast cancer at any age but with one close relative, 2 or more blood relatives, personal history of pancreatic cancer at any age, any individual with acne Jewish, which I don't think it's important for us, any male breast cancer in the family, or any individual, the personal family history of 3 or more of the following, diagnosed before the age of 50 years, the breast cancer, pancreatic cancer, prostate cancer, melanoma, sarcoma, adrenocortical carcinoma, brain tumors, leukemia, and the hereditary gastric cancer, colon cancer, endometrial cancer, thyroid cancer, kidney cancer. So any of them, 3 of them have been in the family. These are the patients where genetic risk counseling and evaluation is important. I will limit my talk to BRCA1 and BRCA2 because these are the most commonly talked about hereditary genes. And basically what we talk about them holds true for the other strong penetrance genes also. So even though I'm talking for that, you can actually extrapolate it to the other genes. The main understanding of the importance of these 2 genes came by the EMBRACE study, which is a prospective analysis. And what it told us, for the BRCA1 carrier, 60% risk of breast cancer, 59% for ovarian cancer, 83% for other breast cancer. The BRCA2 has 55% for breast cancer, 16.5% ovarian cancer, and 62% for controlled breast cancer. Understanding another thing, that hereditary breast cancer is only around 5 to 10% of breast cancer cases. But majority of these cases have a gender mutations in BRCA1 and BRCA2. And the problem is that a surgical treatment in this patient is a little bit tricky because these are young patients and the challenges involve aggressive therapeutic and risk reduction interventions. So if you have a BRCA patient with LFBC, our basic focus should be on the disease because that might outweigh the risk of a secondary cancer. On the other hand, if it's early breast cancer and BRCA and BRCA2, even then we cannot just have a blanket statement because the age, the completion of the family, and the psychosocial concerns of having a risk reduction procedure done are still to be looked at, and only then we take a call as how and what to do. So I would say that if today your patient diagnosed with breast cancer without having a BRCA, what surgery would be suggested? I think any of this or all of this could at some point of time be thought of as right. On the other hand, if it is a patient with a BRCA mutation, we might talk about this, but something that is always added is this. And I think today we'll look at it. This is often the most commonly opted for disease or procedure in a patient with a BRCA positive disease. So what are the important factors that we need to look at when we talk about BRCA positive disease? What are the chances of local recurrence in the same breast? What is the risk of controlled breast cancer? What is the effect of prophylactic or the risk reduction mastectomy on survival? And what are the factors that will increase or decrease the risk of breast cancer on the same or the opposite breast? I had a recent patient, and I think most of Geeta has also seen this patient. This patient was a young female, 40-year female. She had lump from right breast for 1 month. PET scan showed mass T1 with bilateral ovarian masses and internal lymph nodes and even external lymph nodes. We did the histopathology of the breast, which was IDC, TNPC. C1 was normal, CA was raised. We thought it might be a Kukenberg, but since the whole process changed, did a biopsy and it was adnexal carcinoma. This patient had 2 cancers. Since it was also TNBC and she also had some disease and we were waiting for the BRCA report, we gave her 4 cycles of NACT, doxy with carb. BRCA was positive, BRCA 1 was positive, BRCA 2 was negative. I did a right MRM with sentinel sampling with a conservative risk of mastectomy and cytoreductive surgery. The final histopathology was there was no residual tumor in the breast, and the ovary had adenocarcinoma on the right side. There was a nodule in the pelvic peritoneum which was positive, and also in the pouch of Douglas and vasorectal nodules were positive, though nodes of internal peritoneum were completely negative. I sent the patient for 2 more cycles of chemotherapy. The issue is, with the current understanding, could I have done differently? Could something else have been done which actually might have been better at such a young age? And let us look at the option that we have in a BRCA positive patient. We, assuming the eligibility for a BCS, we could have BCS versus MRM, a nipple sparing mastectomy versus the MRM, a contralateral risk reduction mastectomy without an NSM, and a risk reduction hysterectomy. These are the 4 surgeries, the risk reduction surgeries that we often talk about. So the issue becomes, is a BCS safe in the BRCA cancer? And there have been multiple studies. If you look at Nielsen, Pierce, DeBrock, what these 2 studies showed that the local recurrence was definitely higher if we do a BCS vis-a-vis mastectomy, though Brock did not show that sort of difference. And the basic difference that was shown was in early time, within the first 7 years, the recurrence difference was 17% BRCA, 11% without BRCA, which was not significant. But after 7 years, this recurrence rate started increasing. And the thing was, is it a recurrence or second primary? And what was studied was that only in 30% it was true recurrence. In 70%, the histology was different quadrant, and they were actually a different primary. And in all of these patients, survival did not change. So if you look at the overall survival, BCS versus mastectomy, it is similar. The recurrence as the time goes by definitely is much higher with the BCS. And for this reason, since the survival is same, BCS should be offered as an option to BRCA mutation carrier with proper preoperative counseling if the patient so desires. Though ipsilateral mastectomy should always be discussed to decrease the chance of a local recurrence. And if you use a breast conservation surgery in this procedure, local recurrence rate should be tried to be reduced, and it has been seen in multiple studies that adjuvant chemotherapy and a bilateral circumflexectomy reduces the local recurrence to 50% in the same breast. So if you are giving the patient opts for a breast conservation, she should definitely undergo this. Now, in the caveat for the other strong penetrance genes like TP53, this is one area where BCS is not indicated because a TP53 patient predisposes radiation to DNA damage. It has been seen that if a patient of TP53 is given radiation, there is high incidence of angiosarcomas. So a BCS is okay for BRCA2, but for the other strong penetrance genes, we don't have data to suffice that we should get away without mastectomy. The other thing is, what about nipple sparing mastectomy? Can we do that? Because if we can do that, the cosmesis improves. And we had studies from Manning and Zhao, and both of them showed that there was hardly any increased recurrence in these patients. And actually speaking, if we do a nipple sparing mastectomy, the cosmesis was much better as compared to any other patient. So recurrence rate was not too much, almost similar to mastectomy. So today, if the patient wishes, I think we should all be offering a nipple sparing mastectomy. Of course, we have to have the proper plastic surgery tools or education for that. The other option becomes, what about the contralateral breast cancer risk? And do we do a contralateral risk reduction mastectomy? Now, what is interesting is that in a BRCA1 patient, this is a BRCA1, I think photo is coming over that. If you have a patient who is less than 40 years of age, after 20-25 years, there's 60% cumulative risk. And if a patient is more than 50 years, even then the risk is more than 38-40%. On the other hand, if it's a BRCA2 patient, in that scenario, less than 40 years after age of 20-25 years, the risk is around 68%. But for a patient who was diagnosed after 50 years of age, the risk after 20-25 years is only 20%. So in a CRRM, it is important to understand what is the age of the patient and whether it's BRCA1 or BRCA2 before we opt for a controlational risk reduction mastectomy. The risk of recurrence on the opposite breast definitely is there if we don't do a mastectomy, and that risk has come down with most of the studies that has been shown, Kass et al., Von Sprundel. What is important is that 3 or 4 important studies by Evans, by Hemskirk, by Metcalfe and Sprundel. These 3 studies actually show that survival is also better vis-a-vis not doing a CR. And Sprundel, though, showed that the survival did not change. So we had a mixed breed where few studies showed that survival was better, but then this was a prospective cohort study with a median follow-up 11.4 years of Hemskirk and Gerritsen. The mortality rate was 9.6% of the group with a controlled mastectomy, while it was 21.6% with this group. So he definitely said that we should go ahead, not just for the purpose of removing the risk of local recurrence, but for survival. The meta-analysis Carbon et al. Of 7 studies did not show any survival. So the jury is still out for that, whether the survival is different or not, but definitely the chances of second primary goes down, and we should definitely offer CRRM with or without NSM in all patients with BRCA1 and BRCA2 mutations. This is the last part of the risk surgeries, and again we have plethora of studies working on RRSO. What is important on these studies, which are most of the prospective studies, and they show that if it is a BRCA1 patient, and we're talking about the breast cancer risk, in a BRCA1 patient, the hazard ratio is beyond 9 of 1. That is, a BRCA1 patient, RRSO did not have any benefit in terms of decreasing the breast cancer. On the other hand, BRCA2 one, after 5 years, did show. If it was less than 5 years or 2 years, there was hardly any benefit of a risk reduction has removed it. In BRCA2 also, but as the time progressed, there was a benefit. So, what is important to understand is that in a BRCA1, we might not opt for an RRSO, but there is a potentially beneficial effect in the BRCA2 mutations, and this could be because that most of the BRCA1 are TNBC, triple negative, while BRCA2 are more often than not ERPR positive. And there was there was a very small incidence of increased survival, so there is a very low set evidence that it might improve survival. But what is important and why RRSO should be offered, that it has reduced the risk of ovarian cancer 80%, and all-cause mortality by 68% in females with BRCA1. So the reason that we have to do RRSO is not for the breast diameter, but to reduce survival, to improve survival, because the ovary is something which is bad, and because it is for the ovary, the timing of the RRSO changes. For a BRCA1, it's 35 to 40 years, while for a BRCA2, it's 40 to 45. Understanding that if we do it early, the patient has problems like cardiovascular disease, osteoporosis, and quality of life. So RRSO should be delayed, even though we are doing the CRRM or mastectomy much earlier. So last 2 slides. So what do we do as an approach? If the patient is having all these things, BRCA1 carriers should have the surveillance started at the age of 18 years, with MRI starting from 25 years, and medication, Forceid, like tamoxifen, should not be used in BRCA1 because they are negative, but in BRCA2 carriers, tamoxifen has a role in decreasing it. Mastectomy, risk reduction is important in BRCA1 because we do not have the option of a chemo prevention. But for a BRCA2, patient can be discussed about it. We can talk about medical agents to reduce the risk, or we can go for a mastectomy. And the breast cancer is where there has been seen there is no benefit of a risk reduction mastectomy. So the male breast cancer, it is still not advisable whether it's BRCA1 or BRCA2. So to conclude, risk reduction surgery is an important armamentarium for the hereditary breast cancer today. We can opt for mastectomy or nipple sparing mastectomy or BCS if they decide. Safety of BCS is basically for the risk of the second primary. This risk is also reduced using a serpentoprectomy, tamoxifen, or adjuvant chemotherapy. Contralateral profiling mastectomy reduces the incidence. Whether it has impact on survival is still out, jury is out, but yes, some studies have shown yes, some no. RRS current evidence of this carcinoma ovarian breast cancer in BRCA2. But whenever we are opting for that, we have to look at the psychosocial and infectious issues of the patient, especially when they're using RRSO. And based on that, this decision should be taken. Thank you very much.
Thank you, Dr. Mittal, for an elaborate talk on the risk-reducing surgeries for BRCA1, BRCA2. If there are any questions for a minute. Yes. Can you use the mic at the...
Just a query that should the BRCA testing should form a part of routine workup before if patient of breast cancer comes to you, operable. Will BRCA testing will be a form of essential part of your workup or not at the moment?
Hello.
And will it change your surgical procedure at the moment or not as per today?
Basically, as I said, that I showed you a graph where the patients who require,
Will it be a, this is important because when we send patients for surgery, should we send, we get a mammography, other things. Should we do a BRCA testing or not?
the criteria are very straightforward.
At the moment.
No, at the moment, it is only if you are in those criteria. You have a strong family history, you are known to have a mutation, you have a TNBC. All TNBCs should
That
have
means
it.
all TNBC patients should have a BRCA
Should have
testing.
it. All patients less than 50 years should have it.
So that means every patient probably. In
I mean,
another
I mean,
country.
if you look
So
at,
it's very, I mean, we are not,
Yeah,
I'm
if it's
not,
less than-
in my practice, we are not getting
if
it.
it's less than 50 years, you should have it.
All.
All.
Okay.
Dr. Sari,
so
Dr. Sari,
I'm
just one small
yes,
comment.
Go ahead.
One paradox which always bothers me, that on the cancer side, you are talking of BCS. And if BRCA1 is positive, we are talking of risk reduction mastectomy on the other side. So suppose we have done the BCS today and later on we are doing a contralateral mastectomy. Somehow the other, this paradox is bothering me quite a bit.
Sir, I think it is more about mental well-being, as all the reports have shown the overall survival doesn't change. But it's the mental well-being, fine, I will not have it. I mean, if we can convince, that is why I said BCS should be offered. CRRM until unless it shows the survival advantage. Some studies have shown survival advantage. Survival advantage is shown, then we are right in offering a CRRM. And some studies have said it. So that is the reason why CRRM is being touted as one of the reasons.
So
A quick one.
yeah, just a quick comment to what the gentleman asked. See, I'm very, very worried about this BRCA1 and BRCA2 being offered over the counter. So it is not a right thing to do. You must counsel the patient because, you know, the patient has to be very clear on what the implications of a positive or a negative test is. And then the test is a choice. Whether you want to do the test or not is a choice of the patient.
I just interrupt because as per the discussion,
I
I'm given
think
to
we will
understand
take-
that BRCA testing
We
is
will
so
take the,
important to
No, we
decide the
need to
type of
understand,
surgery.
see, we need to understand the
So it should be very
implications.
clear to the audience that should we get it tested or not?
No,
It's very
so
important, isn't
No,
it?
testing is the secondary thing. I must know when I know, you know, there's a triple
Because normally
negative.
I'm not getting, I think most of us are not getting it done at the moment.
Interaction, we'll take
Yeah.
it
Yeah,
outside.
so if there is a
Yeah.
triple
The
negative
questions
40-year-old, you
yeah.
would do a counseling
Make your
first and then a testing, not other way around.
Yes. I think we are running short of time. But
Yeah,
I
just a
think
last
it's
comment.
interesting to
Actually,
know.
I think ma'am wants to say that the patient should be ready to undergo the surgery after the BRCA comes positive. If the patient is willing to undergo that surgery, only then BRCA should be done. Otherwise, it's pointless to do BRCA beforehand.
I think we'll take this discussion outside, but what I actually want is that there are other modalities to reduce your risk. And I think lack of time, Dr. Mittal did not mention that lifestyle changes the diet, and the prophylactic hormonal treatment, tamoxifen or otherwise. There are other modalities if somebody is not willing for risk-reducing surgery are also there. And also, I think this dilemma that you can do mastectomy, breast conservation, this has been there for 15 years, and I don't think we made a progress. The younger the patient, more the mastectomy they need. Older the patient, they may not. And the younger the patient, they don't want mastectomy. So counseling is the answer. And thank you so much for
I think, ma'am, we
being here.
are running short of time. So with this, we declare this, with the permission, the session closed. And I must thank Shyam again for giving us this honor to chair the session. Thank you very much.
Yeah, thank you.
Hello everyone. So as surgeons, we have seen two major face-offs. One is BCS versus MRM. BCS won some, MRM won some. Then came SLNB versus ALNB, and ALNB clearly lost on many fronts. But now there is a third contender in the ring, and that is SLNB versus ALNB post NACP. And so we are already in the mood for a very spirited discussion, and I will call on Dr. Rohit Nair, who is chairperson of surgical oncology at Max Healthcare. So welcome. And I'll hand over the stage to you so you can take forward this spirited discussion and keep the peace also. Thank you.
Hi, good afternoon. I just wanted to correct, sir. I am working with Max Saket as a director of surgical oncology. So, very interesting discussions going on. So, as far as breast cancer is concerned, so we are cutting down, we are coming down, we are reducing. We started from Halsted surgeries to mastectomies to MRMs to quadrantectomies to lumpectomies, and now we are still coming down. And in fact, when I was studying that time, people were saying that surgeons are going to be redundant because breast cancer is only medical oncology disease. So we are just going to treat it with medicines. So much of development has happened as far as the newer drugs are concerned and the treatment of breast cancer is concerned. Well, if you see the other side, colon cancer, GI surgeries, we are going towards maximalism. We are tracking and tracing the tumor cells. We are doing hepatectomies. We are doing peritonectomies, CRS, and HIPAC. So it depends upon which disease and what drugs do you have, and what adjuvant treatment and how effective treatment you have, and what is the biology of the disease and how we are treating it. So because of that reasons, now we are coming into an era of minimalism as far as breast cancer treatment is concerned. You see that you wear a slim fit dress and you start looking fit and fine. So it's just like same is happening as far as breast cancer treatment is concerned. So we are slimming down our treatments, trying to look attractive and trying to get the best out of it. So we have a very good discussion now, a debate on sentinel node biopsies versus axillary node dissection in patients who have received neoadjuvant chemotherapies. So what is the best way forward? So I would like to invite our first speaker, Dr. Rajiv Dua. He is the Director of Surgical Oncology Breast Services with Vedanta Medicity. Sir, please.
Thank you, Dr. Shyam and Dr. Kaul, for inviting me. Before I start my talk, I think I already have a supporter. Geeta has already talked about de-escalation of the XLR post NACT. So axillary node dissection has always been an important component of breast cancer treatment. In the Hestadian era, ALND was regarded as an important procedure to ensure regional control. With the evolution of therapeutic concepts and introduction of biological approaches, the goal of ALND shifted from a purely therapeutic procedure to a diagnostic and staging procedure, and thus guiding further treatment and some therapeutic effect in node-positive patients. I think Cody wrote a long time that sentinel node localization is the second most important development in this century after conservative lumpectomy for the treatment of early breast cancer. And Keddy in 1984 wrote that lymph node metastasis may be an indicator, but not governors of survival. In fact, 30 years back, my dear senior colleague and friend Dr. Indranil Mitra spoke once that lymph node metastasis may always not be a bad prognostic factor. It may be a chronological age of the disease. And why it is so? Because we know that shedding of cells into the vascular and lymphatic vessels undoubtedly occurs simultaneously in the vast majority of cancers. But the later progressive growth of cells and micrometastasis distributed hematogenously to vital organs is the ultimate governor of survival. Coming to my topic, that sentinel node biopsy post NSCT, and I am speaking for the motion. So let us see what are the indications of today neoadjuvant chemotherapy. We know that till a decade back, only the locally advanced breast cancer was the indication of neoadjuvant chemotherapy. But today, any lesion which is more than 2 centimeters, if it is TNBC or HER2 positive patients, they are an indication of neoadjuvant chemotherapy. And what are the situations that sentinel node biopsy can be done? Somebody asked also that we can do sentinel node biopsy before starting neoadjuvant chemotherapy. We can do sentinel node biopsy in clinically N0 nodes on presentation. And when we say clinically N0, it means clinical imaging, and today ultrasound FNAC of the lymph nodes has become a very, very important part of the pre-treatment workup for axillary nodes. And of course, the clinically positive nodes on presentation post NSCT, they become clinically N0. So they are the indications for sentinel node biopsies. And how we judge that whether we should do sentinel node biopsy in all the cases or not, the issues are identification rate, false negative rates, and axillary recurrence and survival benefit. So let us do the first situation, that whether we can do sentinel node biopsy before starting chemotherapy or after chemotherapy in N0 patients. So these are the 4 trials which has been done, that where the sentinel node biopsy has been done before starting the neoadjuvant chemotherapy. And down is the 4 trials where they have done a sentinel node biopsy after the neoadjuvant chemotherapy in N0 patients. And there is a large body of data demonstrating that in clinically node negative patients performing sentinel node biopsy before or after NACD results in the same identification rates, that is almost 85 to 97%, and same false negative rates ranging from 5 to 12%. And these results are similar to other prospective multicentric trials. So today, by and large, the sentinel node biopsy is not done before starting the neoadjuvant chemotherapy, because patient unnecessarily goes for 2 surgeries. So in a clinically N0 node on presentation, most of the time, the sentinel node biopsy is done post NSCT. And so I think there is no disagreement over post NSCT sentinel node biopsy in N0 patients. So coming to the next, which is the most debatable and controversial topic, that is sentinel node biopsy accurate when nodes are positive and the patient received neoadjuvant chemotherapy. In a meta-analysis, there are about 13 trials, but most often we quote 3 major trials on this issue. And first is Z107 trial, where the initial false negative rate was almost about 12.6%. So that is a little less acceptable because arbitrarily the investigators have put a limit of the false negative rate to 10%. But then how we can decrease the false negative rate? When we do a two agent, whether blue dye and radiocolloid, FNR came down to 10.8%. And when we do at least 2 or 3 sentinel nodes, the FNR rate comes to 9.1%. Another trial where sentinel trial, not sentinel trial, where the false negative rate was 14%. But again, when we examined more than 3 lymph nodes, the FNR came down to 10%. And with the double mapping, the FNR rate came to 8.6%. Similarly, this Canadian trial, again, the overall FNR rate was 8.4%, but it came down to 4.9%, or even a dual tester technique about 5-2. So if we select our patients properly, if we do a proper technique, I think our false negative rate can come down to less than 10%. And this is the same slide, the sort of summary and comparison, what was the false negative rate initially and how the false negative rate can come down. This is another thing that Geeta has already talked about, a targeted axillary dissection, where we put a clip or radioactive iodine seeds in the node at the time of FNAC. And when we do sentinel node, we remove these nodes also, and false negative rate can be brought down to as low as 1.4%. Next is, as I said, the issue is axillary recurrence. So these are the 2 trials, NSABP04 trial and NSABP32 trials, where the false negative rate of sentinel node was about 9.8%, but the axillary recurrence was only 0.7%, while in the NSABP04 trial, 40% of patients had axillary metastasis, while the axillary recurrence was observed only in about 18% patients. Similarly, a meta-analysis of several randomized trials of ALND versus no surgery in the axilla, the axillary recurrence rate varied from 1.8 to 3%, while the pathological node disease was found to 21 to 28%. What I mean, if we do axillary dissection, the disease in the axillary nodes may be higher, but that does not represent clinically in the long run in the follow-up as axillary recurrence. And this is, we all know that today, if we do a frozen section on the sentinel node, and if the sentinel nodes are less than 3 positive, we may not offer complete axillary dissection. And these are the 2 trials, Z0011 and IPSCG trials, where there was no significant difference in either disease-free or overall survival between the study arms, despite the fact that involved axillary nodes were detected in more than 27% of those who underwent complete axillary dissection. And next is, do we offer survival benefit to these patients? And we know that 25-year follow-up of a randomized trial comparing radical mastectomy, total mastectomy, and total mastectomy but followed radiation, there was absolutely no sort of survival benefit. So these are the just basic trials of sentinel node biopsy, where the sort of false negative rate was fairly high, but there was no survival difference. So that is what my message is, that there should be a sentinel node should be tried today in clinically N positive patients who become N0 patients after an SCT, but we must make some effort to reduce the false negative rate of sentinel node by at least dual mapping, 2, 3 or more sentinel nodes to be removed. If possible, pre-treatment positive node should be marked, and of course use of immunohistochemistry on the sentinel node. And even NCCN guidelines 2022 also says that if preoperative chemotherapy has been given, then sentinel node in selected cases when nodes clinically become negative should be tried. A meta-analysis of sentinel node biopsy after neoadjuvant chemotherapy In patients with initial biopsy proven node positive breast cancer, the sentinel node is fairly accurate and reliable with careful patient selection and optimal surgical techniques, and shall become a standard practice in due course of time. So my take home message is the centers which can have these facilities, which can have a dual technique, and of course a good frozen section on sentinel nodes and correct selection of patient and correct technique, I think we should start practice sentinel nodes in clinically N positive NACT and then becoming clinically N0 disease. Thank you.
Thank you, Dr. Raji. I'd like to invite our next speaker, Dr. K. Lohita Krishna from Sri Shankara Cancer Hospital, Bangalore.
Good afternoon, everyone. I would like to thank the organizers for this opportunity. After Sir's talk, everything is going to be a little difficult convincing people for ALND in the era of when less is more. I'll try my best. So I am Dr. Lohita Krishna. I'm a consultant orthoplastic breast surgeon at Sri Shankara Cancer Hospital, Bangalore. So why is axillary surgery so important? It plays a very important role in staging. It gives us prognostic information. It gives us local disease control. Axillary management is becoming more and more complex nowadays. So there was this era when post NACT, every patient would undergo axillary lymph node dissection. Then we thought, should we do sentinel lymph node biopsy prior to neoadjuvant chemotherapy? And then it was clear, if the sentinel lymph node is positive, go for ALND post NACT. If it is negative, no hope. Then we are now in the era where we are evaluating them into two different groups, clinically N0 at diagnosis and node positive at diagnosis. What's happening in neoadjuvant chemotherapy is what we see, what we want to see is downstaging of disease in breast and axilla. We will see an in vivo response and there are higher chances of attaining PCR, and PCR has shown to give us a better disease-free survival. Is tumor size related to the axillary lymph node metastasis? The association? Yes. So as the tumor size increases, your chances of axillary lymph node involvement also increases. Now, is the breast PCR equal to nodal PCR? No. What radiological and pathological response in the breast and axilla are completely different, and they should be viewed as two separate entities. Responses are vary according to biologies. Hormone positives have very partial response to neoadjuvant chemotherapy, whereas triple negatives and HER2 positive diseases have better chances of attaining a pathological complete response. Now, this also varies between breast and nodes. So there are three scenarios here. Clinically, node 0 at diagnosis, then comes our N1 and then N2. One advantage which we have with breast is the lymphatic drainage is in a very orderly pattern, unlike head and neck cancers. So when we do sentinel lymph node biopsy before NACT, it gives us an accurate staging. It identifies patients who can avoid ALND if sentinel is negative. It identifies patients who need radiation therapy. The only disadvantages are it requires two separate surgeries. If there is a delay in wound healing, that delays your start of neoadjuvant chemotherapy. And importantly, it denies the opportunity of being spared ALND post-NACT. That is the main reason why now everyone talks about doing SLNB post-neoadjuvant chemotherapy. Now, what are the concerns when we do this after neoadjuvant chemotherapy? So neoadjuvant chemotherapy causes fibrosis and scarring of the lymphatic channels. That decreases our identification rate, and there is non-uniform effect of the chemotherapy. So now you have a node which has disease and the lymphatics have become scleroid and necrosis. Now that is no more your draining lymph node, and when you do a sentinel lymph node, you're going to pick up another node. So this will cause a higher false negative rate. The main concern here is clinically node positive patients who have now turned clinically node negative. Can we consider SLNB in this group of patients? So very recent meta-analysis, just few months, it considered 79 studies. It included 10,680 patients and it showed false negative rates are still high, 11.8. Only below 10 is acceptable. And when we go deeper, it shows that hormone receptor negative and HER2/neu positive patients had more false negative rate compared to other groups. And this also shows that 26.8% of patients with initial clinical node negative status had nodal metastasis after NACT. Now another paper from Tata. Now I'm going to concentrate a few on the Indian studies. There are very few, but yes, this is an Indian study, and they looked at around 750 patients, and the clinical T size to start with was T2 and T3 in majority of the cases. These cases have turned node negative post NACT. And when they did that, the first group, what you can see is your sentinel node group. That is your true sentinel. They used a dual tracer, hot node and a blue node is identified. Sentinel node plus adjacent palpable lymph nodes, what they did is they identified the blue node, they identified the hot node, and adjacently wherever there was a palpable node, they've even picked that and sent. The other one is your low axillary sampling. Now the mean lymph nodes retrieved in sentinel lymph node biopsy, true sentinel lymph node biopsy group was 2, sentinel plus adjacent lymph nodes were 5, and low axillary was 7. And the true sentinel nodes showed a false negative rate of 31.6%, which is completely not acceptable. And when adjacent nodes, that is, you can take it as a mean, then 5 lymph nodes removed, and yet our sentinel rates were 19.7. Then you have another study from Kidwai Hospital, which looked at 44 locally advanced breast cancers. Of this, 86% were clinically node negative positive to start with, and they've all turned negative post chemotherapy. In this study, clinical examination and ultrasound of the axilla was used post NACT. Overall identification rate was 86.4 and false negative rate again 21.4. Now, this group also, these are the majority of the cases in India where we give NACT. So again, in India, primary surgery is considered for very early breast cancers. Primary surgery is preferred for hormone positive cancers also. Now, the gray area here will be your TNBCs and HER2/neu positives, where a multidisciplinary approach is advised. We need to do triple assessment of the lymph nodes. Pathologically also, FNAC or biopsy has to be done to determine the clinical status pre-NACT and then go forward. Even in clinically known negative patients, there was high rate of subclinical involvement of the axilla in the NSABP B18 if you look at it carefully. So the recommendations are to consider sentinel lymph node micrometastasis or ITCs also post NACTs as node positive disease irrespective of the biology, as this low disease burden also indicates non-uniform effect of chemotherapy and also chemo-resistant diseases. Many a times we get calls from a pathologist, frozen section, they say it is negative, and then the final pathology comes, oh, there are multiple, there are some micrometastasis on deeper section. Now, what is the mode of evaluation in this residual nodal diseases? So clinical examination, axillary ultrasound, which is most commonly used, and the sentinel lymph node. Axillary ultrasound has accuracy of only 62%. Now, use of axillary ultrasound in predicting chemotherapy, is it a good predictor? There was a study which included 402 patients who were clinically node negative. They did a pre-NACT as well as post. 54% of the patients with abnormal lymph nodes on imaging pre-NACT did not require ALND post NACT, and 20% of patients with normal looking lymph nodes on imaging pre-NACT had diseased lymph nodes post-NACT. So this study concluded that axillary imaging pre-NACT is not accurate in predicting nodal metastasis and need for post ALND post-treatment also. Then you have the MRI, of course, by not mentioning it. The sensitivity okay, but the specificity rates vary a lot amongst literature. A targeted axillary lymph node dissection, it has opened more questions and left many questions unanswered. So locating and removing both clipped nodes and sentinel nodes is what targeted axillary dissection is. Yes, results have shown decrease in false negative rates. but we still do not have ideal tool for this targeted axillary dissection. Many markers can be used. You have radioactive seeds, you have MAC seeds, you have carbon tattooings also. We really don't know which one to use. Then how many nodes have to be placed? Is it in one or is it in many or all suspicious forms? Then what if the clip is lost? Then can all the clips be retrieved? No. Many studies have shown that 20% of the cases, the clips are not retrieved and you have to revert back to your axillary lymph node dissection. And the use of this, whether it is to be used in clinically node negatives or node positives, that also we need answers. Arm lymphedema, yes, we do acknowledge that ALND has increased breast cancer related arm lymphedema, but now with immediate lymphatic reconstruction coming up, maybe we can decrease those rates. Now, trends in axillary management of early breast cancers. This was a questionnaire then published in India. So this included, the questionnaire was answered by 111 doctors, and they said that 47% used methylene dye alone till date, and the other 45 doctors did not perform sentinel lymph node biopsy. This is in a general sentinel lymph node biopsy, not like post NACT. And the reasons for not performing is radioactive dye not available, frozen section not available. The other reasons are lack of training, financial issues also. So in India, it has to be still, like even in 2-tier cities also, people need to have sentinel lymph node biopsy availability. So why not? So majority are retrospective studies, what we are looking at. Prospectives are very small series. Survivals also still very short follow-up, long-term follow-ups are required. Our stages of presentation is completely different from what we see in the Western world. We have more T2s and T3s. Dual tracer, again, as I told, licensing, availability, and cost. Then with us, patient follow-up is also going to be a little poor. Now, when we come to the 2021 consensus statement from the Association of Breast Surgeons of India, I read as they say, in post-NACT setting, targeted axillary dissection or picking of clip node is an ideal option to decrease the false negative rates and should be done in context to research settings. In clinically node positive, which have become clinical node negative on imaging after sentinel lymph node biopsy, SLNB is not recommended. So by giving you a summary of all this, there is a growing evidence of omitting complete axillary dissection, but we need more evidences. Even though response is good with triple negatives and HER2/neu positives, given the aggressive nature of these tumors, leaving behind even micrometastasis in axilla will increase the risk of relapse. It is important for institutes to recognize their own false negative rates and identification rates. Thank you.
Excellent. Please have a seat here. Any questions from the audience, please? Yes, madam, please. Can we have a mic for her, please?
I think the discussion has been going on for more than 5 years. So, I mean, what I believe is that sentinel lymph node biopsy post-neoadjuvant chemotherapy in N positive going to N0 is feasible in centers who have done a large number of sentinel lymph node biopsy without neoadjuvant chemotherapy and know the technique and have the double dye technique and can recover 3 lymph nodes. I think it can be done in selected centers with selected people because it does reduce your lymphedema and your other side effects. So it's not for everybody. It's for highly specialized centers who's been doing sentinel lymph node biopsy and know the technique. It is exhausting. It takes time. It actually endures your patience. I mean, you need to have a lot of patience. It can take 45 minutes. And it's not that easy to do, but it's there to stay.
Definitely, ma'am. That is why every center should have their own identification rates and false negative rates. They should have their own, techniques of doing it, whether they want the dual tracer or single dice, and come up with own results and then only implement it on a wider, make it your protocols, your institution.
Also for those patients who had bulky disease, like more than one node positive before chemotherapy. So those who are having larger number of nodes, and even if they shrink after chemotherapy, still doing sentinel nodes, I think is still not the term nowadays. So you need to select your patients for them. It is still on the trial basis, still the number of patients included in these 3 trials are still not the dictum for it, but yes, that's the way forward. It's showing us a way you can still select your patients and offer them sentinel node biopsy. Thank you very much. Thank you organizers for giving us this opportunity.
Made, and I like to be corrected that sentinel lymph node post-neoadjuvant chemotherapy and 1 plus should be done in patients with level 1 lymph node involvement. If you have a level 3 lymph node involvement prior to the neoadjuvant, sentinel lymph node is not required. It has to be proven that it's level 1, and I think ultrasound can tell you it's level 1, level 2, or level 3. So not level 3, level 1 plus minus level 2.
Thank you.
Thank you, Dr. Rohit, Dr. Mohita, and Dr. Rajiv. For the next case panel-based discussion, I would like to invite the panelists. Dr. Ajit Tiwari, Assistant Professor, Surgical Oncologist, Sri Mahan Ganesh Hospital, Dehradun. Dr. Manish Patnaik, Principal Consultant, Surgical Oncologist, Max Healthcare, Dehradun. Dr. Satyam Taneja, Director, Department of Surgical Oncology, Shanti Mukund Hospital, Cancer, Delhi. Dr. Ashutosh Gupta, Radiation Oncologist, Jammu Medical College. Dr. Amish Chaudhary, Director, Surgical Oncologist, Asian Institute of Medical Sciences, Faridabad. Dr. Deepika Gupta, Associate Consultant, Surgical Oncologist, Sir Rangaram Hospital, Delhi. Dr. Bimlesh Thakur, Surgical Oncologist, Sir Rangaram Hospital, Delhi. Dr. Anu Puri, Associate Consultant, Radiation Oncologist, Fortis Hospital, Guwahati. And Dr. Shubham Jain, HODN Consultant, Surgical Oncologist, Manipal Hospital, Curious.
So, can I have my presentation, please? The presentation which is open here is of Dr. Zamre. Anyways. Thank you, Dr. Agarwal and Dr. Kaul, for inviting me here and involving me in this meeting. And for a change, the panel is all surgeons. The top is it? I was told they're all surgeons, so okay. Lateral end, wild card. Can we have the slides? Oh, here it's still showing Dr. Vaishali Zamre. So I don't know. I'm not even able to move. We'll start straight away with the cases, and I'll start with two cases of similar problem. One is a 57-year-old postmenopausal lady, hypertensive, screen detected solid cystic lesion, right breast, 11 o'clock, 7 into 6 mm, which was seen on USG as well as on mammo, reported as BIRADS 3, 4A. No microcalcification seen on mammo, and examination was normal. Her mother also had CA breast. The other lady is 64 years, hypertensive again, screen detected pleomorphic microcalcification in the right breast, 9 o'clock position, BIRADS 4A, ultrasound was normal. Last mammo of 2017 was also normal. Examination revealed a dense area which was tender on the opposite side. Same side did not show any abnormality. She also had a family history of colorectal cancer, prostate cancer, as well as RCC. Now, I have the films only of the second patient, so I won't be able to show the first one. These are the mammo films. And if you see, that's the microcal. That's here. And this is a magnified view, which is showing it slightly better. So what are the next steps, and can we start from one end, Dr. Manisha? For all of you, please, what is your next step for this patient?
Am I audible? Yeah. You want my take on both the patients?
Both the patient, please. Yes.
Yeah, both are postmenopausal. And first we need to, and both have a clinical suspicion, clinical and imaging suspicion of malignancy. So we need to prove it and do a metastatic workup. These are the two major things that we need to see first, and then go on from that.
How do you want to prove?
I would do a true cut biopsy for both of them, image guided, obviously. Both look like they would be obvious on ultrasound. So a ultrasound guided biopsy would be possible in both of them.
The second one actually was not showing anything on ultrasound. Only the first one was showing. Second
It was
one,
only X-ray
ultrasound was normal.
mammography.
It was only on mammogram.
Okay. So probably the second one would need a stereotactic or a like mammo guided or a MRI guided biopsy if it is available.
Okay. So next, please.
I would agree with her. The second would require an MRI guided stereotactic.
Closer to the mic, please.
Hello.
Okay, so he says, I agree with Dr. Manisha. Next, sir, would you like to comment on this?
Yeah, I think first thing is to establish a diagnosis with a tissue. And in first case, looks obvious that lesion is visible. So a true cut will be of use. And second case, I feel you should have a better imaging. Probably MRI may be helpful here.
Okay.
Because you have to image it before you biopsy it. So a better imaging
Okay, so
procedure.
another opinion is that we should do MRI as well.
Because you have to visualize it before you take a tissue.
Okay. Dr. Shubham.
I largely agree with the same that we need to do the triple assessment because in the second case, it's
Triple
not.
assessment, by and large, third part of the assessment you are saying, right?
Yeah, and because in the second patient, it's not visible on the ultrasound probably, and we are suspecting a strong family history. So that is why getting an MRI done for both the patients may be more worthwhile in the first patient because there is a significant family history in the second patient as well.
So MRI in the second patient actually did not show anything. I'll show only the report. I don't have the film, but MRI did not show anything.
We'll believe
Reported
you.
as BIRADS 2.
Wow.
So your other colleagues are wiser now, at least for the second patient.
Actually, I was going to agree with Dr. Shubham that we should go for MRI for the first.
I told you MRI is normal for the second patient at least.
So we need to go do a true cut biopsy guided.
True cut biopsy.
Where the lesion
Dr.
is-
Shubham, true cut biopsy.
The question is, how would we localize the lesion? I would want a biopsy since there is.
I think we have only one way now to localize is stereotaxy.
Yeah.
So with Byrad's 2, you want to go ahead actually?
That is MRI. This is Byrad's 4.
I would say because there is a discordance of the reports, between the mammography and the MRI, it would be better and in benefit of the patient to at least do a biopsy so that we are more sure and certain about.
There are 2 reasons why we should do it. First, this is a suspicious microcal. I hope everybody agrees here whoever can see this. And secondly, more importantly, it was not there in 2017 mammogram.
Strong family history, and the mammography showing Byrad's 4A lesion. So we cannot disregard 4A lesion only by looking at that MRI showing Byrad's 2. So we must prove this, and we are seeing the lesion on the mammography. So true cut biopsy, I think, would be the first choice.
Okay, Dr. Ajit.
Actually, the first case, true cut biopsy won't be possible. 6 mm true cut hitting then going. So wire localization and mammogram of the sample. And the second case, obviously, the lesion is not visible, so we have to excise it and send for intra-op mammogram. That's the only option we have.
So you say both of them localize and excise.
Localize and excise for tissue diagnosis.
Okay.
Because 6 mm we cannot do true cut if it is not palpable.
In first case, no doubt, if we can target it by a USG guided, because it is there, we should be trying without an MRI also, we should be trying first by a USG guided biopsy if it is possible. If not possible, we should get an MRI done and proceed further with the biopsy accordingly. And in the second case, which is not localized, which is not visible on ultrasound, we have to go for a stereotactic biopsy.
Any other opinion from the house? So there are various opinions. MRI, many people have said, most of them have said true cut biopsy. One has said localize and excise both of them. And one is saying localize and excise one and true cut for the other, right, Dr. Satya?
Can I just add a point here about the sensitivity of MRI? It's really opposite, isn't it? Mammography is showing a Byrad's 4 and MRI is not coinciding with it actually.
Only microcal may not be visible on MRI unless there is.
So that means what I mean to say is that if you have a suspicion on a mammography, should you routinely go for MRI or not? Is it less sensitive?
Okay, so that question is also one of the questions. Let's see, this is why mammogram is important. Many a times we see patients coming up with PET CT
and MRI.
Sometimes MRI, but no mammogram. Biopsy also done, but no mammogram. So that is why mammogram, I think, is important for every patient. Ma'am, you wanted to say something?
What I wanted to say was that whenever you have a suspicious lesion, my take is, it's always better if you can make a biopsy because you can do one surgery with a sentinel node. If you do a wire localization and excision, you need a second surgery. So as far as possible, if a biopsy can be done, ultrasound guided, mammographic guided, MR guided, only available in Medanta, I think it's always better to make a biopsy and then plan your surgery. And for this microcalcification, I mean, I think you just said MRI is normal, but never mind. Mammographic cord biopsy or mammographic VAB, if somebody is doing it, and take the whole thing out and have a biopsy is always better, or a close follow-up.
Ma'am, why VAB over true cut? You mentioned VAB, you're the only one who has mentioned VAB. So why VAB and not true cut?
No, it is not the question of where. If you have the facility, if your radiologist is confident of doing a stereotactic core needle biopsy, you can do a core needle biopsy. If she feels or he feels that core is not possible, then of course the VAB is the possible. What madam wants to convey or what I want to convey, that pre-treatment tissue diagnosis is very important. A new appearing microcals over the period of 2-3 years, I think we must suspect and do a biopsy because it will save 2 surgeries. We can do a VAB or a stereotactic biopsy, and if we feel all the microcals has come up, we can put a clip in that.
Yes. So even why I was asking VAB versus true cut, because the upgradation rate after VAB is practically 0. Whereas after true cut, there is still some upgradation possible and you may end up with another surgery again. So even after doing a true cut, you may end up with another surgery. anyways.
That is expensive as well.
Sorry?
It
Yes,
is quite
expensive also.
expensive.
So there are many issues. Availability is again one more issue. So both had MRI. One was BIRATS 4A, other surprisingly reported as BIRATS 2. We did discuss with the radiologist and they said, no, I can't see anything there. What we did, we discussed, at least for the first one, I said we will do a wire guided localization rather than doing a biopsy. The second one, option of WAB was given, but patient did not agree for it. And we actually did excise both of them after doing a wire guided localization. So these are the options that I had put, and almost everybody did mention one or the other except observation, which is obviously not an option in any of these patients. So this was the wire placed, and that's the specimen mammogram. Wire in at least in one view had gone beyond the microcal, in the other view was okay. And you can see that the margins are looking okay. And that's the biopsy. Both are DCIS. The first one is a 3 mm grade 1 cribriform solid, no necrosis. Closest margin is 4 mm, ERPR 10% and weak staining. Whereas the other one is a 5 mm intermediate grade, cribriform papillary type. Margins again are clear and ERPR is 95%. What would be your adjuvant therapy and is the margin adequate? The second one margin was more than 1 centimeter. The first one, the closest is 4 mm. Is margin adequate as per all of you?
Yes.
Both the cases? Fine.
I think more than 2 mm is.
More than 2 mm for DCIS is what is acceptable today, and no ink on tumor for invasive cancers. What about adjuvant therapy? Dr. Satyam?
It is DCIS, we will be proceeding for an adjuvant RT along with hormonal treatment.
Any difference of opinion, sir? Can we avoid radiation for any of these?
Yeah, a good surgery is sufficient for this. And radiation, why should you give a DCIS?
Sorry, please, louder, please.
I think I would avoid radiation in this case.
For both the patients?
Both there's no invasive malignancy in both cases. So a good excision, I mean,
RT is must in both the patient.
Because
for the first patient, since ERPR is 10%, I might give an option of not going ahead with hormonal, but definitely RT.
Okay. Any difference of opinion?
RT to both the cases, but looking at the hormone positivity in one of the case, and if it seems to be a low risk case, few cases you can avoid RT, but general practice is to give RT to all the patients.
This is a unique situation, sir.
I
They are saying
also-
give RT, and the radiation oncologist is saying not to give RT for both the patients.
Actually, what I would say is probably we need to discuss what the patient wishes. In view of the biopsy reports, there would always be an option of a mastectomy if the patient wants to avoid the radiation altogether. So that component also needs to be discussed along with other things. Definitely, these are low risk cases, but I would still probably err on the side of the patient is keen for the conservation to go ahead with radiation.
So as Dr. Puri mentioned, I think
I mean, I'm sorry
there is
about.
a very small.
It's a small
cohort of
lesion,
patients where you can avoid RT in today's time with DCIS. There are more and more studies coming up where you probably may be able to avoid RT in more and more patients. But a low-grade tumor who is going to receive tamoxifen or any other hormone therapy, clear margins, small size, probably those are the patients where you may be able to avoid RT. But otherwise, even in those patients, the local recurrence rates are higher if you don't give RT, but in the very long run. So yes, to be fair, there are some patients who can avoid RT, but largely, if you say so, this was discussed in our tumor board, and again, 2 radiation oncologists had 2 different opinions.
Such a small lesions we hardly see.
Yes, we know.
So what did in your case? What
It was from,
did you give RT in this patient or
Less than
not?
6 or less than 7, the local recurrence rate is less than 5.
there was single university, University of South
Doing
California, which
radiation
was
for
doing
the
this thing.
entire breast, you know.
So that's what I'm saying, ma'am. There is a small cohort of patients, and definitely one of them fits into it.
What did you do?
The first patient. So second patient, we have recommended RT. The first one, my personal opinion is avoid RT. Yeah, we don't have. Unfortunately, we don't have. So
NCCN recommends that RT should be given. You should consider RT
No,
only
NCCN
in a
has-
very small cohort of patients where endocrine therapy is being given and very low risk features. Von News index can be used in those patients, so they can be, you know, there we can avoid RT.
Have to wait for the Loris and Comet. Patience.
Okay, now, my question is, if you have a papillary lesion on ultrasound, which seemed to be the case in the first patient, it didn't turn out to be, but it seemed to be the case. What would be your initial management? The patient comes to you with an ultrasound, maybe mammo also done. Ultrasound is showing a papillary lesion. What is your first management for that patient? First investigation. So basically, I want to just highlight that our pathologists don't want a true cut, definitely don't want a true cut on a papillary lesion or a solid cystic lesion. They are wary of reporting even on VAP because they say the morphology gets distorted. They prefer, they are very happy if we excise them, widely excise them and send it, the whole specimen is sent. So that's how it is, and I guess most of us are practicing that. Ma'am, you have a different opinion or?
Mentioning are possibly you're talking of dilated retroareolar duct with a papilloma, 95% being benign, 5% being malignant, but you need to excise it.
Yes.
So I agree with you. I would like to do a good excision surgically than doing a VAB. Actually, Jyoti prefers doing VAB on these, excising the whole thing. But I think a good surgery and a good pathology
Is
would
very
be in
important.
order. I mean, these are retroareolar papillomas, right?
Yes,
Not-
most of them turn out to be papillomas.
Dr. Kabra, one more thing I think we should have discussed in the second patient, especially. The second patient had a non-palpable, non-mammo detectable lesion.
No, it was detected on mammo.
It was mammo detected. It was not seen on ultrasound.
Yes.
So, and we do a biopsy and it turns out to be a DCIS. Are we sure that she doesn't have an invasive breast cancer, which is not detectable at the present
Exactly,
investigations
absolutely
that she
right.
had?
That's why I said the upgradation rate of
Yes.
only a true cut is much higher as compared to a VAP.
So it would probably not be very safe to advise her not to have RT unless she opts for a mastectomy.
No. We
RT
have-
will be given
Sorry,
only
sorry.
after we have
No,
excised the
oh, You're
lesion.
saying that it is not a true cut biopsy. It is a wide excision biopsy. We have a margin clear. We have no other microcalcification anywhere else.
Yeah, but
I think
what
we have-
about multicentric disease?
No, it's not there. Right
It's
now,
not
it's not
multicentric.
there. We have done MRI also, so we don't have a proof to say that we should go for mastectomy. Not for this patient. That in my opinion would be an overkill.
Did these patients end up with radiation in your center, both of them?
First one, second one, yes. First one still deciding. Recently operated. Both of them operated a month ago.
First one, she's ERPR is just 10%. I think she must go
She's
for RT
deciding.
in this
She's
case.
deciding. She's deciding. She has met a radiation oncologist, discussed everything, but she's still deciding. Not yet started. So I told her, what I told her, I'll tell you. I told her that you have a very low risk of reoccurrence, but there is an increased risk if you don't take radiation. However, with the kind of histology you have, if you are not keen, you can avoid it. The rest, I said, you please discuss with the radiation oncologist and take a call.
Madam radiation oncologist, as per NCCN guidelines, second patient doesn't require any radiation. Wide excision is good enough.
And the first one?
First one also, it's a small lesion, wide excision, good enough. NCCN guideline clearly says it doesn't require.
NCCN actually says give radiation to all DCIS. It says give radiation to all DCIS.
If not adequately excised.
It has mentioned certain exceptions, yes, in the text. But as far as guidelines go, they say radiate all. Anyways, we move on to our third patient. Is a 31-year-old premenopausal unmarried Iraqi lady. Had a excision of a breast lump, lower outer quadrant of the right breast in 2019, fibroadenoma. She didn't have any slide or block available, so we don't know what it was, but we presume that it is fibroadenoma. In May 2022, she presented with a breast lump, which was clinically 3 by 2.5, hard nodular, 9 to 10 o'clock, so adjacent quadrant. And there was another smaller lump inferior to it. Mammo and USG mammo showed very dense breast, but a lesion was seen in upper outer quadrant, which was highly suspicious. And she's very keen on breast conservation. Does the panel agree that if we have to conserve, there are two lumps palpable, at least one seen, and ultrasound, both are seen? Do we move with MRI if we are to offer conservation, or you feel that conservation should not be offered at all at this stage?
I think the second lump is very close.
So anyways, first, those who feel that conservation can be done. Okay, so everybody feels. So we do MRI or we move ahead with this dense breast and ultrasound? We should do MRI. Okay, fine. So this is how the clinical picture look like. I just marked the lumps. There are two lumps, and that scar also you can see just below that, which was a previous scar of fibroadenoma excision. MRI was done, showed two lesions. The largest one was 2.6 centimeter. There were few sub-centimeter nodes, but looking normal on MRI. And true cut biopsy was ERPR strongly positive and HER2 positive on FISH. IHC was equivocal. What would be your management? Or you need PET CT or you don't need PET CT? Dr. Manisha, you wanted
I
to
would
raise this
be-
question of PET
I
CT.
would be comfortable without a PET CT. This is the largest size of the lesion is 2 centimeter, 2.5 centimeter.
5, yes.
So PET CT wouldn't be recommended, but most of these patients would come to me already a PET CT with a PET CT being done by somebody or other. So, but I would be comfortable if it has not been done. I would be comfortable with without a PET CT. C can be conserved, and obviously the true cut biopsy has already been done.
Okay,
If
so-
I can take it out, as you showed the picture, I can take it out with a single incision. I think C would be a good candidate for breast conservation, and probably would require some, because he's 31-year-old with a dense breast, maybe would require a level 1 oncoplasty.
So we did end up doing a PET CT. This is how it was. The MRI also is showing the upper and the lower pictures are showing the two lesions which were adjacent to each other. Now, what are the treatment options? These are the 4 options that I can think of, and each one of you please select one and let us know. Maybe we can start from this side now, Dr. Satyam.
Patient is ERPR positive, triple negative.
No, HER2 negative, triple positive.
Triple positive.
HER2 positive, triple positive. I
Triple
said.
positive.
All 3 positive, ERPR strong, HER2 positive. She has 2 lesions. The largest one is 2.6. Nodes on ultrasound, mammogram, or sorry, and MRI, PET scan, everything is okay.
You told one of the lesions was pyrite 1.
No,
Sorry, that is
no, no. That was something else on the other side.
I'll be offering upfront BCS plus oncoplasty.
Okay, so BCS with oncoplasty, Dr. Ajit.
Yeah, so patient, I think from Iraq, and I don't think so she would be having insurance. So offering
No,
new
that we are
adjuvant-
presuming. That we are presuming.
No,
Please don't
so
presume right
unless,
now.
unless patient has money to pay for
So let us
trastuzumab later
go
on.
by guidelines right
So,
now. Or,
so we have to discuss with the patient. If the patient is not willing for that, at either adjuvant trastuzumab emtansine, then obviously upfront surgery would be feasible.
And if she is willing?
Better. If she is willing, then definitely HER2 we
And we
will
will
have
have
to. Yeah, yeah.
Okay.
She's HER2 positive.
Yes.
So, and T2 lesions. So NCCN these days recommend
Early
that,
T2.
yeah, even T2 lesions should be, they should consider for this thing, new adjuvant chemotherapy, followed by BCS.
So considering that there are 2 lesions and that there is an adjacent scar, to give good cosmesis, it would be better to go for NACT followed by BCS and oncoplasty.
Okay.
So the patient was keen for a conservation. So definitely the first 2 options are out, I would say, for mastectomy. This patient will
No,
be,
patient may be keen for conservation, but you feel it is not safe for the patient, right?
no, it's feasible for this patient.
Many a times patients are keen, but we can't offer because we feel it is not safe. So that's why I've put those options.
So it would be feasible as per my understanding of the images. This patient will definitely need chemotherapy. If we can give neoadjuvant chemotherapy, that will be my first preference. But if,
And the reason for giving new adjuvant is?
because it's HER2 positive disease and she's a young patient.
Okay.
If for some reason she's not keen for a neoadjuvant chemotherapy, then upfront surgery, BCS is also feasible for this patient, I feel.
Okay.
It has been seen that the HER2 positive and triple negative breast cancers, they respond very well to the chemotherapies upfront. And PCR can be an indicator of long-term survival. So even the early lesions T2 and NEC and plus are considered for neoadjuvant chemotherapies these days.
I think upfront surgery in the form of conservation should be a good option because I mean, patient is operable and you can very well do a conservation. Why should you start chemotherapy neoadjuvant first? I think, Dr. Shyam, what will you do in this patient? Will you offer neoadjuvant?
I'll ask them later. Let the two people finish.
See, let's make the thing simple, you know.
Let the panel finish. I'll ask them definitely this question.
So surgery first, of course, remove it and do a good reconstruction, then send within a 3 to 4 weeks to surgeon.
2 surgeries and 3 NSCTs, 1 plus minus depending on the affordability, right? No, we are not discussing affordability here right now. Yes. No, because he said if the patient can afford trastuzumab, I would prefer neoadjuvant.
I think NSCT should be offered, followed by BCS plus oncoplasty, and it would also require preoperative placement also for localization.
That's a very good point. Placement for both the lesions.
Yes.
Both the lesions.
I already gave my opinion.
No, you didn't.
BCS, yes.
No, acha, okay. BCS, but upfront BCS or after NSCT?
Upfront BCS.
Okay, can I ask the house to raise hand for upfront surgery? Very few. Only surgeons are raising. Only surgeons.
No, I think Vedant, she is 31. She is HER2 positive.
Yes, sir.
There are 2 lesions. One lesion is 2.6 centimeter. The other lesion is also very nearby. So actually the total area of abnormality is almost 4 centimeter. I think this patient should be given NSCT plus targeted therapy. We clip both the lesions and then we later on, whatever she opts, whether BCS or mastectomy. But I think this patient from today's guidelines, HER2 positive disease more than 2 centimeter, this patient fits in for neoadjuvant treatment. Whether she can afford dual block, whether she can afford single block, that's a matter of economics, that Herceptin plus pertuzumab or Herceptin alone. But these patients should be given neoadjuvant therapy followed by surgery.
So you said that it's a total area of around 4 centimeters. Now suppose this was only single lesion, upper outer quadrant.
Correct.
So yes, you did answer your question later on.
Can I think one of the MRI said it's 1.8. So do you take 1.8 or 2.3? And the Sara Tulane, Dr. Agarwal can correct me, Sara Tulane paper of de-escalating the hormonal treatment, the anti-HER2 treatment with just Taxol alone for lesions less than 3 centimeter. You can de-escalate rather than giving TCH or AC followed by say. So if the lesion is 2 centimeter and less than 2, solitary lesion. If there are 10 solitary lesions of less than 2, it's T1, it's not T2. So to my mind, upfront surgery, no lymph node involvement, upfront surgery, laterally placed, so easy to excise.
Ma'am, it's T2 and it is not solitary.
One of the MRI is 1.8.
26 mm.
If it's more than 2, yes, you can give her neoadjuvant chemo, but it's less than
Not
2,
much time left.
you can
Maybe
de-escalate.
one medical oncologist also. They haven't. Okay, Dr. Randeep.
Ma'am is right. Sara Tulane's paper APT trial was 3 centimeter inclusion, but ma'am, the fine print is that only 7% of the patients were 2 to 3 centimeter. 93% of the patients were 2 centimeter. So that's why the data has evolved in that way. Coming to the comment of whether we give NSCT or why we give NSCT is in a HR positive 2 to 3 centimeter lesion. Node negative is that we tend to achieve past CR, and we believe that if we achieve past CR, we will achieve at least at 10-12% DFS. And if we are not able to achieve past CR and we add Catherine data, that is the adjuvant CATSALA, we achieve another 11% DFS. I can't comment about OS, but yes, we do feel that if we are escalating the therapy bit by bit, we may be able to achieve 15 to 20% of invasive disease survival
I
advantage.
agree with you. This is something which has to be considered, but at the same time, when you are using asking for either pertuzumab or TDM1, then definitely question of affordability would come for large number of our patients. And if a patient is not able to afford TDM1, then I really don't know whether we are offering any advantage.
We are talking about disease-free survival.
That's what I said.
So that's
Dr.
another
Rajiv
question you need
accepted
to-
that only DFS is improving. He has said that. Right, so I also
Dr.
wanted
Vedant,
to.
any role of Ki-67 in deciding it, which you have not mentioned in the biopsy?
No, I don't think I'll decide based on that. So I also wanted to discuss fertility preservation, but I don't think we have time. Just wanted to say that for such younger ladies who are either unmarried or married but nulliparous, desirous of having a child, we must discuss this. Whether they express it or not, we should bring it up ourselves. There is one more very quickly. Can I just go through this, Dr. Paul? 2 minutes? Okay, this is a young lady had an ultrasound in January, was told that it is all okay, you go back. In April, another ultrasound shows an irregular lesion, 2 centimeters. There's no family history. Rucut biopsy was done outside before doing anything else, which was IDCA grade 1, ERPR strongly positive, HER2 negative, and a reasonably low KI. Mammo was done when she came to us, and this is the mammo, which is dense. So we did MRI as well, which was showing a solitary lesion. Again, I've put role of PET here, but I think we have discussed, so I'm not going to go there. Normal looking notes, just one more minute. Yes, now what is your opinion, surgeons? Upfront surgery. Now this lady has a very small breast. It's a largish lesion, would require some amount of skin also to be sacrificed. Upfront surgery, and obviously she wants BCS, which she's suitable for. Upfront BCS versus neoadjuvant. If neoadjuvant, then what? Chemo or hormone? Upfront. So yes, so there was a dimpling, no puckering, I would say. There was a dimpling because there is a large area of the tumor which was pulling the breast. No skin involvement. Skin was not involved anywhere. You would prefer neoadjuvant?
Upfront BCS with oncoplasty.
With oncoplasty. So neoadjuvant hormone or chemo? Chemo. She is ERPR strong positive, HER2 negative, KI low, may not respond very well to chemo. Dr. Shefali is smiling. Dr. Shefali, please. What is the percentage of very good response that she will achieve BCS according to Dr. Shubham? Shubham's satisfaction.
I mean, in these high risk subgroups where it is TNBC or HER2, I mean, DFS can be taken as a very well accepted
No,
surrogate
we are not
marker.
discussing that, please. Sorry, I don't have time about this patient.
All right. So can you repeat that question, please?
This is a 2 centimeter lesion, 2.6
Yeah.
centimeter.
Yeah.
Which is strong hormone positive, KI low, HER2 negative, grade
Yeah.
1.
Yeah.
Everybody wants to operate for
Hormone positive?
oncoplasty because it is a small breast and she would definitely need almost a quadrant will go.
Right.
But Dr. Shubham says that I want to give neoadjuvant chemotherapy.
Right.
My question is, what are the chances that this is going to so significantly decrease that a big oncoplasty?
So in strong hormone positive, if you wish to achieve a PAT-CR in a hormone positive, so it is not very common. So it's to the tune of say 18 to 20%.
And
only,
even
not more than that.
K67 is low, so they're not going to respond
The
that well
problem
to
here
the
is
chemotherapy.
I said breast size is very small. So even if you achieve some kind of response, you will end up using a volume
Yeah.
replacement. not
In
just-
a hormone positive, or for that matter, till now in every. Yeah. Yeah, absolutely. So PAT-CR and hormone positive is not more than 15 to.
So anyways, we finally did surgery first with a TDAP, and this is the
surgery
photographs.
first.
Sentinel node, I'm not discussing it because it has already been discussed and debated also. Thank you very much. Thank you very much, all the panelists.
Thank you, Dr. Kabra. Thank you, panelists, for a great discussion. I would like to call Dr. Vaishali Zambre, Senior Consultant Surgical Oncologist, Max Super Specialty Hospital, Ghaziabad.
Very good afternoon to all my seniors and my dear friends. At the outset, I would like to thank Dr. Shyam Agarwal sir and the organizing team for this opportunity. My mandate for today is comparative flaps for breast reconstruction. I'm an oncoplastic breast surgeon, so I'm going to talk only about partial breast reconstruction by using perforator flaps. So at the outset, I would like to discuss why perforator flaps are actually needed in the armamentarium of an oncoplastic breast surgeon. We all know that breast conservation surgery in a suitably selected patients actually offers better cosmetic outcome and equivalent survival as well as good quality of life. We know that for achieving good cosmetic outcome, we need to use breast volume displacement or replacement techniques. And in small to moderate breasts with larger tumors, sometimes we are at a loss to use some volume replacement therapy, volume replacement technique. So far, for last many years, LD flap has been a workhorse for volume replacement in such patients with small to moderate breasts and larger tumors. Later on, we started using mini LD. However, with the use of LD flap and mini LD, there used to be a significant morbidity and loss of muscle function. At the same time, with the better understanding of the anatomy of the intercostal vessels, the plastic surgeons actually evolved the muscle sparing flaps, and these flaps then were incorporated into the armamentarium of an oncoplastic surgeon with the aim of reducing donor site morbidity and better aesthetic outcome. So what is a perforator flap? It is a flap, it is an island of tissue which is consisting of skin and subcutaneous tissue which is perfused by an isolated artery and a vein which perforates the deep tissues, that is either a muscle or a fascia. And the perforator flaps are actually named after the source vessels. We have seen that the perforator flaps have actually evolved from the random pattern flaps which were pioneered in the late 20th century, which then were converted into or were adapted in the form of musculocutaneous flaps and fasciocutaneous flaps. However, till the later part of the 20th century, till we could not understand the vascular anatomy of the flap, there used to be many flap failures. And as a result, when the perforator technique or the concept evolved, perforator flaps were actually devised, and these were incorporated into the oncoplastic breast techniques. It was realized that there were many perforators in and around the periphery of the breast which could be utilized for developing these perforator flaps and for replacing the volume lost after tumor resection in breast. So in the early part of 21st century, there was a conference in Ghent which was actually based on the perforator technology, and it was the perforators were classified into 5 different types based on their whether they are perforating the fascia or whether they are perforating the muscle and then reaching the skin, or whether they are perforating the intermuscular septum. So the perforator flaps are based on mainly the angiosome and perforasome theory. So an angiosome is a territory of tissue supplied by a common source artery, and among these angiosomes, a perforasome is a very special tissue which is actually a unique vascular region supplied by a single perforator. And now we'll see how these perforator flaps are used in breast surgery. These breast perforator flaps are used in multiple ways, either for reconstruction of after BCS, the partial breast defects can be reconstructed, or after mastectomy for breast reconstruction, either alone or with the help of a implant. And again, for correction of post BCS deformities, these perforator flaps are very useful. So either they can be used in the form of a free flap especially for post mastectomy breast reconstruction, or in the form of pedicle flap, which is the commonest way the perforator flaps are used in today's times, and propeller flap when we need to replace the skin and we want the flap to be mobilized at a distance. The pedicle of the perforator flap is actually skeletonized and can be used at a distance from the source or the donor area. So for partial breast reconstruction, many flaps have been actually devised, and the commonest flaps which are actually used in today's times for partial breast reconstruction are the intercostal artery perforator flaps. These flaps have been actually first described for the use of partial breast reconstruction by Mustafa Hamdi et al. Now let us see how these perforated flaps are actually selected for reconstruction. It all depends on the breast tumor ratio, and the most important thing is location of the tumor. So whether the tumor is located in the lateral quadrant or medial quadrant or inferior quadrant of the breast, the choice of perforated flap actually varies. So TDAP flap is actually utilized or is useful for most of the quadrants, excluding the upper or extreme medial quadrants. Then for lateral quadrants and the lower pole tumors, the LICAP and the LTAP flaps are used. And for medial and inferior quadrant tumors, either anterior intercostal artery perforated flap or superior epigastric artery perforated flap or medial MICAP, these can be used. There is an overlap of the area which can be covered by these flaps. However, we have to choose the most suitable flap which will have a good reach without any tension at the donor area. So this diagram shows the location of the perforators, as you can see here, and based on the location of the perforators and the location of the tumor, whether the flap will easily reach to that area, the perforator flap is selected. So what are the suitable candidates for perforator flap surgery? Basically, small to medium breasts with larger tumors, and the patients who have either no ptosis or mild ptosis. These are the ideal candidates for selection for perforator flaps. And especially so if there is a loss of more than 20% of the breast volume after resection of the tumor. And the other prerequisite for selecting reconstruction with perforator flap is that the patient should have sufficient laxity of skin either at the lateral or inferior part of the breast, so that the flap can be harvested and the donor area can be primarily closed. So these flaps are suitable for most of the tumor locations based on the location and the availability of the perforator in that area. So what is the pre-operative planning? The most important thing is to do a pre-operative perforator mapping. In case if the patient has a lateral tumor and if the patient has had previous surgery or there is an extensive scarring in the lateral chest wall, then probably the perforators may not be available for flap harvesting. So a pre-operative perforator mapping is very, very important. And for that, a handheld Doppler device is good enough. Usually CT scan is not done on a regular basis, but in case if there is a doubt about the perforator availability, then occasionally CT scan may be required. Then ideally the pre-operative marking should be done 1 day prior, so that we are well prepared to operate on the patient and we do not hesitate or we do not jumble on the surgical planning. Then there are two parts of the pre-operative marking. One is to mark the incision through which the tumor can be easily resected, and the other is to mark the donor area. So both the markings have to be done to get best access to the resection as well as to achieve a best aesthetic result at the end of the surgery. And for marking the flap donor area, the marking should be done in such a way that the donor flap actually reaches the defect in a very convenient manner, and we can achieve primary closure without any tension in the donor area. And of course, the donor area aesthetic result is also equally important. Most of these patients can be actually treated or operated upon by placing the patient on OR table in a supine position, except for some cases wherein a long TDAP flap is required, where after the resection of the tumor, the patients may have to be turned into a lateral decubitus position. Otherwise, a supine position with a pillow under the shoulder and abducted arm is good enough for harvesting these flaps. So I'll talk in detail about intercostal artery perforators. These intercostal artery perforators are the branches of posterior and anterior intercostal arteries, and they form an arcade between the aorta posteriorly as well as the internal mammary artery anteriorly. And this arcade is divided into vertebral, costal and muscular segments, and these perforators actually arise from dorsal and vertebral, costal or muscular segments, which can be utilized for development of these flaps. Let us talk about LICAP flap. LICAP is the lateral intercostal artery perforator flap. Is suitable for again small to moderate non-ptotic breasts and suitable for laterally placed tumors, especially from 1 to 4 o'clock position or 1 to 5 o'clock position on left side and from 5 o'clock to 11 o'clock position on the right side. Again, sufficient lateral chest wall laxity is important. If a large flap is designed with a good perforator, then the LICAP flap is actually able to replace nearly 50% of the breast volume. However, in majority of the patient, this is not required. In case if the tumor is large, then usually we either tend to use neoadjuvant chemotherapy or some other technique is actually utilized. These LICAP flap perforators are actually easy to locate and they are of good caliber. And the other advantage is that the donor scar, although it is long sometimes, but it can be very well hidden under the bra line. It's a fasciocutaneous flap and is based on perforating branches of costal segment of lateral intercostal arteries. However, the pedicle length is short. It is only 3 to 4 centimeter, and that too when you are actually properly, dissecting the perforators. And that is the reason the reach of the flap is not very large compared to the LTAP flap. So, and these perforators are actually located from the anterior border of the LT vessel at the distance of 2.6 to 3.4 centimeter. And there is, in most of the patient, there is a dominant perforator which is found in the 4 to 8 space, which actually communicates with the thoracodorsal or serratus anterior vessels. So these are the some of the cases which I had operated along with my colleague, and there are other cases which have been actually taken from the internet. For inserting the LICAP flap, whether you are you need the skin to be replaced or not, it depends on that whether you are actually utilizing this as a propeller flap where you skeletonize the perforator and increase the reach, or whether the defect is very close to the donor area wherein you can just flip the flap into the donor defect where probably you may not require to skeletonize the perforator. Then there is a modification of LICAP flap which has been actually suggested by Maybody et al. Which the flap orientation is in a vertically oblique manner so that a transverse long scar can be avoided, and from the superior aspect of the scar, you can access the axilla, and from the anterior aspect, you can access the laterally placed tumors. So again, a very good modification and suitable for patients who are in the lateral quadrant. These are some of the examples. Then MICAP is again located in the medial aspect of the breast. Easy to locate, consistent perforator location, good caliber vessels, and suitable for tumor locations in the medial aspect. Another example, again, MICAP has been used to replace the large tumors in the inferior quadrant with the skin replacement as well. This is pre and post-op. Again, MICAP skin replacement can be very well achieved. Then anterior intercostal artery perforator flap suitable for inferior pole tumors located between 5 to 7 o'clock position. The perforators are located around the 6 o'clock position below IMF. Pedicle length is limited. However, they can be actually flipped or folded into the defect situated in the inferior quadrant. In both MICAP and ICAP, you need to recreate the internal inframammary fold. Scar can be very well hidden under the inframammary fold. These are some of the examples. Then post BCS deformity can be very well corrected by using ICAP, as this can be shown in this picture. Then lateral thoracic artery perforator flap, suitable for again moderate to small size breast. Lateral defects can be used in combination with LICAP. However, sometimes in nearly 25% of the patients, the perforators may be inconsistent, and you should always have a plan B in case if you do not find the perforator. And they are actually useful in combination with LICAP for replacement of a large resection volume. These are actually larger caliber vessels compared to the LICAP vessels and have more flexibility and wider reach. Again, a picture showing lateral thoracic perforator flap. Advantages, they actually, because of the larger caliber, and you can actually replace a large volume of tissue, as you can see here. Then TDAP is a thoracic dorsal artery, has two branches, and both branches give multiple perforators. And because of these multiple perforators, the flap can be harvested either horizontally or longitudinally or in a bilobe fashion. And it can be harvested with a large skin paddle of around 14 into 25 centimeter. And if the perforators can be dissected to the source, then the pedicle length can be achieved to 14 to 18 centimeters. And as a result of that, these flaps are actually suitable for all the locations except for maybe extreme medial locations. Again, these are some of the examples. So TDAP is an actually alternative to latissimus dorsi flap. And because LD muscle is spared, it leads to less morbidity, muscle is spared, reaches all quadrants. However, it is technically challenging and you have to be very, very careful while dissecting the pedicle through the muscle. So these are other flaps. I'm not going to talk about the post-mastectomy. So to conclude, I would like to say that perforator flaps are very much here to stay in the oncoplastic breast surgery surgeons' armamentarium. They have less donor site morbidity, less seroma, less contour deformity, and faster recovery. Because the muscle is not utilized, there is preservation of muscle function, and they have reliable blood supply, and they can be actually filled with breast-like tissue, skin island also can be replaced. And the most important thing is does not lead to asymmetry. So because of the use of perforator flaps, we do not need to do any contralateral symmetrization procedure. Although the scars are long, but over the time they fade and they are very well accepted. With this, I would like to thank you. In case if there are no questions, we can move on.
Thank you, Dr. Zambre, for an interesting talk. For the next presentation, I would like to invite Dr. Shefali Sardana, Consultant Medical Oncologist, Max Super Specialty Hospital, New Delhi.
Good evening, everyone. And I would like to thank Shyam sir for giving me this opportunity to present this topic. So I'll be discussing on role of immune checkpoint inhibitors and chemo in neoadjuvant TNBC. So we know that triple negative breast cancers contribute to 30% of all invasive cancers, and this is the Association of Surgeons 2020 data. And the incidence of triple negative breast cancer was higher in patients who are younger, premenopausal, as compared to the age group of 35 to 70 years. And globally also TNBC accounts for 10 to 20% of all breast cancers. Majority of TNBC we know are basal-like or claudin low. So they have a genetic heterogeneity and their patterns of gene expression are heterogeneous. Given the lack of effective treatments in this type of breast cancer, so there are several trials, several efforts have been made in recent years to increase the therapeutic approaches for TNBC patients. So if we see the survival data, so the rates drastically drop for TNBCs if stage by stage comparison is made. And if caught early, a patient has approximately 60% chance of surviving 5 years. So earlier, the diagnosis is very important. Patients with triple negative subtype, they are younger, they are premenopausal in majority of the groups, and the higher proportion of TNBC, they present in locally advanced stage, and they have a high proportion of more positive patients as compared to the non-TNBC counterparts. So I think it may not be clearly visible. So this was the profile of triple negative patients in India, and they clearly showed that most of the patients presented in LABC and they were younger and premenopausal subgroups. So now if we talk about the role of NACT in breast cancer basically. So the dictum holds on to downstage the tumor actually. So we use NACT in breast cancer. However, there are certain high risk subsets like TNBCs and HER2 positive where we literally somewhat expand this criteria. And chemotherapy, as we know in TNBC, for that matter, neoadjuvant or adjuvant is recommended in women with TNBCs more than 0.5 centimeter or with no positive, regardless of the tumor size. Because these patients have higher risk of relapse as compared with other breast cancer subtypes, and they are not candidates for other form of targeted therapy as well. So for these patients receiving NACT, PCR is associated with actually improvement in DFS. And like we were discussing in previous panel discussion also, in these high-risk subsets, DFS is actually seen as a surrogate markers for improvement in survival. Though absolute advantage in overall survival is yet to be seen in these subgroups who receive NACT with or without any targeted or IO agents, but DFS is important marker which has been seen associated with whether we incorporate neoadjuvant carboplatin in these subgroups or neoadjuvant immunotherapy. And additionally, one important factor in TNBC is, so early TNBC may often be neoadjuvant chemotherapy, particularly if we think that there might be candidates where additional treatments like adjuvant capecitabine and other things would make a difference in actually overall survival. So till date, anthracycline or alkylating agents, taxane-based chemotherapy regimens, they remain the standard of care regimens in NACT and TNBC. However, some non-anthracycline-based regimens are an appropriate alternative for patients with lower risk TNBC, like node negative, less than 1 centimeter, or where we tend to intentionally avoid anthracyclines like cardiac risk factors, and those who prefer to avoid risks associated with anthracyclines. So where does the role of carboplatin stands in neoadjuvant setting in TNBC? So there are basically 3 large randomized trials and where some phase 2 trials also which address this issue, and they have certainly shown that PCR rates are better, are improved when we add carboplatin to the neoadjuvant chemotherapy armamentarium in TNBCs. To mention or highlight a couple of them, so this was GPAR 6-2 trial which actually saw the survival analysis of carboplatin added to an anthracycline taxane-based NACT, and they also finally saw that subset if HRD score was a predictor of response in these subgroups. So what they did was they gave paclitaxel plus non-pegylated liposomal doxorubicin and add on carboplatin as the experimental arm. The secondary study endpoint included DFS and OS, apart for the primary endpoint of PCR also. And they also tried to look into whether HRD or homologous recombinant deficiency was defined, whether it made a difference in the carboplatin receiving group or non-receiving group. And they defined HRD as HRD score of 42 as a positive, 42 or more as a positive versus less than 42 as a negative HRD scoring. And they saw that there was significantly better DFS with a better hazard ratio of 0.56 in patients with TNBC who received carboplatin as the neoadjuvant arm. HR deficiency was detected in approximately 71% of the patients of TNBC, and out of which 60% showed a high HRD scoring, where tumor-mutated BRCA was not seen actually. And adding carboplatin to the arm actually made a difference in increase in PCR rate from say 34% to 65%, especially the HR deficient. However, it was seen that adding carboplatin actually made a difference in non-HRD high score patients also. So DFS rates were improved with addition of carboplatin in both of the groups. The quantum of benefit was more in HRD deficient patients rather than non-HRD. So this study concluded that addition of carboplatin to neoadjuvant arm improved DFS, which was significantly better in TNBC. Long-term survival analysis, though, support the neoadjuvant use of carboplatin. However, we have yet to decide DFS as a surrogate marker for that end. HR deficiency in TNBC and HRD score in non-tumor mutated BRCA are predictors of response. However, the response does not depend upon the HRD scoring actually. So now another study, though this study, which was GPAR OCTO trial, the primary endpoint was not exactly to see the quantum of benefit with carboplatin. The primary intent was to see whether the dose intensity or dose density could help this TNBC subset to improve the DFS or the PCR rates. and they used dose-dense epirubicin, paclitaxel, and cyclophosphamide versus weekly regimen of Pacli and Lipodox add-on carboplatin in TNBC cohort. So they included, this trial actually saw the addition of the chemotherapy arms in basically high-risk group, be it HER2 positive or the TNBC, and HER2 positive patients additionally received the anti-HER2 regimen also. So as you can see in TNBC cohort, basically the HER2 negative and hormone negative, so the dose intensity and density does not matter actually to achieve that PCR. However, numerically, the patients who received carboplatin had a better PCR rate in this trial also. So this also concluded that in high-risk early breast cancer, the dose intensity does not matter actually, and dose intensity is one of the effective and feasibly given regimen in these patients. So if I summarize carboplatin in NACT, so there are 3 randomized trials which showed that improved PCR rates with the addition of carboplatin to taxane and anthracycline NACT, while none of these studies were designed for definitive determination of impact of carboplatin on long-term outcomes. So 2 have reported improvements in event-free survival or DFS with addition of platinum. There are no randomized trials which have directly compared 3 weekly versus the weekly carboplatin. So still unanswerable question whether we should use platinum weekly or a 3 weekly regimen. So in clinical trials, while both germline BRCA mutated or BRCA wild type, TNBCs were more likely to achieve a PCR with addition of carboplatin in NACT. However, the BRCA-ness or the BRCA mutation, the quantum of benefit is much larger. The magnitude of improvement in EFS with addition of carboplatin actually did not differ between both of the subgroups. But however, small number of these BRCA mutation carriers and the limitation in study designs, I mean, they do not give us confidence to conclude in this armamentarium. Now coming to role of immune checkpoint inhibitor in TNBCs. So there are various trials which have tried to look into this question, and to mention or highlight them is Keynote 522, which included pembrolizumab, and IMpassion 031, which saw the effect of Atizo, and GPAR NUMO, which saw actually addition of durvalumab did make a difference or not. So if we see the rationale, we know there are increased predictors of response to IO and TNBC, basically the tumor infiltrating lymphocytes, the higher expression of PD-L1 and higher tumor mutational burden in these subgroups. Now, this is very important to understand that the companion diagnostic test with each of the immune checkpoint inhibitors is different. So the results are expressed in terms of CPS in pembrolizumab or IC scoring in Atizo. So we need to understand that the simultaneous companion diagnostic test should be used when we are deciding for one or the other immune checkpoint inhibitors. So this trial was actually I-SPY 2, which tried to assess whether the addition of novel therapies like immune checkpoint inhibitors did make a difference in different cohorts with the addition of these targeted agents along with chemo in the NACT arm. So this trial concluded that the patients who, this trial gave actually 2 good messages, that the patients who actually achieved a PCR, they had a good EFS, irrespective of whatever the regimen was used in the NACT arm, and the patients who did receive IO along with chemo, they did even better, even if they did not have that PCR in that arm. So they did better as compared to the control arm. So a number of studies have investigated this impact of addition of IO agents to NACT on PCR rates in HER2 negative breast cancer. However, till date, only Pembro has concluded in a phase 3 study, which has shown a long-term benefit and has received a regulatory approval in this setting. Other agents still are in the investigational setting. So important highlights for 2 of the trials I'll mention. One is Keynote 522. Keynote 522 was basically including the T1C node positive or T2 to T4, any node positive TNBC who were good performance status. They were also evaluated for the PD-L1 expression, and they received the standard of care neoadjuvant chemotherapy, but along with carboplatin. So Pembro was given in the first phase of neoadjuvant with carbo and taxane, followed by the second phase of neoadjuvant with AC and Pembro. Then patient was forwarded to the surgery arm in case of a good response, and Followed by that, they received pembrolizumab in the adjuvant setting for remaining 9 cycles. And the control arm did not include pembrolizumab as an inclusion. Otherwise, the arm was same regimen. And the primary endpoint was PCR, and secondary endpoints were PCR and PFS, of course. This slide shows actually that patients were, at par balanced in both of the subgroups, with majority of patients pre-menopausal, younger, as we see in the TNBC cohort. And this trial also concluded that the quantum of benefit in terms of PCR was more in patients who received pembrolizumab. And though the difference was a little more skewed in favor of the PD-L1 expressor, however, the PCR rate was increased even in the non-PD-L expressors also. So PD-L1 more than 10% versus, less than 10% did not affect the PCR achievement. However, the quantum was different. So this was 18 months PFS, which showed that pembro group fairly did well. We have updated analysis of the result also, say after 37 months, which is still showing a benefit favored in terms of PFS in pembro arm. So, this trial concluded that this is the updated result which I highlighted, and the absolute PFS benefit with addition of pembro was more actually in the NACT arm. The node negative patients had superior outcomes compared with the node negative, compared with the node positive patients, and the magnitude of benefit of adding pembro was similar in terms of distant recurrence-free survival, while there was also numerical, but it was not a statistically significant improvement in OS. Adverse event, we know, immune checkpoint inhibitors, there was nothing new add-on in this trial. And, but this trial actually left us with few of the important questions. Should pembro be continued in the adjuvant setting in patients who actually achieved the PCR? Should adjuvant pembro be administered concurrently with other adjuvant therapy regimens where they did not include a platinum or anthracycline? Will the addition of pembro also improve outcomes if patients treated with a different NACT regimen? And if suppose somebody has already started, can we add on pembro in the second or third cycle? Or if somebody has not received it in NACT, what is the quantum of benefit in the adjuvant setting? Similarly, IM PASSION, the trial schema was more or less same. Atezolizumab add on to the standard AC followed by taxane arm followed by surgery and adjuvant, and the primary endpoint was PCR and the key secondary endpoint was PFS. This trial also again highlighted there was a quantum of difference with the addition of IO to the NACT arm, and the patient achieved more PCR when IO was added. And it was also irrespective of the PD-L1 positive versus negative, though quantum of benefit was more in PD-L1 positive. So similar conclusion. Another study to highlight is GPAR-NEO, which included durvalumab. However, the important point in this trial was patient did not receive adjuvant IO in this setting. So this study failed to show that PCR was better in terms of when patient achieved IO. And also one study to mention is NeoTrip PD-L1 study where atezo was used in the neoadjuvant setting. This study also failed to show that there was increased PCR rate when IO was added. However, they concluded that it was not the primary endpoint. Primary endpoint was to see the EFS, which is still awaited. The data is still immature. So if I conclude, so the status of IO is, not very much clear in terms of the long-term outcomes. Though if we take PCR as a surrogate marker of the, say, DFS and the OS in the long term, adding IO and for that matter carboplatin did make a difference. So my take would be to add on IO in a NACT regimen in TNBC high-risk patients where we see that it can make a difference in achieving a PCR and then leading on to advantage in DFS. In TNBC, testing we do for our sake for the gain of confidence or not, but however it does not alter the decision.
Thank you, Dr. Sardana, for an interesting talk. For the next talk, I would like to invite Dr. Kapil Sundhi, Radiation Oncologist, Department of Radiotherapy, Safdarjung Hospital, and Dr. Nova Gupta, Consultant Medical Oncologist, Tyndall Hospital and Cancer Center, Palwani. And I apologize for not inviting you earlier, sir.
Well, I'm Dr. Kapil Suri. I'm a professor and radiation oncologist at BMMC South Asian Hospital. And I think we invite the next speaker. The next speaker is Dr. Randeep Singh. He's a well-known medical oncologist in Delhi. So, Dr. Randeep, he'll be talking on.
Thank you, chairpersons, and thank you, organizers, Shyam sir and Dr. Paul. The topic which has been assigned to me is actually a difficult topic even for a medical oncologist, and the topic is to justify the role or to place the role of neoadjuvant chemotherapy for a hormone-positive early breast cancer. So let us start with that. How do you define an early breast cancer? Helps us to decide whether you are putting the bar at a node positive as early breast cancer, whether you are taking only less than 2 centimeter as early breast cancer, or you are taking as anything which is 1 to 3 nodes as early breast cancer. So we have to be very clear that how we are defining the early breast cancer. And for this talk, I will keep it as anything which is less than 2 centimeter or anything where the nodes are less than 4 or anything which is N1 as early breast cancer. Before I proceed further, we all have started to recognize an entity called low HER2. And yes, this entity is here to stay and it is a defined entity now. And as you can see on the charts, there will be around 1/4 of our patients in our practice where we now label them as hormone positive HER2 negative. Once we have the TDX like molecules which are there as an approval, there will be 1/4 of our patients who will be following this algorithm and going into a HER2 positive from an ER positive HER2 negative disease. Why neoadjuvant therapy for a hormone positive? Early control of micrometastasis when you have a luminal B disease, and these are two my indications that when I'm thinking of prescribing a neoadjuvant chemotherapy to a patient of a hormone positive HER2 negative disease, making BCS feasible. For example, a 4 centimeter tumor in a small breast lady, trying to achieve a path CR, which may or may not convert into any event-free DFS or OS advantage. Neoadjuvant hormone therapy, and then in the lab, following the dynamics of Ki-67, and then seeing that whether those dynamics help, and this is for purely a research purpose. And I will be very keen to follow the space of a combination of chemoendocrine therapy, which we sometimes do. That is a combination of capecitabine and letrozole, which we sometimes do as a medical oncologist in a metastatic breast cancer patient. To my mind, this is where the neoadjuvant therapy plays a role in ER positive breast cancer. So what are the prognostic and predictive factors? The standard prognostic predictive factors which we follow for TNBCs also plays a role in hormone positive EBC. The size, the grade, the histological subtypes, percentage positivity of ER, whether it is less than, whether it is 1%, 1 to 10%, more than 10%. Ki-67 in the ER positive disease, because we all know that luminal A and luminal B are defined majorly on the basis of Ki-67, and also the genomic signatures, which we always talk about in the adjuvant setting, such as oncotype, MammaPrint, or Canacyst. So whenever you have in an early breast cancer, whenever you have a high grade tumor, grade 3, high Ki-67 more than 14%, weak ERPR, say less than 10%, unfavorable genomic signatures, a luminal B subtype, and all these either 1, 2 or in combination exist, are to my mind the indications where I may consider neoadjuvant chemotherapy. Coming to the Cortazar et al. As well as one big twist, I think we all know these two papers. These are all meta-analysis of neoadjuvant therapy correlating with PathCR. If you concentrate on the one which is in red, you can easily see that the PathCR is also different in a ER positive disease when you have a grade 3 cancer, and that is quite well evident on the red mark that in grade 3 ER positive HER2 negative breast cancer, these may not be early breast cancer, but whenever they have been considered for neoadjuvant, the curves do differ. The second curve down is also the meta-analysis, where you see that in a luminal A subtype, there won't be any difference in pathological CR, but in luminal B, the curves separate not to a major extent, but to some extent like it used to separate in a HER2 or a TNBC. And thus, thinking in the mind that you will not be able to achieve a PATH CR in a hormone positive early breast cancer is a misnomer. You can achieve PATH CR by giving neoadjuvant therapy. Whether they convert into DFS or IDFS, that we don't know. This is a beautiful study. It is a phase 2 study, but a very good proof of concept study. If you see, they have done a biopsy, and on the biopsy, they have sent for a recurrence score, oncotype DX. They have divided the oncotype into less than 11, 11 to 25, and more than 25. And this is what we follow as of today. And on the basis of this, if someone has less than 11 low recurrence score, they have given endocrine therapy, and more than 25 goes on a chemotherapy. Coming to the response rates, if someone has group A, if you concentrate on this, if someone has neoadjuvant hormone therapy recurrence score less than 11, 83.3% of the patients will be able to achieve the response. On the contrary, if you have recurrence score more than 26, then everyone is going on chemotherapy and 92% are achieving response rates. So this slide gives us proof of concept that whether we can incorporate these genomic signatures in our pre-operative setting, we can't do that. And I would love to see that whether we have clinical trials such in much more larger scales to adopt these genetic signatures into pre-operative setting. And once we are able to do that, what we talk about today about TAILORx and MINDAC and RX-Ponder in the adjuvant setting, we wish we can use these cutoffs in the pre-operative setting. And if I have a 30-year-old lady who has a strong hormone positive with 2 node positive, or at least a 3.54 centimeter tumor, and I have data, I would wish to use TAILORx, RX-Ponder and MINDAC in the neoadjuvant setting. So suppose we decide, this was the food for thought that where we can consider pre-operative settings. Now suppose we decide and we agree with in the tumor board that we have to give a pre-operative chemotherapy to this patient. So the question comes what to give and what regimen to follow. This is an age-old gold standard trial that overall survival doesn't improve NSCBP 18. Everyone in this house must have gone through this slide that give you ASC before, followed by surgery, surgery followed by AC. There is no overall survival advantage. Coming to the trial, ABC trial schema, there are multiple trials on this slide. It is not only NSCBP, this is NSCBP 46, 49. The test arm was constant in all these trials. This was 6 cycles of TAC. That is triplet regimen, which we don't use nowadays because of toxicity. The comparison majorly have been anthracycline followed by taxane versus docetaxel and cyclophosphamide TC regimen. And then everyone has received endocrine therapy. Now, if you come to the pre-operative setting and you just concentrate on the hormone positive column, which is the topic of today, if you have a node negative disease, and if you concentrate on the invasive disease-free survival on this chart, these are these 2 values. Giving both anthracycline and taxane achieves a IDFS of 91%, and giving TC achieves 94%. That is because you are able to maintain a very good dose intensity and density with 4 TC. And thus, if I have to consider a node negative patient for an early breast cancer NA neoadjuvant therapy, I wish this data gives me some confidence to give only 4 cycles of TC and can avoid anthracycline, at least for an elderly lady or someone who has a cardiotoxicity. This is an interesting, this was about ACT followed by TC. Second paper is also an interesting paper. This is again a neoadjuvant trial of paclitaxel versus nab-paclitaxel. It is also known as ETNA trial, and there is also another trial of neoadjuvant setting, Pacli versus nab-pacli. If you see the pathological CR, in the complete trial set, it is 22% with nab-pacli and 18% with pacli. 4% difference in pathological CR. In luminal breast cancers, it is another 4% difference in pathological CR. And thus it gives some hint, though the difference in pathological CR is not to the tune of 10%, which we have been used to see. But yes, if someone is using a nab-paclitaxel in the neoadjuvant setting, he has the right to do so. Dose-dense chemotherapy, which is often talked about, we know that it reduces the breast cancer mortality by 4%, as seen on this slide. This is the Lancet 2019 famous EBCG data set of 40,000 patients. And by using a dose-dense chemotherapy, we reduced the breast cancer mortality by 4%. Coming to the breast cancer mortality for ER negative, ER positive, if you concentrate on the right hand side, the ER positive breast cancer mortality is only 2% difference. And thus I feel that subjecting a patient to early breast cancer patient to a hormone positive to a dose-dense chemotherapy is not justified. Now, response adapted therapy, I think there is enough of data set, and a medical oncologist thinks in a triple negative and HER2 positive breast cancer with the mindset of giving a pathological CR and using the response adaptive therapy. Can we do it in a hormone positive disease? For this, we have a CREATE-X trial, where we gave CREATE-X trial had 48% patients who were hormone positive. We gave chemotherapy, pathological CR was achieved. If not achieved, they all went on capecitabine. Concentrating on the curve on the overall survival full analysis set, there is not much difference, but in the triple negative there was difference. So basically, in a hormone positive breast cancer, which was contributing to the overall survival data set, the difference was not there. But when we looked upon triple negative, we saw a difference with a hazard ratio of 0.52 in OS. Thus, in a hormone positive disease, giving adjuvant capecitabine if someone is not able to achieve pathological CR is not justified. The second trial, which is not talked about but presented at 2021 ASCO, is a very good recent proof of concept trial. Here, the patients with hormone positive early breast cancer as well as advanced breast cancer and were subjected to neoadjuvant aromatase inhibitors for 3 months. Then their E67 was studied. So the two as well as recurrence score was used as I suggested earlier. So a static marker of recurrence score was used at the biopsy. 3 months of hormone therapy given, and then a dynamic marker of P67 was used. As P67 less than 10% or a recurrence score less than 25, less than 12 was considered as low risk. That was only endocrine therapy subset, where patients with recurrence score more than 12 achieved a reduction in P67 to 10%, or they were having node negative with recurrence score 0 to 11 was subjected to endocrine therapy alone. The 5-year invasive disease-free survival was remarkably better, whether the recurrence score was 0 to 11 or the recurrence score was more than 12, but the P67 on neoadjuvant hormone therapy reduced to less than 10%. The 5-year IDFS is 93%, which suggests that if we use such adapted mechanisms in our clinical practice, we can reduce the use of neoadjuvant chemotherapy. Also, in the node negative or node positive, you can easily see that a recurrence score 12 to 25 having a remarkable reduction in P67. On the right hand side, there is no difference in the disease-free survival. With this, we also know and we also appreciate this slide that in a post-menopausal, this whole discussion was for a pre-menopausal female. In a post-menopausal female, we are aware that neoadjuvant endocrine therapy can achieve equivalent response rates. It can achieve a response rate of 75%, whether you give chemotherapy such as one of the active regimens of adriamycin and paclitaxel or anastrozole. The response rates are equivalent, and this slide definitely has a meaning in a patient who is having a borderline tolerability of neoadjuvant therapy or is an elderly postmenopausal female. And this is also there in ASCO recommendations. These are, I think, 2021 recommendations. For a postmenopausal female, HR positive neoadjuvant endocrine therapy with an AI may be offered, but for a premenopausal female with an HR positive, HER negative early stage disease, neoadjuvant endocrine therapy should not be routinely offered outside a clinical trial. And I think this slide actually sums up a lot about what I have discussed. Is majorly about premenopausal early breast cancer. Sentinel lymph node biopsy, I think, has been discussed in the debate extensively, and converting CN1, I mean a node positive to node negative after neoadjuvant chemotherapy was a debate in the preceding session. And The two debaters beautifully said that you have to use two agents. You have to follow the axillary ultrasound. You have to remove 3 nodes or more. And you have to use IHC with micromets so that you can adopt sentinel lymph node after NACT. Recommendation about how to follow. I think I have 30 seconds. I will be able to close the talk in 30 seconds. So you have to follow with clinical examination regularly if someone is on neoadjuvant therapy. Whatever baseline imaging was used, mammography, ultrasound, MRI, or loco-regional staging, the same staging has to be adopted and used. So with this, I would like to conclude, and this is my last slide. NACT in an early breast cancer is beneficial for a luminal B breast cancer or a high risk young patient, grade 3, 1 to 3 node positive, more than 2 centimeter size, luminal A breast cancer, as well as these patients can go for BCS. Who needs chemotherapy in N0, N1? We don't know exactly, but I wish that genomic risk score in the preoperative setting, dynamics of Ki67 after exposure to neoadjuvant endocrine therapy as an ADAPT trial, tumor burden with respect to 1 to 3 nodes or T size, but all these are not yet validated for the preoperative setting. In a node negative breast cancer, I would like to use TC, but in a 1 to 3 node positive EBC, I would like to use AC and T in a sequential manner. Yes, there are benefits of achieving BCS, controlling micrometastasis, achieving pathological CR, at least in a luminal B breast cancer. The field is dynamic. The role of BRCA positive breast cancer in a hormone positive. On the other hand, CDK inhibitors combinations, such as the Neo Monarch trial, as well as a concept which conventionally we have been taught that we can't combine chemotherapy and endocrine therapy, are all being explored, and phase 2 data are available as well as phase 3 data are available for CDK inhibitor and hormone therapy, but we have to adopt them in the preoperative setting. Thank you.
Thank you, Dr. Randeep. Thank you, Dr. Randeep, for that wonderful talk. I just have one question.
Sure. Yes, please.
So, in the neoadjuvant setting, we are basically targeting the PCRs. We've seen the NAPTACLI in the HER2 positive, the PCRs are higher, and also in the ER positive patients also, we're seeing the NAPTACLI with the higher PCRs. So, do you think, NAPTACLI should be incorporated more and more in the neoadjuvant setting?
So I have put one trial here. This was Etna trial. There is another trial which I don't remember the name. In both, the pathological CR was better with nab-paclitaxel. But if you see, the difference is around less than 4%. But yes, if you believe this data set, that's why I put it. There are no guidelines to use neoadjuvant paclitaxel, albumin-bound paclitaxel in the preoperative setting. But yes, if someone is using a paclitaxel in the preoperative setting, it is not wrong.
Okay. So any questions from the house? Okay. Thank you, Dr. Randeep. So next, I would like to invite Dr. Professor William. He is the Chief of Hematology and Oncology, Department of Medicine, Professor of Medicine from Northwestern Memorial Hospital, Chicago. It's virtual. It's a virtual session. So can we have the... Sir, could you please unmute yourself?
Hello, my name is Bill Gradisher, Professor of Medicine at Northwestern University in Chicago, and I'm pleased to present this lecture on new standards in HER2-positive early-stage breast cancer. I want to thank the organizers for the opportunity to participate in the symposium. So let's get started, and I think a way of level setting is if you look at some of the guidelines that are widely used both in the United States and around the world, the NCCN guidelines, you can see that in early stage HER2-positive breast cancer, we have a number of different options. And this applies to both the neoadjuvant and adjuvant setting, and we'll talk about both of those settings as we go through the talk. But you can see that there are a number of preferred regimens, the APT regimen with paclitaxel trastuzumab for lower risk disease, TCH and TCHP for patients with higher volume disease. And then, of course, we've now gotten into the era where we look at residual disease and make treatment decisions on whether there is residual disease following preoperative therapy or not. So we'll talk about all of these topics. And then as you scan the slide, you can see there's a number of other options that could be used, although the preferred options for a variety of reasons are what we typically choose. The reason that this space has become so active is because of the evolution of HER2 therapies that have become available over the last 10 years. Every year we seem to get new anti-HER2 therapies, which is great for patients. If you think back to the era before we had trastuzumab, patients with HER2-positive breast cancer and early stage disease were thought to have a poor prognosis. With the introduction of trastuzumab into the pivotal trials that led to its approval, you can see that there was a significant improvement in outcome for patients with HER2-positive breast cancer. Disease-free survival improved significantly. But the other notable thing is that as patients were followed longer, even in these early trials where there was a clear benefit to trastuzumab, there were still about 25% of patients who were developing disease recurrence. So despite the early results showing a very significant improvement in outcome, we still had patients recurring and developing metastatic disease. And this really begged the question of, could we do better? So if you go through some of the early trials, which are outlined here, you can see that with follow-up that varied between 5 and 10 years, if you compare patients with HER2-positive disease treated with trastuzumab to those that did not get trastuzumab, there's a consistent improvement in outcome. And the outcome of these patients starts to look very much the same as those with HER2-negative disease. So whereas in the past, go back 25 years, we would have thought of HER2-positive disease as having a much worse prognosis than other subtypes, with the introduction of HER2-directed therapy, particularly trastuzumab in the early trials, we saw that this was offset. You could make up for that worse prognosis with the use of HER2-directed therapy. Some of the questions that have been asked over the years include whether or not we could shorten the duration of trastuzumab. And as you know, there have been a variety of trials that have either looked at longer durations, like the HERA trial, or shorter durations, which would be particularly relevant to resource-stressed countries. Could we achieve the same results with shorter than a year of HER2-directed therapy? And you can see on this slide a number of those trials that have been presented over the last 5 to 7 years with various size trials asking the question of, is 6 months the same as 12 or even as short as 9 weeks the equivalent to 1 year? And at best we can say that there's no clear evidence that anything shorter than 1 year is equal to 1 year of therapy. Inferiority was not reached, and 1 year of trastuzumab remains the standard, with the exception being that in patients who are not tolerating the drug, which is relatively uncommon, we would discontinue it early. One of the questions that has arisen more recently is whether or not anthracyclines can be avoided. So in a sense, tailoring the therapy appropriately to minimize the side effects. In the early trials, anthracycline-based treatment regimens were commonly employed with trastuzumab but we know the cardiac toxicity is an issue. And as a result, regimens like TCH were developed. And the question became, are you, by substituting a taxane for an anthracycline, are you somehow offsetting the benefit that is seen with the anthracycline? If you look at the BCRG trial shown here, with a long follow-up now, more than a decade. Remember, this was a trial that looked at AC fall by T as the standard treatment arm, no trastuzumab, compared to ACTH, compared to in the final treatment arm, TCH. And if you look at the disease-free survival, particularly between the two treatment arms that contain trastuzumab, there's really no difference. Similarly, overall survival, not difference. And even in the patients with lymph node positive disease, the disease-free survival was identical in the patients who did not receive an anthracycline. So again, outcomes were the same. And as you might predict, with the avoidance of anthracycline, cardiac toxicity was less, as was secondary leukemias. And these are those same data showing in the orange and yellow lines, the ACTH and TCH arm, which are pretty much superimposable. Clearly, the introduction of trastuzumab is better than ACT alone, which is the purple line. So we've had more recent data from the so-called TRAIN trial that looked at patients who received preoperative therapy with chemotherapy and pertuzumab. In this trial, patients were, 2/3 of them were node positive, 40% were hormone receptor negative. And if you look more carefully at the treatment regimens that were used, some of the patients received an anthracycline in the form of FEC, followed by a taxane with trastuzumab, pertuzumab, or there was no anthracycline at all. And if you look at the PCR rate between these two treatment arms, they're absolutely identical. So again, the anthracycline in the form of FEC did not outperform a regimen that did not have an anthracycline. As a result, we can feel fairly confident that we're not compromising anything. And these are the results, again, looking at event-free survival at 3 years, the lines are superimposable. If you look at patients who are clinically node negative or had higher nodal burden, event-free survival was identical, whether you had an anthracycline or not. And as a result, I think we can safely say that an anthracycline can be avoided in most patients. And as I said before, less cardiac toxicity, less leukemia, and there's equivalent outcomes even in high-risk node-positive patients. So let's move on to introducing other HER2-directed therapy into the regimen. We know that the introduction of pertuzumab in the preoperative setting significantly improved the PCR rate. And if you look at some of the trials that have been done over the years, the Neosphere, Trifina, which was actually a trial that was assessing cardiac toxicity, you can see that with the introduction of pertuzumab, you're getting PCR rates in the 50 to 60% range. So this led to the idea that perhaps the use of pertuzumab as an adjuvant component of a HER2-directed program might further reduce the risk of recurrence. And again, this is the Affinity trial, a large trial with almost 5,000 patients. HER2-positive disease who postoperatively either received chemotherapy, usually a standard anthracycline or non-anthracycline regimen with trastuzumab, or the same chemotherapy options with trastuzumab and pertuzumab. Endocrine therapy as well as RT was appropriate per the clinician's discretion. And if you look at the follow-up from this trial, the addition of pertuzumab for all patients in the trial looked to improve things by about 3%. The lines are pretty close together. Overall, the patients did well. Out at 6 years, most patients are free of disease, but nonetheless, there seemed to be a small advantage with the addition of pertuzumab. Now, with longer follow-up, who are the patients that really benefit? If you look at the hormone receptor positive patients, initially we didn't think they were gaining benefit, but as it turns out, there is about a 3% benefit with the addition of pertuzumab. Hormone receptor negative patients also had a similar improvement in outcome, particularly node positive patients with about 4.5% improvement in disease-free survival, whereas node negative patients did not seem to gain any benefit. And at this juncture, there is not a survival benefit. So where do we use pertuzumab? Well, most patients in a preoperative setting who have a tumor that is roughly around 2 centimeters, or certainly if they're node positive, we would consider a regimen containing pertuzumab. And we know that it does improve the PCR rate, but it doesn't improve the disease-free survival in all patients, particularly those with node negative disease. So again, we have to recognize that in some patients, we may be over-treating them, but there is clear evidence that pertuzumab adds benefit. But can we de-escalate therapy, particularly in those with lower risk disease? So the APT trial, which Sarah Tolaney published in the New England Journal of Medicine, and then was subsequently updated with longer follow-up, is shown on this slide. These were patients with HER2 positive, ER or ER negative, node negative disease, less than 3 centimeters. Most patients had tumors that were 2 centimeters or less. And if you look at the regimen, it's weekly paclitaxel times 12 with trastuzumab, followed by the completion of a full year of trastuzumab. And the results of this trial shown at this slide with long follow-up, disease-free survival and recurrence-free survival are excellent. Even at 7 years, only about 7% of patients had an event, and recurrence-free survival at 7 years, only 2.5%. So again, for the appropriate patient, de-escalating therapy appears to be an attractive approach. Can we achieve similar outcomes or even better with less toxicity? The ATTEMPT trial was a follow-up to the APT trial just shown. These were patients with stage 1 HER2 positive breast cancer. They could have had N0, N1 microscopic disease, and they were randomized to TDM1 or paclitaxel trastuzumab per the APT trial. And the results from this show that on the whole, most patients are doing well. Obviously, at 3 years, the follow-up is not as long as in the APT trial, but very few patients in this group have recurred. But there was a finding that there was actually more drop-off in the patients who received TDM1. Actually, 17% of patients discontinued therapy compared to 6% in the paclitaxel trastuzumab regimen. The TDM regimen was associated with less in the way of neurotoxicity, which can be attributed to the paclitaxel and the APT regimen. So there are trade-offs in using TDM1, but I suppose in certain patients it would be an option. And the follow-up study is shown here, and this is the ATTEMPT 2.0, similar population of HER2 positive stage 1 patients who are randomized to TDM1, but for only 6 cycles, after which they receive subcutaneous trastuzumab or the APT regimen. We don't have results from this trial yet, but this may be an effort to limit the amount of TDM1 and hopefully the drop-off that occurred in the ATTEMPT 1.0 trial, and we'll see what the results actually show. It's also important to see that with the ATTEMPT trial in the TDM1 arm, there are more patients who retain their hair compared to the TH arm. So as I said at the outset, there are trade-offs with any of these different approaches, and we'll see what the net effect is when we look at the ATTEMPT 2.0 trial and the results are available. One of the issues that we've acknowledged is in those patients who receive preoperative therapy and have residual disease, their prognosis tends not to be as good as those who have a PCR. So therein lies the rationale for the Catherine trial, which is shown here. These were patients that had residual disease following neoadjuvant therapy that included a taxane. Anthracyclines and alkylating agents were also allowed, and all the chemotherapy was administered prior to surgery. And patients also received at least 9 weeks of trastuzumab. Residual disease was defined as any invasive disease in the breast or axillary nodes, and postoperatively, patients were randomized to TDM1 or trastuzumab for a full year. With the use of TDM1, as you can see, there's an advantage. The 3-year disease-free survival, invasive disease-free survival, was improved by 11%. So again, the thing we're trying to affect most are the recurrences that are distant. And if you look at the table, there are clearly fewer of those as well as local regional recurrences. So as a result of this trial, TDM1 became a standard for those patients with residual disease. And if you look at the forest plot depicted here, there's really no subset of patients that doesn't gain from the addition of TDM1 rather than continuing trastuzumab. And in fact, those patients who actually had a conversion, a small number of patients who went from HER2 positive to HER2 negative, in the group that continued on TDM1, there was still an advantage over trastuzumab alone. And this, of course, speaks to the heterogeneity of the tumor, that it's not all uniform. But nonetheless, all subsets seem to benefit from TDM1. So are there ways that we can improve upon the KATHERINE trial? We see that the 3-year invasive disease-free survival, particularly in high-risk patients, is still about 83%. There was no real improvement in the rates of CNS recurrence. So there might be other strategies that are going to be evaluated that really address those issues, including trials that look at the combination of TDM1 and tucatinib, which has CNS penetration, as well as looking at trastuzumab deruxtecan, which is the subject of one of the DESTINY trials. And there are also trials that look at the addition of CDK4/6 inhibitors to endocrine therapy post HER2 treatment. So we don't have results from those trials yet. One of the other issues is there anything else beyond a year of therapy that we can do once the anti-HER2 therapy or the standard anti-HER2 therapy is complete, be that trastuzumab or pertuzumab and trastuzumab? And one trial that sort of addressed this is the ExteNET trial depicted here with the TKI neratinib for patients who had completed 1 year of trastuzumab. They were randomized to neratinib or placebo and then followed. It's important to note at the outset, these were not patients who received TDM1 if they had residual disease. These are not patients who received pertuzumab. So it doesn't necessarily reflect contemporary treatment patterns at this time. Nonetheless, if you look at the IDFS on the left at 5 years, there was an advantage of about 2.5% for those patients who received neratinib. There was no improvement in survival, as you see on the right. But interestingly, if you look at those patients who received neoadjuvant therapy, so these might have been patients the clinician thought was at higher risk, they did not receive or did not achieve a PCR, and they were hormone receptor positive. You can see on the left that there was a significant improvement in DFS, about 7%. And there's also a suggestion of a clear survival benefit for this population. So what I would say is that in this group of patients, particularly those that are highly motivated for additional therapy, who have a high risk without a PCR, this could be considered. But again, we know that in patients who receive neratinib, in order for them to tolerate it, you have to either slowly escalate the dose of neratinib to mitigate the diarrhea that can occur, or add other agents, including steroids, cholestyramine, et cetera, that may, again, add to the reduction in side effects that some patients experience. So what are the efforts going forward to even further personalized therapy? One is the COMPASS trials. The COMPASS HER2 trial shown here is an effort preoperatively to minimize the amount of chemotherapy with the THP regimen, where the T is either paclitaxel or docetaxel, with trastuzumab, pertuzumab, given for 4 cycles rather than oftentimes the standard 6. They go to surgery. If they have a PCR, they would go on to 1181, which is completion of 1 year of HP. If they did not achieve a PCR, they would go on to the COMPASS HER2 residual disease trial, which would randomize patients between TDM1 or TDM1 and tucatinib. And again, we don't have results from this. We're actively accruing to this trial. The DESTINY-5 trial is depicted on this slide, and this is going to address whether or not TDM1 is going to fall by the wayside compared to trastuzumab deruxtecan, which has shown significant activity in patients with metastatic disease. We'll hear data about this at ASCO 2022 in a few days about its role in HER2 low disease. But this is comparing the use of TDXD to TDM1 in those with residual disease who had operable breast cancer with node-positive N1 to 3 disease after neoadjuvant therapy. I alluded to the fact that there are some strategies that look to employ additional therapy following the HER2-directed therapy. The eMonarch HER study is shown here. These are patients who either initially go to surgery with the full complement of chemo, trastuzumab, pertuzumab, and endocrine therapy plan, or receive preoperative HER2-directed therapy, and then surgery, and then TDM1 or endocrine therapy if they have residual disease. And in these patients, they will be randomized 1-to-1 to the standard endocrine therapy of physician's choice alone or with the addition of abemaciclib, trying to see if in this population, not unlike the Monarch E trial that showed abemaciclib in high-risk patients further reduces the risk of recurrence. This trial will look to determine if that can be achieved in HER2-positive patients. So how I would summarize things is that we have a large variety of drugs that we can now use. They've been demonstrated with activity in the metastatic disease setting. The adjuvant trials have clearly improved the outcome of patients with HER2-positive disease. We tend to use preoperative therapy, often with a trastuzumab, pertuzumab-based regimen for node-positive or tumors greater than 2 centimeters. And in those patients, at least today, who don't achieve a PCR, we would consider TDM1 postoperatively. The issue of extending therapy beyond 1 year of HER2-directed therapy must be individualized. We do have neratinib that could be considered, but again, as I mentioned earlier, this does not apply, or at least the results are not applicable to those that have pertuzumab and TDM1 because that was not evaluated in the EXTENDED trial. In lower risk patients, those with stage 1 disease, we have the TH or TDM1 regimens from the APT and the ATTEMPT trials, and we have a number of trials that are ongoing that are looking at strategies to de-escalate and personalize therapy appropriately based on risk. So I think the next few years will show even more data that will let us tailor therapies for our patients and hopefully improve outcomes without increasing toxicity. So with that, I'll stop and I appreciate your attention. Happy to answer any questions.
Thank you, thank you, Professor William. That was a wonderful talk. And I think we have the panel discussion now. So I would like to invite Dr. Krupa Shankar, who is the consultant medical oncologist from NSR CanCure Coimbatore. Can we have?
I think we conclude this session.
Thank you, Dr. Kapil Suri and Dr. Nawag Gupta for moderating the session. And thank you, Professor Gradisher, for the wonderful talk. For the next session, the case-based panel discussion on NACT, I would like to invite Professor William J. Gradisher once again, and Dr. Shrujana Joga from Delhi, Dr. Mohit Sharma, Senior Consultant Medical Oncologist, Venkateshwar Hospital, Dr. K. Medi, Director Oncology and Senior Consultant Medical Oncologist at Batra Cancer Center. And once again, Dr. Noah Gupta, Consultant Medical Oncologist, Jindal Hospital and Cancer Center, Palwal, and Dr. Rohan Khandelwal, Lead Consultant from the Breast Cancer Center, CK Birla Hospital, Gurugram. And to moderate the session, I would like to invite Dr. Krupa Shankar from Coimbatore on the stage.
So very good evening to everyone. And at the outset, before I begin, I'd like to take this opportunity to congratulate Shyam sir and the organizers for actually breaking the monotony and bringing us all together physically. I think we've all been fed up with webinars, so it's nice to actually gather everyone physically. So I have this honest task of discussing on the role of neoadjuvant chemotherapy in breast cancer, probably in early breast cancer. So I thought we've already had a lot of talks on hormone receptor positive subset and in the triple negative breast cancer and HER2 as well. But there's a lot of controversies, especially in the triple negative breast cancer subset, which is probably why I thought we'll focus more on that and also on response therapy. So I have a distinguished set of panelists, both national and international panelists, to help me through with the panel discussion. So let's get started right away. So this is a 38-year-old practicing gynecologist with P2L2 premenopausal lady with a complaint of left and left breast for 1 month duration, presented in the oncology of PD and had an FNAC which is suggested an IDC. And on examination, palpable lump around 5 centimeters in the retroiliac region with palpable mobile left axillary lymph node. So biopsy report, that's it. It's an IDC grade 3, triple negative. So, probably I'll just begin with this. We've already talked about the molecular subtypes of triple negative breast cancer, but do you think it has any relevance as far as treatment is concerned or therapeutic relevance of the molecular subtypes of 3 and BC? We'll begin with Dr. Sujana.
Although we are not doing it,
I can hear you, but
although we are not doing it in clinical practice, but this has got a clinical significance in terms of response to immunotherapy, with the immunomodulatory type having more likely of PD-L1 expression and basal-like expression having more likely of BRCA positivity.
So, do you think that we're actually ready to use that in clinical practice to use our judgment? Say, for example, if you want immune checkpoint inhibitors, you probably want to select an immunomodulatory subtype. Do you think that is, are we there yet?
It has not come into.
I think we are not doing it in our routine clinical practice as of now, but maybe I do not know. I think it's still more of investigational thing. Routinely, it's more of investigation.
Fair enough. So I think we had actually done it. We had done checked for the androgen receptor positivity in patients with triple negative breast cancer, and look at targeting the androgen receptor as well. But there's only phase 2 data to that tumor, where the people have looked at using either androgen receptor blockade with abiraterone and enzalutamide as well in breast cancer. So that's just food for thought. Not in the neoadjuvant setting, but it's in the metastatic setting. But I think, like all the panelists have rightly agreed on, I think we're not yet there as far as translating it into practice. It just exists as far as knowing about the molecular subtyping. So this was the finding of the PET scan. And let me again get your thoughts on that as well. Do you think, what are the indications for doing a PET CT as far as staging workup is concerned in your practice? Any of the panelists? Dr. Mehdi?
Yeah. Although there is no standard recommendation, but in young patients, most of the patients we are doing, and in fact, if we do not suggest, also patients themselves are doing the PET CT. So I think now the time has come, we cannot avoid PET CT in this type of situation.
So I think like rightly said, it's probably become more of a status symbol. I've got my PET scan, have you done yours? But I think if you look at the recommendations and guidelines, I think it's more clearly for the locally advanced breast cancer starting from stage 3B, even if you look at the HCC recommendation or even for NCCN as well. For early breast cancer,
if the patient comes to us without a PET CT, we have to tell that patient that the PET CT is not indicated in your case. Then it is up to him if him or her if he wants to get it done. But we should tell the patient that it is not recommended in your case.
Yeah, shared decision making is what you're calling it. Probably an informed decision. Yeah. So, Professor William, are you there? And if you can hear us.
Yes.
Yeah. So, your thoughts on the role of a PET CT scan in early breast cancer, be it even early triple negative breast cancer?
Yeah, I think the broader question is whether we do imaging or not, and the answer is yes. I think there's still disagreement about whether it should be PET CT or CTs and bone scan. PET CTs are often many times more expensive than a CT bone scan. So it's not uncommon for CTs and a bone scan to be done rather than a PET CT. But I think the bigger issue is, yes, imaging should be done in somebody like this.
I think, when we talk about upstaging the disease as far as early stage breast cancer is concerned, be it even triple negative breast cancer, doing a PET CT doesn't actually, we again had this data where we looked at patients with early stage disease, even when checking on a bone scan, only around 10% had, we were able to pick up bone marrow cells only 10%, even in the triple negative breast cancer subset. So I think probably that's why, probably you end up over investigating. But like the panelists rightly pointed out, I think we are right now in the era where people actually tend to look at getting a PET scan done for any indication. So, and probably, in some places it does turn out to be cheaper than having to do a CT chest, CT abdomen, and a bone scan together. So you're probably looking at a single stop investigation to get that done. Any other investigations that you'd want to order for this patient? Dr. Mohit?
I guess all the relevant investigations have been already, mammogram has been done.
Yeah. As in any other genetic information that you would like to know for this patient. Do you want to do genetic testing for this patient? I'll be more precise.
Yes, genetic testing has to be done.
Okay.
It should be done.
So, I know for anybody with triple negative breast cancer, we always look at getting a genetic testing and counseling done for the pre-test and post-test counseling. Is there any indication where, you would not want to do a genetic testing in a particular individual with triple negative breast cancer? Or is it across the board? Because, NCCN mentions a cutoff of less than 60 years. So if we have somebody with 65, 70, does that mean we wouldn't offer them genetic testing?
If they have other risk factors, we'll definitely consider it.
So you would consider probably
If there is strong family history.
I mean, I do not get it done routinely. We really discuss it with the patient. She wants to get it done, and only then we go ahead and do it, rather than just directly advising a young female triple negative. We just discuss it that you should know getting the test done and the implication of the test. Only then she should get the test done.
So ideally, yes, you would probably need to have a genetic counselor and talk about pre-test counseling and post-test counseling as well, and the implications of having a genetic testing done. But I think across the board, it should be offered. And, that's how what the recommendations are as well. Professor, if you can hear us again. So, do you routinely offer genetic testing to anybody who walks into your clinic with a diagnosis of triple negative breast cancer?
For that subset of patients, we usually do. And obviously this patient is younger, so there'd be little disagreement about obtaining genetic testing. And of course, the other implication is if she has a BRCA2 mutation, somewhere along the line, PARP inhibitor might figure into her therapy.
Yeah, I think we're all in agreement on that. So, slides. It's moving on the system, but it's not moving on the screen. It's not moving on the screen, but it's moving on my desktop here. All right, great, thank you. So I think those are the indications. If you go by the recommendations across the globe, this patient had a germline BRCA mutation as well. And I think as far as definitions are concerned, early breast cancer, Dr. Sujana, if you want to touch on that and define as to what early breast cancer, what operable LABC is.
Yeah, in a triple negative breast cancer, any tumor more than 1 centimeters or node positive irrespective of tumor stages less than 1 centimeters is usually considered as early breast cancer.
Okay, I think it's anything up to T2 and N1 is considered to be early breast cancer. Any T3 or N2 makes it LABC, and up to T3 and N0, T3 N1 also is considered to be operable LABC. So I think that's how they look at defining it. So I'll probably ask Dr. Novak. I know all the recommendations are probably very clear that anybody with more than 2 centimeter lesions and triple negative or HER2 positive disease, yes, go ahead and give neoadjuvant chemotherapy. So let's say in the Indian scenario as well, somebody walks into your clinic with a 2.5 centimeter lesion. Would you still stick to the guidelines and offer them neoadjuvant, or would you be tempted to go ahead and send them across to your surgical colleagues?
So, sometimes we are lucky that the patients does come to us with that kind of lesion and that kind of disease. So when they turn up to us, we offer a neoadjuvant. But mostly what happens is these patients actually, they've come to us after the surgery. You just have to go ahead with the adjuvant.
Okay. The point was, are we really looking at these cutoffs to be very stringent? Anything more than 2 centimeters, let's say even 2.1, 2.2, are we going to strictly suggest it? Or are we going to be more flexible about that, say even up to 2.5 centimeters or maybe even up to 3 centimeters and node negative? You probably might want to.
I'm more inclined to give a neoadjuvant therapy.
And the reasons as to why probably you would want to give neoadjuvant chemotherapy, I think you probably ask Dr. Mehdi.
Yeah, regarding that question, whether 2.5 centimeter tumor should receive neoadjuvant chemotherapy, or it depends upon whether patient landed in with the surgeon or it's with medical oncologist. Most of the time we receive the patient after the surgery. So because when we talk to them, then surgeon says that 3 centimeter tumor, it's very easy to take out and we can do reconstruction, we can do BCS, there is no problem. So it depends upon when, where the patient landed.
So I think, you're talking about putting it in a very real life practice and, the perspective as to who the patient lands up with. But I think, if you go by that, especially in the current year of response adaptive therapy, where attaining a PACR is both prognostic and predictive as well,
Yeah.
you're absolutely justified in going ahead and doing neoadjuvant chemotherapy
Yes.
for anybody with more than 2 centimeter lesion. So moving on to the choice of neoadjuvant regimen, we've heard from Dr. Randeep as well on the role of nab-paclitaxel. And I'll just quickly take you through the PACR. Well, here is the data that shows that it's not just about having a higher PACR, but that's translated to an EFS benefit as well across the board. And this is a CTNO BC pooled analysis as well, which shows you that across the board, not just the HER2 positive subset, but also the triple negative subset as well. So I'll move on quickly to this debate. Nab-paclitaxel versus paclitaxel in your practice, Dr. Sujana.
We are not using nab-paclitaxel in our city, sir.
You use a lot of
No,
nab-paclitaxel?
no,
You don't?
no.
Okay, conventional. Any takers here for nab-paclitaxel?
No, we are using.
Okay.
We are using.
Anyone else on the panel?
I'm using conventional paclitaxel.
Conventional
but,
paclitaxel.
I was just seeing the data which Dr. Randeep also presented. HER2 positive and even the Harun positive, we are getting more of a PCRs, though the delta is somewhere about 3%, I believe, 3 to 4%. But probably from tomorrow, I'll be more inclined to go ahead with the nab-pacli.
Okay. So I think, Dr. Randeep, you also showed us the data of the ETNA study. This is the other study, the Japan Septo study, which is also shown that there's an improvement in PACRs when you use nab-paclitaxel. So I mean, if I can probably quickly ask the audience as well, a quick show of hands. Govind sir, Govind sir, Sham sir. I mean, do you routinely use nab-paclitaxel? Okay, Govind sir is agreeing. Govind sir, nab-pacli as well. Okay. So yeah, I think, if you go by the data and also by the PACR rates, I think, you justified in offering nab-paclitaxel. Let's get Professor William's thoughts as well, if he's here. Professor William?
Yeah, so in this setting, we're more likely to use immunotherapy per keynote. So we would follow that regimen and not necessarily preferentially use nab-paclitaxel, but carbotaxol followed by AC with pembro if the tumor is roughly 2 centimeters or more. So that's sort of our standard.
Great. So I think, you're using the Keynote 522, but unfortunately, I'm not sure most of our patients would actually be able to afford that regimen. But yeah, having said that, that's probably the gold standard right now. And what about the role of platinums? I think, this is, being debated on for ages and ages. So again, Dr. Sujana, we'll begin with you. You convinced with the data, do you routinely use platinums? And if so, is it dose days, 3 weekly, how do you use it?
So, sir, with the recent update of the brightness EFS data, before that, we were doubtful about the role of carboplatinums or platinums in the TNBCs in relation to BRCA mutation status. But with the DFS benefit shown now in the ESMO, which has come recently, so we are thinking of using it. We are offering it to our patients with weekly Paclica.
Okay, but just to quickly, just to play the devil's advocate here, the brightness study, the primary endpoint was looking at the addition of veliparib, which is a PARP inhibitor, to the combination. And the primary endpoint of that trial was not met. It was a negative trial. So how much would you actually read into a negative trial to pick out the other points and say, okay, that justifies my use of carboplatin, that's it.
But even with the other trials, the addition of carboplatin has improved the PCR rates, which indirectly transfers into the EFS benefit.
So yeah, I think we're all in agreement about that as well. Any differing thoughts from the other panelists as well on the role of platinums? Do you routinely use it in practice?
We definitely routinely use platinum.
Your choice of platinum?
Weekly paclitaxel along with carbo AUC.
Carbo AUC too. Okay. Any takers for cisplatin? Do you use cisplatin? No. Only carboplatin. Okay. I think probably platinum still remains a poor man's PARP inhibitor. I think you can put it that way. And this is the data across the board where you see that there's about a 15 to 20% improvement in the PAT-CR rates when you add a platinum. And that's been shown across boards and across meta analysis as well. But then there comes the debate that it is not actually translated to overall survival benefit. But that's because all of these studies were not powered to do that. The primary endpoint of these studies was PAT-CR. They were not powered adequately to answer that question of the difference in overall survival. So, and this was interestingly another, a debate that happened on international forum between Dr. Rebecca and Dr. Hochbrugel. And interestingly enough, Dr. Rebecca was for it, and Dr. Hochbrugel felt that probably the additional toxicity was not worth taking in. So, and this is very own Indian data from CMC Vellore showing that it can be done. The PAT-CR rates done by my colleagues Dr. Anjana and Dr. Ashish, and they published it as well, albeit only retrospective data. Again, the treatment completion rates were well to the tune of more than 95%, and the PAT-CR rates were to the tune of close to 50%. So I think, yeah, it definitely can be done. We'll get Professor Williams' thoughts as well. Sir, do you routinely use platinums for triple negative breast cancer in your setting as well?
So in the pre-Pembro era, we would make a decision based on patient age, whether they could tolerate the extra toxicity. We were more often likely to use it in patients who were younger with more aggressive features. Once Pembro, and I acknowledge we have it more available in the US than elsewhere, Carbo is just part of the plan. So we're giving Carbo in all patients with Pembro.
All right. So I think we'll take your thought on that. So, I know now this has probably changed the way in which you all look at triple negative breast cancer, the role of neoadjuvant therapy in triple negative breast cancer. So, and this is the data, again, irrespective of the PD-L1 expression as well, it has shown a benefit in the PAT-CR rates. Guys, okay, thank you. So, there's been an improvement in the tune of 15% made both irrespective of the PD-L1 expression, both in PD-L1 positive subset and the negative subset as well. And this was the both interim analysis of the Keynote 522, which is also shown an improvement in the EFS of 84 versus 76%. But if you look at all the other neoadjuvant trials, it hasn't been so promising. So I'm going to quickly pick your brains on that. Dr. Sujana, I'm sorry, I'm starting with you every time. But why are we getting to see these differences across different trials in the neoadjuvant setting with immune checkpoint inhibitors? Your thoughts on that? Because if you look at the Keynote 522, yeah, absolutely, yes, it's a positive study, always gets celebrated around, talked upon a lot. What about the other studies, where if you can see here, clearly?
Basically, these studies, the partner chemotherapy was changing, and whether they were continued in the adjuvant setting also differed. So there are multiple factors because these two studies cannot be truly compared.
Correct. I think, we're on, and look at the numbers as well. The Keynote 522 was the largest study of all these trials. And again, there are a couple of trials, the Japan New and the NeoTrip, which only looked at 6 months of immune checkpoint inhibitors. And then again, if you look at, even the chemotherapy regimen, like you rightly pointed out, they were not the same, they were not uniform as well. But let me go into that as well. So, for example, the NeoTrip PD-L1, they did not complete all cycles of chemotherapy prior to going in for surgery. So that's another reason. So I'll quickly ask you this question. In your practice, do you still believe that probably only patients with PD-L1 should be offered this regimen, or should it be offered irrespective of the PD-L1 regimen? Dr. Mehdi?
Yeah, till we do not have a stringent marker for response of immunotherapy. I think PD-L1 should be considered as a marker. And in our practice, I think we are taking consideration of PD-L1 positivity only.
Okay, you're using that? Okay.
Yeah.
Do all the other panelists agree with that? Because I just showed you the magnitude of benefit, even in the PD-L1 negative subset, where it's to the tune of around 45 versus 30%, again, a 15% increase in the PAT-CR rates. Again, I'll just quickly turn to Dr. Randeep, Dr. Pur.
It all depends on the cost. So if cost is not an issue, patient wants it irrespective of PD-L1, we can offer them.
Yeah,
if cost is making a major concern, we would push for it if it is PD-L1 positive.
I think I'd agree with that, but probably Dr. Randeep, sure. And even the PAT-CR rates are also
if you have a event-free survival, which is a better parameter, I mean, we want PATHFIA to convert into EFS. And if your EFS is not correlating with PDL1, I think it is for all comers. And then you are giving it in the neoadjuvant and adjuvant setting. So it is not a response assessment based method.
Absolutely. And in fact, if you look at the magnitude of benefit, I've not shown you that slide, but even in patients who did not have a PDL1 expression, the magnitude of benefit was still maintained. And probably, even if they didn't achieve a PATHCR, those patients actually seem to benefit much more with continuing pembrolizumab as well. And I will get in Professor Williams' thoughts as well. So Professor, what about the role of PDL1 in selecting these patients in the neoadjuvant setting? What do you do in practice?
Well, we're sort of relieved again that we don't have to rely on PDL1 because it's not necessarily the best marker. Obviously, in metastatic disease, we still rely on it. But in the neoadjuvant setting, it's triple negative all comers that we think of for Pembro. And again, I think if cost was an issue, we may have to discriminate a bit more, but PDL1 doesn't really figure into our decision-making for pre-op Pembro for triple negative disease.
I think that's the take home. I think we should probably be looking at giving it irrespective of the PDL1 expression because the magnitude of benefit has been maintained. Quickly into the adjuvant setting, any role for an anthracycline-free regimen in early triple negative breast cancer, where you do only 6 cycles of Paclitaxel and carboplatin. Any takers for that? Dr. Mehdi?
In young patient, my practice is to go with anthracycline regimen initially.
Okay. Even for early stage disease?
Even in early stage disease, because triple negative disease is even in early stage disease recurrence is
so you're convinced with anthracycline?
Yeah, anthracycline based, then followed by taxane plus platinum.
Okay. Dr. Novak, how impressive is this data? This is also phase 3 data. This is a study called the Pattern study, which looked at Paclitaxel and carbo and compared it to FEC followed by docetaxel in low risk triple negative breast cancer in the adjuvant setting. So your thoughts? Do you think you could do that in practice?
I think young patients, I am inclined to go ahead and use the anthracycline. It's more the elderly patients where I might be avoiding the anthracyclines.
I think probably this is good enough data, especially if somebody's got node negative status and up to PT2. It can definitely be offered considered as a regimen if you believe in the Chinese data, that is. So this patient went out to receive the Keynote 522 regimen. Quickly, I'll just get on to this. So, in the adjuvant setting, how do you choose? What would be your ideal choice if you want to offer capecitabine? Would you pick the Createx way, or would you do it the cis-UCC, again the Chinese data, where you give 1 year of metronomic capecitabine? Dr. Mehdi.
Yeah, we are considering that giving capecitabine for 1 year.
But how do you do it? Do you do it for 6 months or 1 year? And what is the dose that you're comfortable with?
The dose, the Indian patients, our patients are tolerating only the lower side of the dose, maybe 1000 milligram twice daily.
Okay, but unfortunately, that dose, if you look at the French study,
Yeah, that was a higher dose.
So either you go the Createx way or the cis-UCC way. If you feel patients can't tolerate it, probably 1 year of low dose metronomic capecitabine should be the way. Just quickly conclude with this. PARP inhibitors. If remember, this patient had a germline BRCA mutation, and you've already used the Keynote 522 regimen. And so, would you be tempted to use PARP plus immunotherapy in this patient? IO plus PARP, or all of the above, none of the above? What should you do?
There is no data for it.
Okay, you wouldn't combine it. Fine, fair enough. Any differing thoughts from Dr. Novak and the other panelists? No. So you don't you're not inclined towards this data. Yeah, I think probably in the triple negative subset it makes a difference because around 83% of patients in this study were triple negative, hormone receptor only around 17%. And very interestingly, and obviously we've had an ESCO recommendation as well saying that yes, the patients who have a germline BRCA 1 or 2 mutation, yes, this is definitely a valid option. With that, I think I'll conclude and thank my panelists for making it such a wonderful interactive discussion. And also thank Professor William for giving us his wonderful insights. Thank you.
Thank you.
Thank you.
Thank you, Dr. Kripa Shankar and esteemed panelists. For the next session, I would like to invite the chairpersons, Dr. D.C. Dawal, Chief Medical Oncologist from Rajiv Gandhi Cancer Research Center, and Dr. B.K. Malik from a senior consultant, laparoscopic and general surgery, Sir Gangaram Hospital, and sub-dean at Network. Please, sir.
Nice to see the physical meeting back in place. And thank you, Dr. Shyam Agarwal, for having such a wonderful discussion and such a wonderful ambience. I do hope that the message that's going out is that we are across the pandemic and that we are now entering more normal zones. And with that, it's my pleasure to invite Dr. Purvish Parekh, who's been regular at these meetings and full of wisdom and his foresight and perspective on COVID pandemic and breast cancer screening, how things have been, and what can be the impact of COVID thought process on the screening. Over to you, Dr. Parekh.
Thank you, Dr. Malik, Dr. Dowell. Thank you, Shwam, for the wonderful invitation. So what happened with COVID and breast cancer screening, you can see in this graph, right? Actually, this graph represents the stock market of Sri Lanka, but it's no different from what happened to screening with of breast cancer with COVID. And if you look at YouTube, you will find lots and lots of videos that talk about experts giving their comments of what is the problem of screening and what are the consequences and how many lives are going to be lost. But at the end of my talk, I will be giving you a very controversial statement, and I will definitely like to hear the feedback from you guys. So if you look at worldwide meta-analysis, and that was published this year, 994 articles. 7 of them were registry based, and this represents 48 lakh cases, okay? 18 countries, and the drop in the rates of breast cancer screening was between 41 and 53%, and the drop in the breast cancer diagnosis was 18 to 29%. And obviously, the impact was more in countries where there was a lockdown that was announced, like in India. Now, another evidence of whether COVID-19 adversely affected breast cancer screening. This is 39,444 women. Control group was before COVID, January 19 to March 20. Pandemic group was March 20 to September 20. And this terminology I will use in other slides as well. So control group is before the pandemic and the pandemic group is during the pandemic. This data is from 7 academic and community centers in USA. And they looked at screening mammography, diagnostic mammography, as well as breast biopsy. And they said that there was a significant reduction in all 3 of them during the pandemic. This is data from Taiwan, and this is to tell you that it's not just breast cancer screening, but screening for other cancers which are also affected. And in here, you can see that the sharpest decline was for oral cancer, which was as much as 50%. Let us look at healthcare workers who are supposed to be educated, who are aware about what is happening, and therefore should take better care of health, like you and me. This was in the NCI funded network in United States, 794 healthcare workers. And you can see that overdue screening existed for breast mammography in almost a quarter of them, colorectal endoscopy in 39%, and lung cancer CT tomography in as many as 90% of patients. So the more intense the screening, the less is the chance that there will be compliance during the pandemic. This is comparative data of reduction due to pandemic in United States.
Again, control is 2019 data. 2020 data is the pandemic data. Screening mammography reduced by 44%. P-value is very highly significant. Diagnostic mammography reduced by 21%, also statistically significant. But breast cancer surgeries that reduced by 11% was not statistically significant. What about inequalities? Do all the races and socioeconomic patients have the same problem? The answer is no. Again, you can see that this was a cohort where patients, or not patients, people who were screened 2 years ago and then subsequently were due for screening were evaluated. So the control cohort, initial screening was 2017 and second one was due before the pandemic in 2019. That was 18,197 patients. In the pandemic cohort, 16,391 people where the second screening was due when the pandemic occurred. And this said that the higher adverse event was seen in women who could not afford private insurance. So there were Medicaid insurance, and in the Asian race. And I think you should remember this. Now, what about time interval during the pandemic? This is now for patients who had paid or private insurance. Okay. So these are educated and probably upper middle class or rich people. The time one was the control was in 2019. The pandemic was 2020. And you look at the screening rate. In the month of April, 2019 was 4.2 to 2020 was 0.5. Dramatic difference. But by June, that difference had come back. So there was a fear at the beginning, but then as the pandemic continued, people were more worried about other things as well. There were two computer modeling publications that I'm going to allude to. The first one is from United States. The other one is from United Kingdom. This modeling was based on a pandemic that lasted for 6 months. Okay. We know that the pandemic was much longer, but what if it was only 6 months? If it was only 6 months, by 2030, the projection was that there would be additional breast cancer deaths of 950 due to reduced screening, 1,314 due to delayed diagnosis for symptomatic patients, and 151 due to reduced chemotherapy in hormone receptor positive early breast cancer. Similar modeling from United Kingdom. Screen delays was 14 lakh women. Screen not done was 7.5 lakh women. And it said that there would be a shift from screen detected to symptomatic patients in between 2,500 to 4,100 cancers. There would be additional cancer deaths of 148 to 452. Deaths due to screen detected tumors would be 164 to 221. And deaths due to DCIS progressing to invasive cancer would be between 71 and 97. So people have really spent a lot of time and energy and technology to identify exactly how many excess deaths could occur. Now, what were the barriers to screening? Obviously, everybody understands that there was a barrier, but let us look at it formally according to the publications. So there are 3 levels of barriers. One is the policy level. For example, the announcement that all elective procedures are to be delayed. The second could be organizational level because there is a backlog of patients waiting. And the third is individual level because of patient cancelling going to the hospital or the healthcare facility. Fear drives the postponement of screening. It's very logical. And fear of contamination was the reason for more than 50% of cases. Now, what happens about the fear in a patient who already has breast cancer, probably has been treated now in complete remission, but there's a fear that my breast cancer may come back also. So these patients, 4,831, had distress and concern regarding the pandemic. But on top of that, they had distress about treatment plan interruptions and delay, dysfunctional communication with the medical team because the medical team was busy elsewhere or was not available, and difficulty in access of medicine and food, especially in the countries where there was a lockdown. Now, what is the effect of this delay? And in NHS UK, they said there is a 2-week wait pathway between the GP diagnosing and getting an appointment with a specialist, breast cancer specialist in an NHS hospital. So as a result of this, what would happen? So they looked at patients between 2013 to 2016, that was 6,281 stage 1 to 3, that is non-metastatic breast cancer patients. And they said that 27% of these were predicted to die in 10 years due to breast cancer. And because of the additional pandemic, additional lives lost because of this backlog. If the backlog was 25%, it would be 181. If it was 50%, it would be 361. And if it was 75%, it would be 542. Now, did anybody find innovative solutions? And the answer is yes. This particular group said that if the patient comes for screening, we will make sure that we provide everything that the patient needs on that particular day itself before the patient is discharged. So they said if the screening mammography is done and something is abnormal, we would do the diagnostic mammography and the diagnostic test before the patient goes back. And in the control, this was done only in 14.8% of instances, but during the pandemic, they were able to do it for 60.7%. So this is a solution to reduce the risk of exposure or contamination to the COVID virus by making sure patient spends the least amount of time in the hospital. What about solutions to the effect of the COVID-19 vaccine? All of us know that if the vaccine has been taken, it is possible that an axillary lymph node would interfere with the breast cancer screening mammography. And the recommendations from this, that was 1,027 patients of screening mammography who had also taken the vaccine, is that the lymph node is seen on mammography only if it is within 7 weeks of the vaccination. So either you do the screening mammography before the vaccination or wait for 8 weeks and then do the screening mammography. Now, what about the effect on breast cancer features? And this is newly diagnosed breast cancer patients, whether it is symptomatic presentation, grade 3 disease, triple negative breast cancer, first surgery, or neoadjuvant chemotherapy. And all those factors that are shown have statistically significant impact during the pandemic. So these were really badly affected. What about the impact of the stage on breast cancer? This is 573 patients, 376 in the control, 198 in the pandemic. As far as clinical stage is concerned, there was no difference. Nodal disease, statistically no difference, but 23% in control versus 27% in the pandemic. Metastatic disease, 2% here, 2% there. Neoadjuvant treatment increase in the pandemic, and this was because of the use of neoadjuvant endocrine therapy in stage 1 patients, which is something that many of us had used. Now, comparative data to reduction due to the pandemic in United States, impact on clinical stage at the time of surgery. Screening mammography reduced by 40. I've shown this slide to you before, but look at the last point, which I had not shown you in the slide earlier. As far as clinical stage of the breast cancer at the time of surgery is concerned, there was no difference whether the screening mammography was reduced, whether diagnostic mammography was reduced, breast cancer surgery was reduced for biopsy. Clinical stage of breast cancer at the time of surgery was not different. Now let's look at something that is related to India, in the Indian context. Now I came across this on the web that says 50% of breast cancer patients in India die. I don't know from where this guy got these figures, but obviously it is incorrect. So if you look at early breast cancer in India, it's 30%. And why? Because of non-existent national level breast cancer screening program. Okay. And non-participation of women in any such program. This is because of a fatalistic attitude that we know. And there has been evidence that even among people who are supposed to know about cancer, their follow-up on mammography is not as appropriate as it should be. This is again difference between two cities, Chennai and Ranchi. And this was a cross-sectional study in 457 nurses. And you can see that excellent follow-up was there in only 16% of instances. So this is another data in Tamil Nadu. Those who underwent breast cancer screening, 39%, underwent cervical cancer screening, only 16%. And you can see that this included 1 cancer survivor and 8 people who were part of the healthcare provider team. So the problem is compliance. And this is I'm sure that you know this publication, Cluster Randomization Control Trial, which is the R01 trial, a very famous trial. Compliance was 71.43 and 64.93 for breast and cervical cancer screening, which is very good. Now this, for the people who don't know about it, is 20 geographical clusters in Mumbai, 10 screening clusters, 10 control clusters. Trial duration was 20 years. Okay, so this is very reliable data, especially because this included 1,51,538 women. Okay, this was the consort diagram. There was a 5% reduction in all-cause mortality in the screening arm, but not statistically significant. There was a 15% reduction in breast cancer mortality in the screening arm, but not statistically significant. 1,50,000 women, follow-up of 20 years, but no statistically significant data. This is the cumulative breast cancer mortality. You can see hardly any difference. This is now, is it only related to India or some other countries also have a similar data? So this is a data from the Canadian National Breast Cancer Screening Study. I'll just take 30 seconds more. 89,835 women, 2 arms, 44,000 in each. Deaths due to breast cancer over 5-year study, screening arm 180, control arm 171. Deaths due to breast cancer over 25 years follow-up period, screening arm 500, control arm 505. So overall probability of the survival absolutely identical. So whether it is India or whether it is Canada, breast cancer screening has been affected by pandemic. But all the fear mongers that say that this is going to cause a significant increase in the number of breast cancer deaths are speaking through their hat. This is Miller's conclusion. Annual mammography in women, see the last line, between the age of 40 and 59 years does not reduce mortality from breast cancer. Indranil Mitra, again a very good proponent of breast cancer screening, this is what he says. In the absence of a high level of awareness compounded by a fatalistic attitude to life, relative low incidence screening program may not be cost effective. And with that, I thank you very much for a patient here.
Thank you, Purvish, for doing such a in-depth research and enlightening us on that. And I think there are any questions to Purvish, he'll be glad to answer the questions.
Thank you.
With this, can I ask you?
Sir.
With this, you have hit the final nail on the usefulness of screening in the Indian context as well as in the global context.
That is the evidence. Each of us will have to take their own conclusions.
Thank you.
Thank you.
Thank you, Dr. Purvish Parikh, for the excellent talk. And now I would like to invite Dr. Randeep Singh from Delhi for our next session, which is 2 centimeter and beyond, redefining treatment landscape in HER2 positive early breast cancer.
Okay. Thank you again to the chairpersons, and it is a sponsored by Zydus, and the slides have been provided by them. I will be talking about early breast cancer, majorly HER2 positive breast cancer. So if you see this slide, it clearly shows that the chances of recurrence in a HER2 positive breast cancer in the early years, but also if you see decade by decade, as we are escalating the anti-HER2 therapy in a high risk HER2 positive breast cancer, we are definitely able to reduce the recurrence in the initial years. And the data in front of you clearly shows of the comparison of 1990 and 2004, 2006, that yes, there is a reduction in the early relapse. As the time has gone by, I think the whole house will acknowledge these statements that we have actually gone a long way in the advent of HER2 targeted therapy. The studies started with the HERA and NSCPP group of trials where we talked about 1 year of adjuvant trastuzumab. Then we did talk about 6 months of adjuvant trastuzumab. We also explored the field of neoadjuvant trastuzumab, extending it to neoadjuvant trastuzumab and pertuzumab. And we also realized that yes, PATH-CR has some meaning to the mind of the treating team. It may go into IDFS, yes, that data we have, but whether it is converted into OS, that we don't know. So when we give a neoadjuvant therapy in a HER2 positive breast cancer, I think these all principles which we have learned over the last 10 years do apply to triple negative and HER2, that we facilitate BCS, can render inoperable tumors operable, we can achieve pathological CR, go for a response adaptive therapy. And I think the last 2-3 lines are very interesting, that we give time to the patient to plan for BCS, and also the genetic testing, which take 2 to 3 weeks. And if someone after the BRCA positive, a female, deserves a risk reducing surgery, that can also be opted for while the patient is on neoadjuvant therapy. Starting with the Neosphere data, it was a phase 2 trial. It was a registration trial for pertuzumab neoadjuvant approval. The primary endpoint was PATH-CR, and you can easily see that the intention to treat population, the PATH-CR improved by another 15%, but this was majorly driven by a node positive, 21 versus 40%, almost doubling of PATH-CR. Whereas in a hormone positive subgroup, if you see the comparison of trastuzumab dosi versus pertuzumab trastuzumab, the difference is not much. It is only 6%. So when we talk about Neosphere and PATH-CR, it is majorly a node positive or a hormone negative subset which is driving this PATH-CR doubling. Trafina was another phase 2 trial. The primary endpoint of trial was the cardiac safety. And we learned 2 things from this trial, that yes, giving a dual targeted trastuzumab pertuzumab is safe. And second is, apart from an anthracycline sequencing with a paclitaxel and trastuzumab, we can also use a PCHP regimen, that is docetaxel, carboplatin, trastuzumab and pertuzumab. So I think we have learned till date that anthracycline free regimen can be opted for. PCHP is one of the standard lines of treatment. Residual invasive disease is an issue. And from there we go to the adjuvant trials of TDM1 and neratinib. TDM1 got approval in 2019 for an adjuvant setting. There was an affinity data set which gave approval in 2017 of using a dual trastuzumab pertuzumab. And neratinib, which we talk less because we don't have that drug readily available in Indian market, is also approved to be used in the adjuvant setting after you finish the standard anti-HER2 therapy. Coming to the Catherine, I think we have gone through this slide multiple times. I will just rush through this slide. It is basically a T2, as well as majorly the trial was T2 or node positive breast cancer who had a residual invasive disease after being subjected to a chemotherapy with trastuzumab or a chemo trastuzumab pertuzumab combination. The primary endpoint was IDFS. They were subjected to TDM1 and trastuzumab for a total of 14 cycles. This was a phase 3 randomized trial. The IDFS advantage, if the patient is not able to achieve PATH-CR and they were subjected to adjuvant TDM1 for 1 year, vis-a-vis the continued trastuzumab, was 11%. We can definitely debate that if we continue trastuzumab and pertuzumab in this subset, what was the percentage advantage? We don't have that data set. What was good, that apart from IDFS, there was also reduction to some extent, not majorly, in the distant as well as loco-regional recurrence. This, what is to be remembered from this exploratory analysis was that this advantage is not only to the trastuzumab, but also to the patients who have been subjected to pertuzumab and trastuzumab. But yes, the major data set, 80% was pre-operative trastuzumab with chemotherapy. Coming to the subgroup analysis, fortunately, all the diamonds are in the favor of adjuvant TDM1. Only one where the confidence interval is wide. The numbers are so less. These are for elderly patients more than 65, but you can see the numbers in total are only 110 or 120, and that's why you have a very wide confidence interval for elderly females. Otherwise, all of them have their diamond in the favor of adjuvant TDM1. The other endpoints were met. The overall survival was a secondary endpoint, and that has not been met. And also, the data is immature. I think, to my mind, only 25 or 30% of the events had happened by the time when this data was presented. Coming to the adverse events, giving adjuvant TDM1 is a bit funny that it has much more toxicity, and that can be easily seen by the discontinuation rate. If you see, the discontinuation rate of trastuzumab group is only 2%, whereas the discontinuation rate of adjuvant TDM1 is 25%. I'm sorry, it is 20%. So definitely when we give TDM1 in the adjuvant setting, there is slightly more toxicity, and this toxicity is mainly thrombocytopenia, and also there were some abnormal liver functions derangement. Yes, with this trial data set of Catherine, it is there in as well as in NCCN as well as in ESMO and other regulatory guidelines that in a patient, whether it is whether it is HR negative or HR positive, once they are not being able to achieve PathCR, they shall be subjected to adjuvant TDM1. Now, in this subset, once we think of other trial data sets which we have and the approvals, the second approval which is there is of adjuvant trastuzumab and pertuzumab. Affinity, we are all aware. I will not go into the detail, but this was purely an adjuvant trial data set. And in this, the patients were subjected to chemotherapy with trastuzumab or chemotherapy with trastuzumab and pertuzumab for total 1 year. The primary endpoint was again IDFS, and the total follow-up at 6 or 7 years, the difference is 4%, and this is IDFS. If you see these two slides, it is clearly visible to the house that this difference is being driven by node positive and not node negative patient. Also, there was not much difference in hormone positive and hormone negative. So after affinity, the second data set which we have of escalation of HER2 therapy in the adjuvant setting is neratinib. Here, one of the typical thing in the trial was that they had finished 1 year of adjuvant trastuzumab, and then another 1 year of oral neratinib was given. And these were all stage 1 to stage 3 breast cancer patients. And within 1 year of finishing their trastuzumab, they shall be subjected to adjuvant neratinib. And again, there was a 4% IDFS advantage. And this advantage is mainly for the patients who were hormone receptor positive or node positive. Coming to this conclusion slide, I think as of today, there is no doubt that anyone who has T1A, T1B, or even T1C in Indian context will go for surgery, and then they will be subjected to adjuvant trastuzumab and paclitaxel regimen. We can abbreviate chemotherapy, but we can't abbreviate trastuzumab. Or we can give full anthracycline and taxane, and we can abbreviate trastuzumab to 6 months. That is for a node negative patient less than 2 centimeters. Anything which is more than 2 centimeters or node positive, I know we debate with our surgical colleagues quite often, and they do put their point of giving the BCS because of lack of OS advantage and subjecting them to surgery first. But more said and done, if you have to adopt a pathway of pathological CR and you believe in pathological CR and response adaptive pathway, and the guidelines say that anyone who has more than 2 centimeters or node positive will be subjected to a new adjuvant regimen, which will be chemotherapy along with trastuzumab and pertuzumab. Once you give your strong best regimen, if they are not able to achieve pathological CR, they will go on a Catherine data set of adjuvant TDM1. And I will leave it here open for Nitesh comments when he gives his comments that whether he would like to give neratinib after this or not. Now, when you are not able to, this is when you are not able to achieve PathCR. If you are able to, this is the last slide, sir. If you are not able to achieve PathCR, again, among the medical oncologists, we are always divided. that whether we give both trastuzumab and pertuzumab or we continue trastuzumab once a pathological CR is achieved. If you believe in affinity data of 3.54% and you have a node positive patient to begin with, and then he has been able to achieve path CR, I think most of us will put them on a combination of 1 year of dual targeted therapy. Otherwise, you can continue trastuzumab alone for 1 year. And then after this, would you like to give neratinib or not is again an open question. And with this, I would like to come to the end of the talk and thank you for patient hearing. Thanks.
Thank you, Dr. Singh, for the interesting talk. For the next discussion, I would like to call Dr. Harit Chaturvedi, Chairman, Max Super Speciality Hospital, Delhi.
Thank you. Thank you, Dr. Shyam and Dr. Kaul and Dr. Arvind for having me here. So I'm going to talk about HER2 positive breast cancer therapy and a surgeon's perspective. In one line, the surgeon's perspective is that de-escalate surgery and escalate chemotherapy and systemic therapy. So that is a one-line answer. But I think we'll learn through next 10 minutes that why it is so. So actually it is all this for larger good, for the patient's good, and also to help the patient get the best possible outcome. And this will cover through what is now routine practice. How do we select our patients? What is multidisciplinary teamwork is very critical. Without that, you don't achieve the best results. And neoadjuvant therapy selection, surgical management, both the primary, the breast conservation, and axillary de-escalation, and the response at adjuvant therapy. So this, I think, is today the gold standard, that anything which is T2 or upwards or T1 node positive. And when I say node positive, it implies actually ultrasound guided FNA from the node. So most of our patients would have, even if they have a MR or whatever, we always do a sample and node biopsy. And only then we take a call that this is node positive. And all T2 upwards and node positive will get neoadjuvant therapy. Those who are node negative and T1 will go for upfront surgery. And as you see in this, if you have go for surgery upfront, then in that case, if it is node negative, then systemic therapy as written here, Herceptin and paclitaxel. If node positive, then pertuzumab and trastuzumab plus therapy, base therapy. And if it is neoadjuvant therapy, then we look at residual disease and take a call for the selection of systemic therapy. Now, this is the residual therapy. This is the part which is important. That is why neoadjuvant therapy is critical and should be integrated. I'll skip this slide because, or I'll rather share because medical oncologists, just to get a perspective that surgery for breast includes mastectomy or conservation and reconstructions. All this is possible today, conservation or nipple sparing mastectomy, all this is possible. And the only point I would want to make here is that post NACT breast conservation rates go up. I'll show this subsequently also. And that is one big advantage, or rather, that is one area which today's patient population is selecting more and more. So because I have the advantage of almost 30 years of practice, I can say that initially there was no thought given to among the choice of surgery. It was dominantly discussed by patients and families that go for mastectomy. Today they spend hours and do their homework, how we can conserve the breast. So this is a huge shift which we are seeing, and I think it's because the results are same, it's definitely a very good thing to happen. Now, what does neoadjuvant therapy offer in the management of early breast cancer? So it enables response assessment. That is what pathological CR, or is they achieved or not achieved. That is one important thing. So in vivo assessment to response provides an opportunity to adjust adjuvant therapy accordingly, because once you have a pathological CR, your treatment plan changes. Enhances surgical options. As I said, downstaging of the primary leads to higher rates of breast conservation. The important thing is downstaging of the axilla also. So downstaging of axilla is an important data which has come up, and in fact now there are trials going on how to get axillary surgery out of the domain of the surgeons, and if we are getting a good response we can even treat by radiation, and that also will be briefly discussed, and allows planning for reconstruction. And as Randeep mentioned, even we get data of the genetic study and further, and that also you get time for that, and allows early treatment of micromets. So this is an important thing which I drive towards surgeons. When I say that whenever there's a doubt, start with neoadjuvant therapy. And the reason for that is that more patients you lose to systemic disease than to local disease. So if there's a doubt, don't hesitate. If the patient has to have chemo, then better to start with chemo. And that's not a bad choice. So this is how we run our MDTs. The only person who is missing in this list is the radiation oncologist. So I think next time we should have that also in the MDT group mentioned. Otherwise, pathology, radiology, everybody has to be part of it. And once it is discussed, then we take a plan. Now, these are the current recommendations of pertuzumab, trastuzumab is recommended for neoadjuvant therapy in patients, as we just mentioned, that all T2 or node positive is the group, as NCCN says, and similar thing is by St. Gallen. And however, in ESMO is a dual blockade for all concerned high risk patients, again node positive and ER negative. So typically that is a large concern. Only the AGO says that in all groups, wherever chemotherapy is indicated, start with systemic therapy. That is their mandate. Otherwise, it's all T2 upwards or node positive. Now these are, this is just to highlight that how trastuzumab, addition of pertuzumab has made a difference in the response rates, the pathological CR rates, and you see that this jumps from almost 38-39% to 55% plus. So that is where the impact on survival will be seen gradually, and this is what is the expectation. Now, coming to the question of whether downsizing is safe, whether the patient can be offered conservation, I think this question has been answered long back. We have been doing breast conservation for decades now, and it is standard of care that you don't go for initial tumor size, you go for residual tumor size. That is where the opportunity lies in getting good cosmetic results and good outcomes in conservation. And this is proven beyond doubt that this is of equal results as far as the recurrence rates are concerned. What about locally advanced, where the skin is involved, whether it is inflammatory or T4B disease? There, I would say in inflammatory breast cancer, I would not encourage surgeons to opt for this unless unless more data emerges. As far as T4B is concerned, there's wherever there's mild PUD orange and the area has responded very well, these patients, we have started opting for conservative surgeries gradually. So the uptake on these areas is a bit cautious, but gradually we go there and consider that. So to measure, so look at this whole thing in terms of data, we see that the breast conservation rates go up anything from 8% to 12% different studies if you have started with neoadjuvant therapy compared to people who have adjuvant therapy and upfront breast conservation. Now, as far as the axilla is concerned, today almost all N2 disease and upwards, we offer axillary dissection for all these patients. Though we do find, and this year we have given one of our DNB students a thesis topic of targeted axillary dissection. And the purpose is this only, that we want to adopt this in practice. So we will be clipping the axillary node, positive node, but only for N1 disease, that is less than 4 nodes. So this will be picked up on MRI and ultrasound. However, in this study, they have depended on the PET-CT, but I think the MR and ultrasound are more reliable than PET-CT. And once you have done that target therapy and you have got a magnetic radioiodide targeting of the axilla, then in this study, they've shown that just removing the targeted node is just good enough, and they're going for adjuvant radiation therapy. That means further de-escalating axillary surgery, not just depending on the node positivity. Even if the node is positive, they go for only axillary radiation therapy and not completion of the axilla. However, in the last term, where there's a residual disease upfront, there they have considered both AL&D and auxiliary radiation therapy, which is a bit surprising because wherever you do auxiliary dissection, there is no need for auxiliary adjuvant radiation therapy. Now, patients receiving neoadjuvant therapy have improved event-free survival compared to those treated with neoadjuvant trastuzumab only. That is, both who have both trastuzumab and pertuzumab. This is very well proven right in the beginning. We have discussed this, that all these patients have better response rates and therefore better event-free survivals. And this data is also quite significant, that how with event in the, so even in the patients who have trastuzumab only, there the event-free survival, patients with events are 30%, and this drops down to 18% in those who have pertuzumab and trastuzumab, both. And likewise in this study also, this events drop down significantly. So basically highlighting that more and more patients are surviving and doing better. And that is why this adoption in the trials and setting for pathological complete response is giving us good direction. So guidelines again for continuation of pertuzumab and trastuzumab in adjuvant setting is also something which is important. And we see that pathological CR rate guides us whether to use for TDM1 if there's no preoperative therapy or if pathological CR is achieved. Otherwise, in all other situations, we are giving, if pathological CR is complete, then HER2 target therapy is given by ESMO guidelines, trastuzumab and pertuzumab, in case initially node positive or hormone receptor positive, and those by St. Gallen, adjuvant trastuzumab and trastuzumab as originally offered in patients with initial adjuvant systemic treatment regimen. So the basic idea is that all these patients, except for those who have no preoperative therapy, or if TDM1 is discontinued in the event of toxicity, they have to complete HER2 target therapy in all these patients. So in nutshell, I would say that MDTs are directing us to achieve better and better planning for all T2 and node positive disease in terms of adoption of neoadjuvant therapy, and the risk of recurrence is reduced in this subset of patients. So this is the neoadjuvant therapy of HER2 positive patients, early breast cancer. Now, early breast cancer here, I don't know how we'll call it early, because once you're labeling it T2 and upwards and HER2, their adverse factors are coming into play. And therefore, gradually this group will shift towards the not so early group. And surgery is both de-escalated, both for the axilla and also for the primary side. So you know the breast conservation rates are down, the axillary dissection rates are down, and we have target therapy, sentinel node, all this will come into play. And adjuvant therapy subsequently will depend on the pathological response rates, where you have pathological complete response. There is with de-escalation, adjuvant treatment decisions should be based on neoadjuvant response, and patients with low risk and HER2 positive early breast cancer de-escalate adjuvant therapy depending on the pathological CR. So that is basically the crux, that these patients should continue either with pertuzumab and trastuzumab or TDM1 in those who are positive with residual disease. That is to improve the overall outcome. So thank you very much. I think most of the surgeons will be happy to know that most of the medical oncologists that is the main treatment now gradually. And from what we are seeing, even this surgery will be gradually de-escalated for the primary. Yeah.
So whether we'll be offering neoadjuvant therapy in these patients also, or we should go for surgery upfront, since the patient will not be changing to TDM1 later on, whatever the result be.
So I think I will still say that whenever in doubt, start with neoadjuvant therapy. And the reason is that micromets, see, we don't have data on survival. That part is agreed. But the moment you have an opportunity of getting systemic treatment started, it's better do that, because the failure is more in distal site than in primary site. So basic workup of T1, T2 and node positive negative, that is the key. So I will suggest whenever node positive, T2 and upwards, that is what we have adoption very freely adopted on our practice. Thank you. That is there. So in T2, early T2, you're not looking for that actually. You're not looking for that. So early T2, that is why for a significant time, we were all up to 3 centimeters doing upfront surgery. Now we have shifted to all T2, even 2.1, 2.3, whatever. Thank you, Ji. Thank you. as I said, no, escalate chemotherapy and systemic therapy, de-escalate surgery. So that is the motto. Yeah. So now we'll have a doctors. Yeah. So there's a.
Thank you very much for the invitation to
Okay, no, fine.
attend this meeting. It's a huge pleasure to be in India. I was actually in Kolkata just a few months before lockdown attending a consensus meeting, and it was a truly remarkable and enjoyable trip. So it's lovely to renew my acquaintance with Indian oncologists. As you've heard, I'm a medical oncologist specializing in breast cancer, and I work in the Northern Centre for Cancer Care, which is the regional cancer centre for the northeast of the of England, not the United Kingdom. So over the next half hour or so, what I want to share is really our perspective on Phesgo and the impact that it's already having with our patients with HER2-positive metastatic breast cancer. But I want to just cover my disclosures. These are my disclosures, which effectively cover the majority of companies that are involved in the development of drugs for breast cancer, and the disclaimer that this is a healthcare only presentation. Roche India does not support the use of any off-label indications, and there are warnings about pregnancy and pregnancy reporting. So I'd like to wind the clock back actually 35 years ago, to January 1987, when Dennis Lehman first published his classic paper in Science about the prognostic significance of HER2, what he called the alteration. He took a few hundred patients who came into his clinic in San Francisco with breast cancer and tested them for HER2. These were all comers, so not just early breast cancer, but a mixture of early and advanced breast cancer. And he showed that without the HER2 alteration, so HER2 normal, the median survival was 6 to 7 years. But with HER2 amplification, the median survival was only 3 years. And this, just to remind you, this was all comers. So it's a really quite devastating adverse prognostic factor. And the next 10 years were spent trying to elucidate the best way of targeting HER2. And of course, we've had, as we've already seen on the timeline slide, we've had Herceptin since 1998, a little bit later in Europe. Alongside the development of monoclonal antibodies, we've learned a lot more about HER2 signaling, and we know that HER2 dimerization is the key to signaling activity. And you can see here in this animation, ligand-activated HER3 heterodimers, which are the most potent signaling combination in the HER2, in the pathway of HER receptors. So trastuzumab binds HER2 down close to the cell membrane. And as we all know, this has been a very effective drug. It's revolutionized breast cancer with those millions of doses that you've seen given over the last more than 20 years. But pertuzumab acts in a slightly different position. So it binds HER2 in the receptor dimerization domain, and that could be predicted, and as was shown in preclinical models, to more than to increase the activity of trastuzumab. And the concept of dual antibody blockade with a combination of trastuzumab and pertuzumab has become established as the mainstay of treatment, certainly for higher risk patients with HER2 positive breast cancer. So we've seen in the different settings, different clinical studies. So starting with neoadjuvant, Luca Gianni's NeoSphere study looked at the combinations of docetaxel with pertuzumab plus trastuzumab versus docetaxel with trastuzumab alone. There were a couple of other stems in this window of opportunity study, but showed in NeoSphere that there was a very meaningful and statistically significant improvement in pathological complete response rates when pertuzumab was added into the docetaxel trastuzumab combination. There are supporting data from a number of other trials. Trifina looked at an anthracycline taxane with pertuzumab and trastuzumab given all the way through, given only with the taxane containing combination, and given with the Slayman docetaxel carboplatin and pertuzumab with trastuzumab, and showed again very high pathological complete response rates. Berenice was a cardiac safety study using either doxorubicin or epirubicin combined with either paclitaxel or docetaxel, and again confirmed that by the addition of pertuzumab into the mix, we were seeing greater than 60% complete pathological response rates. And I have a fondness for Berenice because I was one of the investigators and authors. In the adjuvant setting, the work has been also carried out with the Affinity study. Affinity again looked at either an anthracycline and taxane or the carboplatin with taxane stem, and compared pertuzumab plus trastuzumab with trastuzumab alone, showing advantages across the board, but the advantages were greatest in the node positive and the hormone receptor negative patients. There was an adjuvant part of the Berenice study. And then in metastatic disease, the Cleopatra study, first presented by Jose Baselga, looked at the combination of docetaxel and trastuzumab, compared it with docetaxel, trastuzumab, and pertuzumab, and showed an extraordinary response rate of around 80% and a 6-month improvement in progression-free survival and a nearly 16-month improvement in overall survival. So this concept of combining pertuzumab and trastuzumab to get the best for our patients has really underpinned the treatment for the majority of women and men presenting with HER2-positive breast cancer. This is the algorithm that we use. So we look at newly diagnosed HER2-positive early breast cancer. And if the tumor is greater than 2 centimeters or node positive, we tend to use neoadjuvant chemotherapy with a combination of pertuzumab and trastuzumab. At the point of surgery, if there's a pathological complete response, we continue with pertuzumab and trastuzumab-based treatment if the patient was node positive. In the UK, there's no funding for pertuzumab in node negative patients. And if there's residual invasive disease, we switch to TDM1, so Kadcyla, based on the Catherine study that showed an advantage in those patients with residual invasive disease if the antibody, either trastuzumab or trastuzumab and pertuzumab, was switched to the antibody drug conjugate, trastuzumab and emtansine, if there was residual invasive disease after neoadjuvant chemotherapy. As a diversion for small tumors, so T1 tumors, T1 node negative tumors, particularly those that are estrogen receptor positive, we know from the APT data and Sarah Talani's data that if we go for surgery first and the patient's node negative, they're likely to do very well with this APT regimen, which is 12 weeks of weekly paclitaxel with trastuzumab. And although we would only contemplate upfront surgery in patients who we feel are node negative, if you get a nasty surprise and they're node positive, then we would use standard pertuzumab and trastuzumab-based regimens. This clearly requires the interaction between pathologists, radiologists, surgeons, and oncologists. And these people can go through our multidisciplinary team meeting multiple times along their journey towards what we hope will be cure in early breast cancer. So I've talked about the MDT resource, but there is also a huge resource consumed in delivery of treatment. So there are long infusion and observation times with intravenous infusion. Initially, we often have to split treatment actually over 2 days. So we give pertuzumab with observation period, trastuzumab with observation period, and the patient comes back the next day for docetaxel. And there are long infusion times varying between 30 and 60 minutes for pertuzumab, 30 and 90 minutes for trastuzumab to get the drug in without producing infusion-related reactions. So it's a very resource-hungry operation giving these treatments. We also have, in the typical adjuvant setting, a 6-month lead-in, so 8 cycles of treatment in the neoadjuvant setting, another 14 intravenous infusions in the adjuvant setting. And there are challenges with intravenous catheters or the complications of central venous catheters. And we can run into problems, and patients get more and more frustrated with the time and the discomfort of establishing intravenous access. Our day units have also got busier and busier and busier. This is a picture from 1954 of the cattle market in Newcastle, and our chemotherapy day unit has often been described as being like a cattle market where patients are herded in, herded out. And with all of the different drugs that are coming through, there's more and more pressure with an exponential rise in the number of treatments that we can offer, but no more than a linear rise in the resource that we are able to use to deliver. And for interest, this is the part of the Royal Victoria Infirmary where breast surgery takes place in the background. So we need to clear out the day unit, and the cattle market has actually been cleared out and is what's now known as Times Square. And this is the head of the cattle market's house. And the key thing here is the time, and patients don't want to spend time in hospital. They want to spend time living their lives, getting away from it, and having a quicker, neater experience. So we've heard a little about the clinical development of subcutaneous trastuzumab. Again, we were an investigator site for SAFEHER, which was the largest 2,500 patient study of subcutaneous trastuzumab. And immediately we could see the advantage of subcutaneous administration, a 5-minute injection rather than long infusions. And there are options, I think, that without treading too much on the label, but there are clearly options to streamline the service, move drug delivery out into the community, shorten the post-treatment observation time, and it's a win all round. So I think we are familiar that IV trastuzumab has transformed the treatment landscape initially, and then dual blockade coming along effectively 10 years later has improved survival outcomes in all of those patients. And we had a great duality in the region where all of our patients receiving trastuzumab monotherapy were receiving a subcutaneous formulation, whereas the patients receiving pertuzumab and trastuzumab were receiving 2 intravenous infusions. So NHS England rules told us we had to use the intravenous infusions. And we felt, and Roche were clearly developing a subcutaneous formulation to give our patients receiving dual antibody therapy the advantages of subcutaneous administration that we saw in those receiving subcutaneous trastuzumab monotherapy. So as we've heard, Phesgo is the first formulation to combine 2 monoclonal antibodies, in this case pertuzumab and trastuzumab. It's a single vial for subcutaneous injection. It has this recombinant human hyaluronidase that allows the drug, I talk about it ghosting into the circulation, and it's interesting talking to the nurses who give it. We may hear a little bit more about that later, that to start with, it goes in quite slowly, but as the hyaluronidase kicks in, it's very easy to give the treatment, and it's given by subcutaneous injection over 5 to 8 minutes. So moving on to the Federica study, which was the registration study for Phesgo, it was a comparison of intravenous versus subcutaneous, pertuzumab and trastuzumab, and the primary endpoint was the pre-cycle 8 pertuzumab serum C trough level, and it was geometric mean C trough level with a non-inferiority design. Secondary endpoints were pre-cycle 8 trastuzumab serum trough level and total pathological complete response rate, which was eradication of disease in breast and axilla, which we know is the best surrogate for the longer term outcome measures, and then longer term distant recurrence, invasive disease-free recurrence, event-free, and overall survival. And clearly we had a look at safety, particularly including cardiac toxicity, and also differences that might occur as a result of presenting the drug via a subcutaneous compared to an intravenous route. Just a reminder that if you give an intravenous infusion, you see this very high Cmax corresponding with the end of the infusion, and then a rapid decline in serum concentration as the drug is distributed and then dropping over time. With a subcutaneous treatment, the Cmax is rather lower and occurs at a later time point as the drug moves from the subcutaneous space into the circulation. And you then see a similar decline. And in this model, the subcutaneous C trough is slightly higher, reflecting that there's a slightly higher dose of, this was actually a slightly higher dose of pertuzumab in the vial. So this C trough is the trough plasma serum drug concentration, and this dotted line here is the minimum effective level. And the idea was to make sure that by administering the drug subcutaneously, we maintained a pertuzumab and trastuzumab concentration in the effective range. So this is the Federica clinical trial design, and it was a trial that was carried out in patients with operable or locally advanced and inflammatory HER2-positive breast cancer with a primary tumor of at least 2 centimeters or node positive. It randomized patients in a one-to-one fashion between either dose-dense AC, so doxorubicin and cyclophosphamide, or conventional 3-weekly, followed by weekly paclitaxel or docetaxel, and they received either pertuzumab and trastuzumab intravenously, in the top here in red, or with the same chemotherapies, they received the fixed dose combination, Phesgo, in their 8-cycle treatment prior to surgery. And then in the adjuvant phase of treatment, they received 14 cycles of either intravenous or subcutaneous treatment as per their original randomization. And we've already seen the endpoints. These are the demographics. So the median age was around 50. There were 20% Asian patients. The majority of patients were Caucasian, either in North America or Europe. There was a preponderance of premenopausal women. There were around 40% of patients were ER and PR negative, the remainder ER positive. And most of the patients had early stage, so stage 2 to 3A disease. And there was a roughly even split between dose-dense AC followed by paclitaxel, or AC conventionally scheduled followed by docetaxel. So moving now to the primary endpoint, it was a non-inferiority study, as we've heard, and this was pertuzumab serum C trough level, which was 72% with the intravenous formulation, 88.7 micrograms per mil in the subcutaneously treated population, and that met the non-inferiority threshold of 0.8. In fact, the ratio was 1.2, and to meet the non-inferiority criteria, the lower limit of the confidence interval of the C trough level for pertuzumab, the ratio of that to the IV level had to be above 0.8, and it was. This is the trastuzumab Herceptin serum trough levels, and you can see the same pattern. The subcutaneously administered level was higher than the intravenously administered level, and again, the lower limit of the confidence interval for the trastuzumab C trough level exceeded the 0.8 non-inferiority boundary. So now moving on to efficacy, this is the total pathological complete response rate, so in breast and axilla. And you can see here in both arms, the PCR rate was 59%, 59.5 with IV, 59.7 with subcutaneous. So basically an identical PCR rate. And again, the PCR rate with subcutaneous administration met the non-inferiority boundary. We touched a little on the relationship between weight and TPCR, and these are patients who were described as underweight, normal weight, overweight, and obese. And there are no statistically significant differences between the PCR rate in underweight or across these strata. And interestingly, in fact, in the underweight people, we saw these 3 patients with IV who had PCRs. You would expect with a fixed dose, the dose to be greater, but there were actually fewer PCRs. But look at the numbers here. So while striking, these differences are non-significant. And as I say, there's no trend going forward. And in fact, if you look at the PK data for subcutaneous trastuzumab by weight, and Bert Lum from Genentech did this, and I had the pleasure of working with him when we were working on the subcutaneous trastuzumab launch. There is actually an inverse relationship between body weight and trastuzumab metabolism. And it turns out that the lower body weight patients metabolize the drug faster than the higher body weight patients, which evens out a lot of the variation in dosing for based on the patients. So if they're bigger, they metabolize the drug slower, and therefore the differences in drug levels are minimized by that. What about safety? Well, any AEs, as you would expect in studies, high levels of any AE, but the grade 3 AEs were very evenly matched. Serious AEs, again, very evenly matched. There was 1 death in each arm of the study. One was from urosepsis with the intravenous combination, and in the Phesgo, 1 patient suffered an acute myocardial infarction. And there were similar numbers of adverse events leading to withdrawal of HER2-targeted therapies. Going into the AEs in a little bit more detail, we saw no meaningful differences in AEs with the intravenous versus the subcutaneous formulation. And going again into a graphical formulation, you can see diarrhea likely to be related to taxanes and pertuzumab. Neutropenia and febrile neutropenia rates were similar. No difference in cardiac dysfunction. A very slight excess of infusion-related or injection-related effects within 24 hours. And the excess of the subcut is related to very minor skin reactions. This is anaphylaxis and hypersensitivity, significant mucositis, interstitial lung disease, which we seem to get very interested in these days, but those rates were low and no different between the treatment arms. And then looking at secondary endpoints, there were a couple of episodes of heart failure. This was the cardiac death from myocardial infarction, but no overall difference in other cardiac events, probably a little bit less in the subcut, and LVEF declines, again, no difference. And that data, I think, is very reassuring. We wouldn't expect here, this is intravenous to subcutaneous, and in that switch over, 88% of patients, 150 minutes infusion time and 420 minutes observation time. And even when you move to maintenance, you've got this excess of time for the delivery. These are slightly different scales, which is a little bit confusing, but you've got 150 minutes or up to 150 minutes infusion, and then the observation time for subsequent doses. So there is a massive time saving with the use of subcutaneous treatment. There are also indirect savings, so there are savings on chair time costs, but I think chair time is not so much the cost of the chair, it's the opportunity cost of having patients sitting in chairs for long periods of time. There are big savings on patients' productivity, there are savings on healthcare professional time, and there are savings on the non-drug consumables. And of course, we heard in the introduction a little bit about the effect of the pandemic. We were desperately trying to get people off our chemotherapy day unit during the pandemic, or if we were bringing them to the day unit, bring them for longer. And we've moved to a model now where patients having Phesgo aren't coming to the hospital at all. They're receiving their drugs from suitably trained nurses with the right equipment in community pharmacies, saving them on visiting the hospital at all. And that's been a massive bonus during COVID. So in conclusion, Phesgo offers a faster administration, patients prefer it, and I think it does allow us the opportunity to optimize treatment of this group of patients. And I'd like to end with this picture that we took in the Cancer Centre on the 24th of November 2020, and this was the first vial of Phesgo that went into a patient in Europe outside of a clinical trial, and that was in Newcastle towards the end of November 2020 when we managed to obtain supply. And since March 2021, all of my patients receiving.
I don't know how many people saw this coming 5 years back or even 2 years back, but I must say that such a thing will take the whole practice by storm. The whole medical oncology shifted from indoor to daycare, and now from daycare to OP chairs, OPD clinics. This is what is going to happen. And that's so in a fixed dose subcutaneous format. I'm sure the adoption must be very fast. And this is something which helps everybody in the game accelerate the whole treatment of breast cancer. So I'll request Nitesh for the panel discussion to make sense of all these things, what we are doing, and also request the panelists, Dr. Piyush, Dr. Bhuvan, Dr. Chandragowda, and Dr. Pankaj Goyal to please come on the stage. Nitesh, come. I'm there for the surgical.
Thank you, sir. Sir, you are there for the oncology part, sir. You are not there for surgical part, but thank you. And really, it's always an honor to come to any of Dr. Shyam Agarwal's meeting from Gangaram. But it's very onerous to be with a very esteemed panel. Piyush is there. Bhuvan is almost there. Last to come in, Chandragowda is certainly there. And of course, Pankaj is there. So thank you very much. Bhuvan very nicely sat next to Dr. Harit to be on the oncology side. Okay, so I think we'll go straight to a case. We've had some very good lectures about both the de-escalation of surgery and escalation of medical oncology. But basically what I heard was that actually it's now time where the amalgamation of care is really helping for better outcomes. So this is a 58-year-old, and I do think, and these are disclaimers, these sites are actually not made by us, but I do think that Roche should be more particular about this. The definition of early breast cancer is actually different than what we call non-metastatic breast cancer. So maybe that's a better word to use. So 54-year-old lady presents without any significant medical history, and there's no family history either, and there are no known genetic mutations, which obviously was tested later. This was her initial mammogram, which obviously shows a lesion, a very obvious circle there. And this was on ultrasound, where if you notice on the right side, there actually is a axillary lymph node, which is quite large and inflammatory with loss of hilum. This was an MRI diagnosis. And this is the characteristic. Can I start with you, Dr. Harit? What would you typically want to know more or do in this patient like this? Okay. Bhuvan, PET CT, something else?
I'm okay with the PET scan also.
Huh?
I'm okay with the PET scan also.
No, you're okay with the PET scan? And I think most of us would end up doing a PET scan.
So patient is also happier. Patient is also happier with PET scans.
So we all, I think, become happy, and I think it's a matter of a good discussion whether we should or we shouldn't. But it's a lesser of the evil of discussion that we have. So we've done a PET scan, and this patient basically didn't have anything else. And now the question is, there is no distant mesh. This is clinically a T2, clinically a CN1, but this is a big lymph node. Do remember that. And the patient wants breast conservation. Piyush, can I start with you? At what stage in breast cancer patient do you approach? Because we don't end up seeing the patients together. So how do you approach this? The patient does come first to you. Dr. Mehdi made a very good comment earlier in the day that it depends on who the patient sees first. But really, I think that era is changing. So what stage do you pick up the breast cancer patient and say, you know what, I really must have you seen by the surgeon first? Or do you start the chemotherapy?
No, so as has been discussed previously, that multidisciplinary way is the way to go for every patient, irrespective of.
So I agree. I think we're going to discuss this patient at TMB in the group. I'm fine. But I'm saying seeing the surgeon, even if you were going to take it to the tumor board, but seeing the surgeon, would you see the surgeon always? Would you say only if the patient is going to be operated, or are you going to say that because I'm going to start you on chemo, but do see the surgeon. I think that's what I'm really.
No, always, because it's going to be a part of the treatment trajectory at some point of time, or earlier or later. It's always that.
Okay. Pankaj.
So I think patient has got a lot of anxiety. What type of surgery will be done later? And since we know that surgery is the main thing when we are talking about a local CA breast, so the surgeon should be there in the loop to start with. Because if some clipping has to be done and some planning has to be done, ultimately if that comes out from the surgeon's mouth, then it makes much more sense and confidence in the patient. So I think when we are dealing with local disease, surgeon should come first, and then accordingly we have to tell the patient what type of surgery, what type of clipping, what are the outcomes, and all the cost issues also to be discussed, how much stay and everything. So when patient comes first, it's better that patient has clarity and all these things are discussed.
Yeah, very good point. Dr. Chandragadu.
I think I agree with what Pankaj said. So we do the same.
And I think I'll add to that yesterday we were in a palliative care group discussion. Dr. Harith was also there. And one point which came again and again was, are we hearing the patients enough? Actually, rather than are we saying enough? And when you do hear the patient, you realize that there are more questions than what you're going to try and tell them. Something you want to say something?
No, I'm just discussing the same thing. Even this practice has from the surgeon's perspective also. Like now they have started even referring patients of 1.5 centimeter tumor in which they know that there will be no chemotherapy. Still they send the patient so that patient has a second independent opinion, and patient has that confidence patient should go for surgery. Because patient will be having second, third opinion, he'll be confused. So we all should be on the same page when we discuss any case.
In fact, there was a point where we were wondering about we should post, we were discuss with the patients together, and these are exactly the situation where that would help. Can I ask you again and then back to Ruben, which are the indications for full mastectomy in a HER2 positive group, or are that definition now gone? It's somebody who
I would say it's almost gone in terms of primary size, but if you have multicentric disease, if you have only two foci, still today there is a consultation regarding conservation. But in some subset of patients, still mastectomy is the difference.
the node and the skin involvement.
Two different things. Node has no play on conservation versus mastectomy. Skin involvement, as I was mentioning, that T3 has no play on conservation. T3 responding very well, you can easily offer conservation. Inflammatory breast cancer, a big no to conservation. However, T4B is an area where gradually we are increasingly doing more and more conservation. But yes, that is a slow take up there. I also want to make one point that whenever regarding the T status, when you were talking about the medical oncologist seeing the patient first and everything. So the clinical findings and the T status is something which is today I depend more on ultrasound reporting of the T status than on clinical findings, because you tend to over or underestimate. So that is one area which is gradually picking up.
I often get confused when there's a video. See the note say video. I don't know if it's infiltrated or not. And then comes in a PET which shows there's a sliver of PET activity. What do you think we should do with that? Because, I mean, is this a case for PCS and there's a good response? And with these drugs, we see a phenomenal response. You know, we see the old people disappearing. So you will certainly see the skin normalizing. And are we doing an age-appropriate surgery but not offering a
So eventually, PDO, so what we do generally is, if there is a PDO, obviously the BCS is not ruled out. Obviously, the response takes a lot. And I think the biggest problem, as Dr. Harith also mentioned, I think it's the multifocality of the tumor. Rather, we had a case today only in which there was a large lump, but then when it starts to melt away, it kind of leaves 2-3 foci, and then you do not know whether they were 1 or they were 2-3 to begin with. So I think that's the bigger
But
problem.
Dr. Harith, I'm asking more about that sliver of PET activity. Because that makes me nervous sometimes that we are missing out.
So, yeah, I can
do biopsy.
Yeah. So frankly, T4B is QD orange. Okay, and that also not just about the tumor. If it's just about the tumor small area, then it is a case you can say to conservation. So it is a larger area. What we are seeing on MRIs and on PET CTs is over imaging. Imaging has gone too intense actually. So that should not direct you to. That is why it is said that all MRIs and all these are directed towards more and more mastectomies, because they instill that fear in the surgeon's mind in relation to a lot of these smaller foci. So that should not direct.
I think that's exactly what I was trying to say, that we shouldn't overcall a breast conservation surgery just because because of the pandemic. Can I have my slides on the screen, please? Because I think, yeah, I can start making sense. So coming back, how often do you use clipping in your practice? What are the challenges of clipping? How does it impact breast conservation patient? And really, what is the definition of an inoperable conservation? So if you could just give me 2 minutes on that, difficulties in clipping and who is never going to be inoperable other than TOV.
So all patients today will be clipped. There was a time, maybe 5 years back, when we were clipping only after talking to the patient, whether you want conservation or mastectomy. Only those who said conservation will say go for clipping. Today we say all, because the surprise is that most of these patients, they come back, they want to have conservation, and then you are in a soup that you have not planned it properly. And now I have a patient just 3 weeks back who we had conservation after NSCT 20 years back. Okay, at that time there were no clips available, so we used to tattoo the breast. So that mark is still there, and for several, almost a decade, I was practicing tattooing and all that. Today it's all gone. That mark, when I see, I say it's not today's practice. So to answer one question, which patients to clip, every patient will be clipped. That is number one. You had one more question.
So I said which patient you would not go for breast conservation other than T4.
Today all patients will be considered for conservation.
So I'm going to give you a typical confusion. Here's a patient for you who has got advanced disease. So who has got disease and can't afford anthracycline, can't take anthracycline because of, let's say, allergic reaction or some level of cardiotoxicity. Would you consider this patient for neuroadjuvant surgery or neuroadjuvant therapy, or would you go with this patient for surgery first? N1, large D, MRM acceptable. N1, large disease, MRM acceptable. Breast conservation not needed. Patient has some cardiac risk, let's say EF is 45% borderline. Would you consider this patient for surgery first?
No, still, I mean, the EF you quoted, we can still go ahead with a neoadjuvant strategy. Of course, the lower you go with the EF, of course, that becomes a bit dicey, because there, of course, we see that because above 40% with a very close monitoring, we have gone ahead with delivering HER2 new blockade. So yes, trastuzumab can be given over there.
The question is not can we, I think the question is should we, that somebody who is
We should, because of
operable, one node, and I'll just come to how many nodes you have to consider, but one node, would you consider, would we have the same parameter, or would you change practice because the EF is like? I think
you operate, I'll just give a trusty question. If you operate this patient and this turned out to be node positive, what do you do next?
Dr. Pankaj?
What do you do next?
I think he's made a point that anyway you have to give systemic therapy. So, but then when you know that you cannot give.
It's not the same though. It's not the same. Adjuvant and neoadjuvant is not the same.
The outcome can be changed. If a patient you give,
Dealing with a complication before you've operated on the patient becomes more difficult in more than one way, including the psychological aspect.
I think if you know that you are not going to achieve PCR because you will not be giving an adequate neoadjuvant therapy, and you are having hiccups whether the patient will continue trastuzumab beyond 2 cycles, some cardiac dysfunction and legal issues also. I think it's worthwhile in that particular patients, you may frankly go for surgery and then go for systemic therapy.
Look, I just escalated surgery again.
Yeah, that's what I was saying. So I think that's a valid point, that whenever in such kind of a situation that you may not be able to give your chemo, better to go for surgery.
But rather, we have been doing that. Eventually, if the patient is unfit to receive, and we're not able to achieve a PCR, we might as well operate and then do it.
I think we can't say we can't do it, but it just becomes very confusing because we have become used to a certain standard practice, and that's because we're seeing phenomenal responses with combination. And then comes across the patient and you don't know which one to challenge first.
And just to add another thing, that who are the patients will not offer BCS. If the patient is not, let's say, affording coming from a distant place, and if the lesion is say 3 centimeter, where I know if MRM is done, patient will not need radiation. So in those particular patients, because so many patients are not that affording. So in those particular patients, we tell them if you go ahead with MRM, you will not need radiation. So that's another thing to be added.
Right.
just a modification, Dr. Dinesh, I think in this situation, sometimes if it is decided that yes, we'd like to take a neoadjuvant, modifying a TCHP to a NAP paclitaxel carboplatin and subcutaneous, let's go.
I'm going to challenge a little bit there in a minute, once we come to that, because we're going to talk about anthracyclines and vaccines and everything. But so you hold your mic, I'm coming to that in a second.
Okay.
So in this patient, the question was what to do. We started, and obviously these are the things we've already discussed, so I won't delve too much into this. And which treatment. So now this is the question, and I'm going to paint these situations. Patient can't afford, and patient has that ejection fraction of 45. What are you going to take your risk with your HER2 for a year or with your anthracycline? So keeping that in mind, what therapy would you choose? So I'm first saying this patient is absolutely fine. Cost is not a concern. I think we are going to use TCHP. So let's close that chapter.
Right.
I'm not even asking you that. I'm saying now let's think of a clinical situation where first patient cost is a concern. Say T2N1 cost is a concern. And then maybe Pankaj can take the cost is not a concern, heart is a concern.
If cost is a concern, I would take.
Your cost is a concern.
So the cost is a concern, then I think TCH is what we do. So TCH and then followed by
Not
maintenance.
ACTH, not AC and then
Anthracycline with the ACTH, I think we know that TCH in HER2 positive patients, so TCH has an edge over the ACT. So ACTH, we know that we have a trial of whether the anthracycline versus carbo TCHP. So that's not going to be equivalent.
So we unfortunately don't have Mark on this, but we asked this question to him last time. He said we give anthracycline to everybody first in Newcastle. Everybody, they don't do TCH.
So earlier used to do it in a ERPR positive HER2 positive setting where we probably used to give maximum benefit there. We would not see the much path CR rate. So we used to give benefit of both anthracycline and anti-HER2. So, but we have a data now that getting away with the anthracycline is good enough back if they're equivalent.
Pankaj, I'm tempted to ask you cost question again. Actually. Then I'll ask that question to Piyush and Bhuvan. If cost is a concern, everything else is fine.
With the ejection fraction of 45%.
No, ejection fraction is fine for now. So
see, for me, whether cost is constrained or not, I'll be sticking TCH. Okay. I'll not be offering per data to this patient.
Okay. Piyush, now heart is a problem, cost is not a problem.
No, anthracycline is a big no. If heart is a concern, yes, as I said that we are giving with the close monitoring with the ejection fraction beyond 40%, we have been following that. So yes.
You've done weekly as well, the 52-week scheduling and all of that.
With the paclitaxel, yes, not necessarily the docetaxel schedule, yes, but with paclitaxel it goes.
Bhuvan, anthracycline is a big no here, or actually 1 year of
finance is a concern, then ACTH, if the heart is also a concern, weekly pacli with, but adjuvant setting, not in an intervention setting. Adjuvant setting, weekly pacli with transfusion.
So if cost is not a concern, heart is a concern, you will not start neoadjuvant, you will go to adjuvant.
If cost is not a concern, but heart is a concern. We already discussed that. Probably depend upon the other factors in the performance status of it.
So what I'm hearing is that for most of us, heart, even if heart is a slight concern, we are actually accepting Herceptin, pertuzumab, provided you obviously operated on this patient and in the adjuvant setting. So that is nice to use. And other than cost, we would not consider anthracycline at all. And actually, half of us would, 3/4 would not even consider anthracycline if cost is a concern. And if the node goes up, maybe Chandrabhadan, you can take that. If node goes up, N2 and N3.
I think then personally I can consider, but we have a data. That's what I want to say. So we can get away with the anthracycline nowadays. So in that context, I'm going to use a TCHP.
Pankaj, how many nodes do you FNAC to know whether this is N1 or N3 in a clinical setting? So we talk about increasing nodes. Sometimes the question of anthracycline comes in for some of us, but we only FNAC one node.
Yeah.
So we don't really know this is N1, N2 or N3 based on PET, and we're already saying that PET is not reliable.
If it is,
I was going to say that.
Supraclavian involvement, then that's a different thing. But just in axilla, I don't think there's any method to tell that how many number of nodes are there.
Yeah, actually it's the other way around also, that at times they say that the node is there on PET and MR unless you do any sampling.
You need to have a microscopic vision for that.
Recently we had quite a few patients where the FNAC was negative, imaging was suggesting disease.
Yeah.
And negative, they did the upfront surgery, sentinel node negative.
and
So
I
don't
think
rely only on the.
me and you had this discussion, and I think the end result of this was you would prefer Enthra, and I would say that there is no data. And eventually, we both agreed that we will reverse sequence it. We'll do TCHP, and then if the patient doesn't have a response, we might add Enthra in the latter half of the.
I think I'll go to the next point very quickly. This will get very confusing, but yes, I still somehow I'm very.
Someone is not responding to TCHP, I'll review the HER2 positivity. If something is not responding to TCHP, maybe the HER2 positivity is wrong.
But to be fair, Pankaj, there is that group of 10-15%. It's not 100%. There's a group of that 10% don't respond to HER2 positive, and in fact, they're still HER2 positive. You get HER2 fish. In fact, this patient had HER2. I'm just saying that there's no clear answer. I somehow am very anthracycline pro when I can't use pertuzumab, but I would not hold anybody against this. We all know that there was phenomenal response to HNP even over the chemotherapy. And Dr. Harith showed these guidelines where the combination is clearly the better thing to do. The question then becomes is, would you consider Herceptin and pertuzumab? And I think the consensus seems to be maybe a quick word coming from you and alternatives on the board. Would you consider residual disease, PDM1, agreed. Not pathological CR, HNP versus H, cost not a concern.
HNP.
So, of course, cost not a concern with various guidelines saying HNP is a discussion, but if cost is always a concern, and that's what it is. Then if you look at the affinity data, the major delta upshift is actually at N2, what I feel. So if I take from there. Sorry.
So you're not taking an FNC, never knew
From the affinity data, I'm saying the N2.
I'm not doing a. You're not doing.
CR. We don't know whether it was N2 or N1.
So cost is not a constraint, give both.
Okay. Cost is a concern. H.
Only H, enough.
H for 6 months or H for
1 year, complete 1 year.
H for 1 year because nobody used anthracycline.
No.
Yeah. Cost was a concern. We didn't use anthracycline. Now we're using H for a year. Anyway, we'll keep that later. Okay, these are the guidelines. We've, I think, all seen that. Now let's talk about FESO. That's we have 4 minutes left. Experience. They all experience FESO now.
Yeah.
You all experience FESO. What's your take on it? Maybe you can start.
So I think with the patients that I've used, they feel comfortable compared to IV. So I think it's less time consuming compared to IV, and easily taken. So that's what it's too early to say. It's just
I just get excited.
Absolutely.
I found my patient who actually switched over was so excited that she was going home.
true. I think yeah.
And I said, but you still have to be observed. She said, that's okay. You can send me coffee, but I'm disconnected.
Agree, completely agree.
Dr. Patrick,
We have just given it to one patient, and I think we are comfortable and happy.
okay, Piyush.
Yeah, I think so. It's a big experience changer. I mean, of course, the patient would feel comfortable about it. And what Dr. Harith sir said, that it is going to change the practice towards probably a daycare, home care, OPD. Don't know.
Yeah.
So both me and my patients are both apprehensive because they come and ask me, किसी और को मिलना शुरू हुआ कि मुझे ही मिल रहा है?
And more consultants apart from medical onc will be using this.
There were 3 patients.
And they're still apprehensive.
No, so I rather did the first. We do a reassessment at the 3rd cycle. I did a first reassessment at the 3rd cycle and did show a response. So I was like, "अच्छा काम कर रहा है."
So then more specialties apart from medical onc will be using it.
So now let me throw 2 questions here. Okay, I don't know if I'm allowed to do this or not, but I'll still do it. So we know the cost is cheaper because the cost of Herceptin is not there. Thank you, Josh, for that. I don't know if I'm flouting any regulations here or not, but cost is cheaper. So there is an advantage, and maybe proven towards Chandragata this time. Second, what are the difficulties you're going to face with FESO? And be very open about it. So what are the advantages considering cost is an advantage? Would you therefore advise to everybody because cost is a slight advantage? It's slightly cheaper if you have to use HMP than use IV formulation. And what are the big roadblocks that you see?
So I think once I develop a confidence in this drug, there is no reason not to advise it.
no roadblocks.
It's a no roadblock. It's eventually, there's a huge cost difference. There is almost if you look at the long run HNP, there's almost a 10 lakh rupee difference in the entire thing, which is a
Will
huge.
that roadblock not exist when it goes home?
When it goes, acha. So, but then, and I don't get offended, but then that's what they're trying to change. They're trying to change the physician's behavior because they want to drive across the points.
I think I'm just feeling a bit naughty today. I don't think it will be a roadblock.
So, a good drug overall looks like to be, and only thing is that the data on low BMI, I would want to see that more.
I think it's both the end of spectrums, the low BMI and the overweight.
That we need to see,
That's a very
and skin
Always
reactions.
slightly over treatment on most accounts. So it's
Yeah,
not
so-
under treatment, it's over treatment on most.
And somebody having skin disease patterns or atopy or allergies, so we need to see.
Okay, and I think I'm slightly worried about diabetics also because of intramuscular.
Yeah, I think there's nothing to add. Sir has already limited.
I think no points to add. It's a comfortable.
So Dr. Harith, back to you. I think you were saying this is more about patients and you caught me time. But that does mean, and I do feel that we do need to re-innovate also in how we practice, because patients are not really trying to cut corners. As long as we can develop a system where we can deliver this at home, and then I think it can be done.
Absolutely. The center of all this is the patient and nothing else. And all of us will grow only as the patient gets served. So I think all these roadblocks will not be there. Even if it moves to the home, something else will happen.
So I think this was actually
Sir, just to ask, we are having so much of emphasis on this subcutaneous pertuzumab, all this thing. How come this trastuzumab didn't kick up? Subcutaneous trastuzumab.
I mean, the simple answer is Roche was not interested because that time it was still in patent. Now it is not. But the real answer is, if you see both of them, there is an add-on treatment time which is getting longer and longer. I do remember this is not developed for our country. It was developed for a country where chair time is extremely important. You do have to serve the X amount of patients no matter what. And the minute you can't serve because your treatment times are getting longer, you have to make expansions. You have to create chairs. So the chair time is extremely important. And this 1/3 patients, this is going to be all comers in US. So 1/3 patient saving chair time actually means that most of the users don't have to cause expansion in the US.
So, but then why not trastuzumab?
Because you're adding 2 drugs. Suddenly your calculation is getting lopsided. That's my take, but so this is
Something more to it. We don't know.
We just discussed this. I think my time is over. I will try to end with a quick summary to say it is in the guideline. My initial experience has been exquisitely good. I'm wary of the diabetics, so we are using a little bit more methods to make the area clean, and I think that should be a concern. But there's no real concern in my mind. I do buy the point about the weight. I think overweight and underweight is an area we have to be careful about. So if I really get that 95-100 kilo patient or the 40, I think I'll be a bit wary. I'll still go back to my previous dosage because that's easy to do. Other than that, thank you very much, and thank you for the panelists. Thank you. Thank you.
So I would request all the doctors to have 2 more minutes. We have a laser show here in the house, so we can spend 2 more minutes.